Good morning, everyone. Now we are all set to start the first session of the last day of this conference, that is innovations. And the judges are Dr. Sandeep Saxena, sir. Please. Now I invite Dr. Rohit Sethi, sir, to the dais as a chairperson, and Dr. Sanjeev Mittal, sir. And now I invite the judges, Dr. Geeta Iyer, madam, Dr. Sandeep Saxena, sir, and Dr. Bhupesh. I'll take permission to start the session. Our first presenter is Dr. Niti Gupta. The total time of the presentation is 3 minutes. You will get a buzzer at 2, and you should finish by 3 minutes. And we have kept 1 minute for discussion. I request everyone to stick the timings.
I'm audible? Yeah. So I would be presenting the use of plus 90D lens and a direct ophthalmoscope for the anterior segment examination and documentation of cases. Move नहीं कर रहा. हाँ कर रही हूँ हाँ. So all those who are in the medical colleges, they know that we get a lot of calls from the ICU as well as from the neonatal ICU, and like there it is a challenge to examine these patients because like we get a lot of calls for corneal ulcers for these patients in the ICU because of exposure keratitis, and it is difficult to examine because we just have a torchlight. We don't have a portable slit lamp there. So this is a challenge in this situation. Also, when you have a patient with a kyphosis, he cannot sit on a slit lamp properly. So how to examine these cases, also then how to document when you are there in the ICU and in these cases. So we all in this hall have used these two instruments, direct ophthalmoscope as well as an 20 diopter lens for posterior segment examination. So I would show this case. Like this was a patient in the ICU. She had sepsis also. So like this case was, it was difficult to examine by a torch light, and then my resident had to like during the night time he had to show this photograph to me. So I had asked her to use a 90D lens and take a picture, and you can see, if you magnify this image, you can see a very beautiful epithelial defect and infiltrates, and like we can document this with the help of a 90D lens. This is another case. This patient again had septicemia with diabetes, and you can see a geographic ulcer in this eye after a fluorescent stain, which is photographed and documented by a 90D lens. These are patients of Stevens-Johnson syndrome, which those who are in the ICU, and you can see that we can stain the eye, and we can take beautiful pictures with the help of a 90D lens. This is a small child, a 3 months old child, and he came with a corneal ulcer in the OPD, and we couldn't examine this patient like or document this case. So we had taken a picture with the help of a 90D lens. Another case of Stevens-Johnson syndrome, you can see.
I think you have finished your time. It's 3 minutes, right?
Okay.
So if you can sum up.
Yeah. So another ulcer, and this is this case I wanted to show you that if you project a direct ophthalmoscope light, you can make it a slit, like you can image as if in a slit lamp. So you can see a shallow AC, and this is the grading of the lens. So to sum up, like we can use the 90D lens as well as a direct ophthalmoscope as an alternative to a slit lamp and to document in ICU settings. Thank you.
Any questions from the judges? We have a minute.
How do you feel that a 20D lens will fare on a
Sir, I think it is just for examination of these cases. Actually, I had to document to show pictures here, but this is for examination of cases in the ICU, especially for the residents. Because actually this idea came to me when I was called for like to see a case of corneal ulcer in the ICU, and there was a desmetocele actually. But since there was a clearing, I couldn't know whether this is a perforated ulcer or it is a desmetocele. So this technique helped a lot. And we applied a glue BCL in that case.
What I meant was whether the view through on a similar setting, a view with a 20D would be better than a 90D lens.
Sorry, I'm very sorry. This was a 20D. I actually made this presentation in the morning only. This is plus 20D. Actually, the image was a plus 20D. I just labeled it wrong.
The image is okay. It's
I'm very sorry.
Okay, thank you. We have the which order do we go? Dr. Ashwini Kumar is here. He's not here.
Yes, sir, he's sitting, he's
Yeah.
actually...
Yes, sir. After this is Dr. Ankit Agarwal. We want him to be ready with the presentation, so we'll not waste time. So when he's answering the question, you can come and be on the podium. Yes. Right.
May I start, please?
Yes, Dr.
I am
Ashwini.
Dr. Ashwini from Mahavir Netralaya, Patna. So I have few innovations. Like, can you see? This is signature guide. I tell people, I give them to at home to practice the signature. This is called signature guide, which is like learned from Shankar Netralaya, Chennai. And sir, this is Notex. You can see the curves. The denominations are written. So the person who can see less, he will just remember the cuttings and he can say which denomination the note is. So these are two things which are very unique from Shankar Netralaya Chennai I learned. So one is signature guide, sir, to learn to make signatures at a check or other instruments. And this is called Subnotex to count the notes. You can see the denominations. So these two things I have learned from Shankar Netralaya, sir. So now I start my presentation. इसको भैया उसमें डाल दो ना, बैग में, बैग कहाँ गया? उसमें डाल दो. So I'll start the presentation now. No, first slide. No. So low vision is the term to describe the significant visual impairment that can't be corrected fully with the glasses, contact lenses, medication or eye surgery or with anything. It includes loss of best corrected visual acuity, BCVA to worse than 20% in the better eye, significant visual loss, tunnel vision and lack of vision in the periphery. Blind spots are examples of visual field loss. The disability sections from 2014 American standard showed that the 2.3% individuals in between ages to 16 have a visual loss or disability. So the interventions, I used variety of telescopes. One was mobility trailing, means the person will make a big M by rotating his head so that he can see the periphery. And there were spectacle mounted telescopes, and homemakers were given kitchen training like increase of contrast sensitivity by changing wall colors, projection of light, needle threader. I used to go to the homes of the homemakers to teach them how to work in the low light because they can't make the rotis with the one hand, holding one hand with the magnifier. So I used to tell them where should the projection of light and change the wall colors, special utensils, and to mark the things so that they can learn that red color one is the namak and aise karke. So these were the interventions. As you can see, the person can see here. This is called directory reader. Means the person will, जो भी line इनको पढ़नी है, he will put that writing guide there, directory reader there, and he can see. And second one is called dome magnifiers to read, to see the near vision things. This person is holding the spectacle mounted telescope. This is for the distance vision.
Dr. Ashwini, you'll have to sum it up.
Yes. Indication, macular degeneration, glaucoma, diabetic retinopathy, stroke, prone injury, diabetic retinopathy, retinitis pigmentosa, albinism, and nystagmus, and optical visual impairment, and spatial aids for magnifying spectacles, hand magnifying telescope, electronic gadgets, and signature guide and special phones. Thank you very much.
Thank you, Dr. Ashwini.
Thank you, sir.
We have one more announcement. The winner will get 10,000 cash prize
हमको उतार दीजिएगा
from
नीचे.
from
इसको
our
ले
president, Dr. S.K. Mittal sir, for this session. Basically, the idea of this session was brainchild of Dr. Mittal sir, the president, current president, past president of this.
So we have Dr.
Society.
Anant Raina, who is going to speak on prospective study of patented laser trabeculectomy. Ankit Agarwal, because innovative low-cost dry eye. Please stick to the time and just get the relevant points out so that we can understand in the 3 points. Introduction, I think we can skip.
Good morning, everyone. The topic is innovative low-cost dry eye treatment. I have no financial interest in the techniques. The dry eye is defined as dysfunction of lacrimal functional unit, which is an integrated system comprising of lacrimal glands, ocular surface, lids, and the sensory and motor nerves which connect them. Most common type of dry eye is meibomian gland dysfunction, and therefore dry eye can also be termed as tear film dysfunction. MGD is also associated with diabetes and poor lid hygiene, which is prevalent in India. The treatment modalities available are range from topical lubricants to anti-inflammatory drugs and like cyclosporine and steroid. And the various device-based therapies have come up in recent years, like LipiFlow and IPL. However, these devices are very costly, and majority of patients in India and even majority of doctors can't afford to buy them or treat with them. Therefore, I have designed this technique to treat dry eye in a low cost. The purpose is to describe an innovative low-cost dry eye therapy system as compared to the much costly alternatives available in the market. The study was performed at a tertiary care hospital in North India. The therapy protocol was designed wherein a low-cost dry eye heater cum massager costing about rupees 5,000 only was purchased online from Amazon and used to treat dry eye diseases caused due to meibomian gland dysfunction. A data of 39 patients aged between 43 to 59 years was collected. Of these, 27 patients underwent therapy using the novel device, whereas 12 patients underwent therapy using traditional method of warm compresses and massage of eyelids twice a day. This is the unit which I am talking about. And this is how the patient wears it. The device is used for 15 minutes at a time and once every 3 days for 15 days. That is, total 6 sessions are done. At the end of 1 month and 3 months, the following data were collected. That is the Sherman's test, TBUT, and the OSGI questionnaire. All patients are prescribed 1% CMC eye drops prophylactically. The results of these 3 tests are compared with those from before treatment. The results were that the low-cost dry device reduced the incidence of MGD at 1 and 3 months as confirmed a normal post-treatment Sherman's test and TBUT. The traditional treatment group also had significant improvements in the Sherman's and TBUT values, but their speed of relief was lesser. The patients were both symptomatically much better from before therapy. Now, this is the data which I collected. The mean pre-treatment values in the novel device were 24.8 millimeters, where after 3 months it reached to 14.2 millimeters Sherman's test. Whereas in traditional therapy, after 3 months, it is 14.7 millimeters, but the main difference occurs at 1 month, that is 16 millimeters and 19 millimeters. Same with T-BERT. After 3 months, the values are quite similar, but at 1 month, the T-BERT values are different. At 1 month of therapy, the patients who underwent treatment had much improved Sherman T-BERT values. At 3 months, not much difference between the two groups. Conclusion, this innovation is a low-cost MGD treatment alternative to devices which are available commercially and thus makes the therapy accessible to a majority of doctors and patients who otherwise would have missed out on the dry eye therapy. Thank you.
So Dr. Geeta and one question each and Bhupesh one question each, and we'll have the next person be ready, Dr. Vibha Singh.
Ankit, it would be better if you had shown everything about the device, not about the study design.
Yeah, exactly.
Session, so we don't know anything about the device till now.
So that is exactly, I think, what all of us. So when you're bringing in innovation, just this is something for you to present as. Remove the dry eye and all that aspect of it. Just concentrate so that now we are. So can you, for the sake of everybody, in a simple word, quickly can explain what does that device do? Does it use heat, infrared? What does it do?
So it has heat plus a vibration and a massager. So what it does is that basically it relaxes the meibomian, the orifice hole.
So it gets heat for how much time?
15 minutes. Alternatively, after every 30
any idea how much heat it goes to? What's the temperature it goes to?
Temperature, what they have written in the brochure is about 45 degrees. But
and the last question is that, is it something you were part of the development or you just...
No, I
Which
actually...
company makes this?
This is a Chinese product, so I bought it
Chinese
Amazon.
one. Okay.
But,
Thank you.
Okay, thank you, sir.
Yeah. So Dr. Vibha,
Good
just
morning.
even if you have, I know, don't worry about the time now. You just stick to, even if you have a lot of introduction slides, stick to what is very relevant.
Okay.
So that we will just go directly to that. You can skip the slides. We're not going to, nobody's going to cut mark if you skip the slides.
Okay.
So just go so that in the 3 minutes we just get the relevant gist of it.
Okay. Very good morning, everyone. The topic for my presentation is a review of subthreshold micropulse laser and recent advances in a retinal laser technology. There is no financial interest and there is no conflict of declaration. To introduce my topic in the short, laser photocoagulation has been used for the last several decades in the proliferative diabetic retinopathy, diabetic macular edema associated with the retinal vein occlusion and central serous choroidoretinopathy. As we all know, conventional laser therapy induce his therapeutic effect by a targeting metabolically active photoreceptor, thereby decreasing a hypoxic drive and VEGF production. But we can modify it by introduce our micropulse laser. Some few words about micropulse laser. Micropulse laser has emerged as a main modality to achieve a subthreshold treatment where a visible laser burn is not detectable. I just repeat, a visible laser burn is not detectable even with the fluorescein angiography and autofluorescence imaging. Micropulse laser achieve this subthreshold application by decreasing a duty cycle of the laser. Instead of one continuous pulse, the laser energy is divided into a numerous short repetitive pulse, typically from 100 to 300 microsecond with 1700 to 1900 microsecond in between of each pulse. So most important part is duty cycle. There is emerging evidence that a micropulse laser, it is as effective as a conventional laser photocoagulation. So there is a various literature which are in the support of this. We will discuss later if time permits. So it is something about a 5% duty cycle, which I just told it is the most important part of the micropulse laser. This is a diagrammatic presentation of continuous mode and micropulse mode. There are few case report in a chronic CSCR patient. Before the therapy, on the examination, the patient was treated before micropulse laser. The vision was 6/9. After giving patient 3 sessions of the micropulse laser in 2018 to 2022, vision is 6/6 and there is no subretinal fluid in the second patient. And he came on 7th May 2022. Visual acuity was 6/36. There is a upper temporal BRVO. After intravitreal injection, the patient was not having any relief, so we just giving a micropulse laser, so it demonstrate ability of the subthreshold micropulse laser to reduce the number of intravitreal injection To conclude my presentation and take-home message, it has been shown that one should not be damaged full-thickness retina to produce a beneficial effect of laser. There was first documented in ETDRS trial, micropulse laser has been able as a main modality to achieve a subthreshold treatment. Thank you so much.
Dr. Saxena, sir. 1 minute. We'll also call the other person, Dr. Ananta Raina. She's here. You were not here, then Amrita Vidushi Bajaj. Please get yourself ready. Yes, sir.
What has been your innovation with regards to this?
I just working in a Vision Plus Eye Center. This is not my innovation. It is we just compare the finding of both conventional and micropulse laser. It is more safer laser therapy in terms of the side effect what conventional laser is having. It's not available is everywhere. That's I just want to introduce in this conference for the patients.
From the literature, do you think that there's anything which you feel can be done, which has not been done in those 5 papers which you had to skip because of time?
Sir, we can do something about sir, there is something as an augmented laser which are just coming up. So we can just go through both micropulse and augmented, and we can just summarize both
Excellent.
of them to give something new to the patient.
Probably that's what you can build on for the next year's innovation, so that you know what is not there in the literature becomes your innovation.
Yeah.
Thank you.
Thank you.
And after this, Dr. Amrita Vidushi Bajaj, the next person would be Dr. Subhash Chandra Saroj. If you are here in the hall, if you are not there in the hall, then Kiran Bala Malik, doctor, you will be the next one, please. Keep ready. Please, go
Yes.
ahead.
Good morning, everyone. So, as we all go through challenging times, so there are the times we should look for innovations and think out of the box. With the increasing threshold for astigmatism correction in all our clinics, the burden on the surgeons as well as operating theatres is increasing for the astigmatic and the toric IOL implantation. And that is why the markerless systems are making their way into our OTs endlessly. With the newer marking systems like Virion and Callisto, there's always a greater dependency of the surgeons on these systems. But what happens if someday these markerless systems break down all of a sudden and we have a long OT list? So all we can do is either go back to our practices where we mark it with the, on the slit lamp and pray for the God that not the marks are released by the time we are operating on the table. So what next? We should not wait to innovate. So here's what we all have, some anterior segment devices that we always have for the IOL power calculations and other things in our OPDs. So all these devices make sure that the patient is in sitting position with the head aligned and the chin rested and no cyclotorsions. So we have an option of having the landmarks with the protractor and without the protractor overlay. What we can do is mark the landmarks which can be either the vessels near the limbus or the pigmented landmarks which can be identified pre-operatively, and thereby after on the protractor overlay the location. This can also be done on the slit lamp with the devices like the toric markers which are protractor overlay available online. And then when into the OT, we can carry these printouts as a soft copy or as a hard copy on one of the devices. The landmarks which have been pre-identified and the cyclotorsion which has already been taken into consideration, there is no hassle of the pre-op marking on the slit lamps, and there is no concern of the mark disappearance. So here we can see that we have already marked these things pre-operatively on our soft copy, and then these devices already with the protractor overlay we know where the things are. So the cyclotorsion is already being negated here, and here we can mark all of these things, and finally we can put our Mendel's ring over it to make the toric IOL alignment what we have seen pre-operatively. In our experience, one of the fine days when our systems broke down, so we operated some 70 odd patients in this timeline, and we did a toric check, and the results were quite comparable with the markerless systems, and none of our patients were posted for the redialing. So I feel complex problems often come up with simple solutions which are already lying around us. Thank you.
Thank you. Bhupesh, would want to ask anything?
This was quite innovative. I think we need more robust studies to prove that this works.
Yes, thank you so much, sir.
Do you think, where did you feel you had a challenge in this system?
So the main thing is once you already have the OT and then sometimes there's a long toric IOL list with you and then you don't have the markerless systems working, then you're just stuck.
No,
Either
no,
you...
I'm saying
sorry.
with your new system you
Yes.
developed,
Yes.
where do you think you had a challenge? In your
The
innovation.
first challenge I feel is this is already lying around, but we really don't know how to use our machines that well so that we can actually put an application
So
to
did
it
you
here
feel
as
that
well.
after you put a topical NS or anything, do you think that those markers you have on the
Yes.
vessels, do you think that it would change?
No, I personally feel so because most of our patients are being operated in under the topical anesthesia, so it doesn't really matter that much now. Had it been under a local anesthesia, along with the fact that we are continuously putting a tropicamide, now also we are using intracameral phenocaine and also the markerless systems. Even if they break down, the pupil is being dilated with such systems, so it doesn't matter that the blanching of the vessels takes place.
Thank you.
Yeah, thank you so much, sir.
After we have Dr. Kiran Bala Malik, do we have Dr. Subhash Chandra Saroj? So he's not there. Dr. Anant Raina? Both of you are not there. So after Dr. Kiran, I think Dr. Sangeet Mittal, you are there. So you'll have to be ready for this. Okay. Dr. Ajay will, it's okay? He's okay. Please.
Good morning, everyone. I would be presenting on the topic of proportion of tear film dysfunction in adolescent and their association with smartphone use. So smartphone have been increased rapidly over the years, especially during the COVID lockdown, especially in children and adolescent. There are adverse effects on the ocular health and smartphone have been well established. There is scanty literature on the association of smartphone use and the tear film dysfunction among the adolescent. So our purpose of the study is to find out the proportion of tear film dysfunction in adolescent and their association with smartphone use. It was a hospital-based cross-sectional study done in between May 2021 to November 2022 among the patients visiting the ophthalmology OPD of AIIMS Rishikesh with sample size of 123. This was the format that a written informed consent was taken, relevant history followed by the basic ophthalmological evaluation and test for the tear film was done, that is tear meniscus height, Schirmer's test and tear film breakup time. In this study we defined the tear film dysfunction as TMH less than 0.25 mm, Schirmer's one value less than 10 mm and T-BERT less than 10 seconds, and these results were used for our study and analysis. As you can see, 75 patients among the 123, their usage of smartphone is more than 6 hours per day, and it was more for the social networking and reading e-books. The purpose was more for that. And this is the distribution of tear film dysfunction parameters and the association of tear film parameters with duration of smartphone use. As you can see, as the number of hours are increasing, the tear film parameters are becoming more abnormal. So the proportion of patients using the smartphone for more than 2 hours per day was much more higher than those using the smartphones for less than 2 hours per day, and the lower values of TMH, Schirmer's one and T-BERT in participants using smartphone for longer duration are more than 6 hours per day. So my conclusion was the tear film parameters are more likely to be deranged if smartphone is used for longer hours. The screen time is expected to increase in near future, leading to negative impact on the ocular health of the adolescent who are actually near our future people. So therefore it is recommended to limit the smartphone use to less than 2 hours per day to maintain a healthy ocular status in the age group. Thank you.
Dr. Geeta ma'am and Bhupesh.
Yeah, a nice study. Probably what could have been looked at, as you mentioned that, you know, it was for even reading books. So sometimes it's difficult to limit the amount of hours. Did you do any comparison between smaller gadget size versus a larger gadget size, or, you know, a change in the blink dynamics or the illumination system? So probably a few more things would have added a little more value to what you looked at. We definitely know that, you know, the use of smartphone does have issues with tear film dysfunction. For value addition, I think we need to look at a few more factors that would give us answers to how to effectively use the gadgets with least dysfunction on the tear film.
Bhupesh.
Similar comments. Study was good, but I think innovation was missing.
You can, Dr. Geeta ma'am has, Dr. Kiran, so she has given some good ideas. The idea of this innovation is to, when you go back, you make the addition, whatever a suggestion has been taken, and come back and present it with that part of innovation. So hopefully we'll see you next year with that, whatever she's asked you to do. Pleasure to invite Dr. Ajay Arora sir into my journey into suprachoroidal space.
Thank you, sir. Thank you. Good morning, judges and dear friends. So I'll be talking on my journey in the suprachoroidal space. So this all started way back when I had presented a presentation something else in Italy, where this presentation was being made in 2017, where a jugaad was shown on how to enter the suprachoroidal space. And then I looked up the literature that there are microneedles available, and then I asked myself, can we safely inject suprachoroidal injections with commercial needles? Will it be precise? So these are the various devices that are available, and this is not available at the moment in India. It's very expensive. This is not very consistent, and this requires incision and is very expensive. So the way to go into the suprachoroidal space is to go vertically, which possibly will take you into the intravitreal cavity. But if you enter obliquely, we can actually, by changing the angle to the surface of the sclera, go into the suprachoroidal space if we know the scleral thickness and if you have created a nomogram for the angle of entry and the depth that is entered. So we created multiple devices, and this is one of them which is being used. Went through some animal experiments where we injected triamcinolone, methylcellulose and helone, and this is the actual device being used in human eyes, where we've injected now about 108 eyes have been injected. And this actually, we inject either in the inferotemporal or an inferonasal quadrant, where the pain is extremely less, leaves the conjunctiva pristine. So this is an example of a patient who was a diabetic, where anti-VEGFs had been given, Ozurdex was given, and at that time Ozurdex was not available in the country, and how the dramatic response was, and the effect lasted for almost 88 days. I went a step ahead and centrifuged the triamcinolone, and then we removed the supernatant and injected the centrifuged triamcinolone. So this is a patient of non-infectious uveitis, where we injected triamcinolone in the suprachoroidal space. The effect lasted for 4 months. This is the same patient who had a recurrence, and then we injected a centrifuged triamcinolone, and the effect lasted for almost 8 months. She then came back and we injected a third time, and now the effect lasted for about 7 months. So if you look at this, one injection of a triamcinolone which lasts for 6 months, I do not think there's any injection available anywhere in the world. If you look at the economics and the environmental friendliness, if the entire country was using Ozurdex, we spend about 152 crore rupees. But if entire country was using Skita, we'll be spending only 1.44 crore rupees. Not only that, there is less of plastic, and we will be saving about 150 CR if we use Skita versus using Ozurdex. This particular device has multiple other uses, but today I'm concentrating on presenting for triamcinolone. So in conclusion, suprachoroidal injection is safe. It can be done with the SCIT device. Centrifugation has allowed us to extend the time, and we have done in non-infectious uveitis 28 eyes. Multiple uses and larger studies are required. Thank you.
Thank you, sir. Dr. Saxena, sir.
I think it's quite innovative concept. And what kind of complications you might have had using this device?
So the complications, I've had 3 intravitreal injections during the initial phase when we were not sure. So it's very important to measure the scleral thickness with an OCT, so we know what is the scleral thickness there. I have 3 devices with different angulations by which we have a nomogram. I can ensure at what depth one can enter. So one can enter exactly in the suprachoroidal space, and then at the time of entering, it's being injected by an assistant. So the moment the assistant feels the give, you are in the suprachoroidal space. It's a 100 micron space. So the moment there is a give, it automatically flows. If it is in the scleral fiber layer, you will not be able to inject it. And the advantage of this is an oblique entry, so there is no regurgitation. If you inject it perpendicularly, there is a chances of regurgitation.
One thing, sir, a suggestion is you are in Delhi and you have IIT and all these institutes. They have very good imaging technologies. Why don't you, because many times lot of Indian innovations do not reach the wider market, because lot of innovations we don't put our, we don't have technologies to prove what you're saying in real life scenarios, means real live imaging scenarios. I have studied why Japanese innovation attracts to us. I've seen the first video of Yamne's technique. Yamne's technique, he had first video more than the patient. He had put his effort to do all this kind of hardcore imaging work with animal eyes.
Right.
And he brought out the video and that became Yamne's today. I'm just giving one example. Why don't you talk to IITs or one of this optics department of it? They will exactly what you have thought process. They can recreate that model for you. Okay. And those model, when you were exactly telling about, you beautifully explained about scleral fibers and electron microscopy, atomic force. One of these microscopies exactly prove what you are trying to say. And if you combine it with, then it becomes a global phenomena. I mean, this is my take.
So what I did, sir, I have worked with IIT. So before I did this, because it's 3 minutes, I can't present anything. We have done scanning electron microscopy
exactly.
on triamcinolone. So we took 4 triamcinolones from the country, and the first thing was to prove why a triamcinolone can be injected through a 30 gauge needle and not a 26 gauge needle. So we actually calculated the particle size, went to the firm from where orocort is sourced, calculated how much particles are there in each orocort vial.
Absolutely.
And that is that. But then your suggestion of actually showing the needle going inside, that I have not done.
So that is something which
but
you
I
can
did
do
SEM for triamcinolone. I've done
you can do that, the exact path, the path, they do the, velocity measurements, they do the flow measurement, they can do everything for you. All we need to do is we had to go tell them, we had to give our menu to them. This is what I want, and this is. And
so I'm working with the biomedical department, and we did something else also with them. But the optics part is a good suggestion. I never thought of doing an optical way and imaging a needle through an opaque sclera. That was my question. Now,
how it goes through different collagen. Yeah. Thank you, sir. We have Dr. Sangeet Mittal, and after Dr. Sangeet Mittal, we have Dr. Rohan Mehra is here. You be ready on this side, please.
So I'll be presenting some innovative methods to do ocular sampling. Can we have the audio?
Assistant to hold the eye while the surgeon withdraws the fluid using both hands. Also, sample collected is not sufficient. We describe a new homemade device for aqueous tap. 2 cc syringe is cut at its back end and a rubber suction cap is attached to it. 26 gauge needle is then mounted on the syringe. Small hole in the rubber cap acts as a safety valve. Vacuum is creating by pressing the rubber cap after covering the hole with finger. Aspiration is done when the pressure over the cap is slowly reduced as shown in this demo. Vacuum is created by pressing the rubber cap before the needle enters the eye. Once the needle is in AC, the pressure over rubber cap is reduced and the aqueous gets collected in the syringe. The obtained sample can then be inoculated directly over culture media or sent to lab after covering the needle. The conventional method of vitreous tap causes pull on the vitreous, resulting unsafe vitreoretinal traction in already inflamed retina and may lead to retinal detachment. We present an innovative method of vitreous tap which is safer, easier and does not cause traction. 3-way cannula is connected to the vitrectomy aspiration tubing and the third extra port is kept closed. 25 or 27 gauge sclerotomy is made superatemporally 4 mm from limbus and cannula is inserted. Vitrectomy cutter is used to cut and aspirate the vitreous till the eye becomes hypotenuse. This is indicated by inward dipping of cornea. As we cut and aspirate, the vitreous collects in the aspiration tubing. Intravitreal injection of antibiotics is then given through the same cannula. This also helps in rebuilding the intraocular pressure back to normal. Cannula is removed and sutureless closure of sclerotomy is done. Syringe is connected to the third extra port of three-way cannula and vitreous fluid in the tubing is then actively sucked into the syringe by opening the port. The obtained sample is then sent for microbiology. Though the bag in which the fluid collects can be sent to lab for microbiology, but many times we reuse the same bag either for multiple procedures or on multiple days. This compromises the quality and sterility of fluid. We present an innovative hack to collect the vitrectomy fluid for adequate sample. An IV tubing is placed in a pre-sterilized Ringer lactate bottle. The plastic connector at the other end is removed and it is then connected to the vitrectomy machine. Thus, the bottle acts as the collection bag. The vitrectomy fluid collects into the bottle during the procedure. The whole bottle can then be sent to lab for microbiology.
Thank you, sir.
Dr. Saxena, sir.
Yeah, I think these are quite nice innovations and quite simple to use and practice. Yes. Very nice. Yeah.
Dr. Sangeet, it's quite very simple, like what Dr. Saxena said. Really like, and since how long you are practicing this?
So I think it's now about 3 years. And actually we have done a comparative study of both the techniques, the conventional ones and these ones. And one of these techniques, the aqueous aspirator, in fact was awarded with the Nursing Rao Award in the AIOS. But because of the time, I could not validate these techniques in this. I just wanted to show that these can be done.
Okay. Just a question, just an inquisitive one. Do you think that when you compared your samples,
yes, sir,
you must have had a mix of bacterial, fungal, and different. Do you think that this technique, compared to the conventional,
yes,
were better in, say, a fungal infection or P. acnes kind of a situation?
Yes, sir. The thing was like we got higher, not the sensitivity part, but because the higher sample size, the labs were able to culture the material, because otherwise the aqueous sample that we routinely obtain is very small sample size, and most of the time is the sample is returned back.
Yeah, because many times bacterial and fungal will have much more sample, especially if we're looking at P. acnes.
Yes, sir.
Many times, you know, it just comes as negative, and because they are not so much in to pick up in a fluid.
Yes, sir.
Thank you, sir.
Thank you, sir.
We have Dr. Rohan. Before he starts, there are two people who are not spoken today. The last chance for them if they're in the hall, Anant Raina and Subhash Chandra Saroj. If both of you are not there, then this will be the last. So okay. So Rohan, you start.
Reticule extracting hydrocannula for smile refractive surgery.
The authors have no financial disclosure to make. Ever since the existence of human life, our aim as a united community has been to make things easier, and in order to do that, one has to constantly innovate. What is innovation? Innovation is the art, science, or process of developing better solutions from existing inventions and ideas. It is the validation and exploration of ideas that others may have missed, rejected, or long forgotten. Innovation connects the dots. Here, we demonstrate the separation of the lenticule and its extraction by pulling it out with the help of a microforceps. If we take a look at this particular case, there is a marked resistance in the separation of the lenticule, which leads to a tear of the hinge in the tunnel incision. This resulted due to improper dissection followed by a tugging movement to retrieve the lenticule. Such complications are not uncommon. Going through the review of literature, there are multiple highly cited papers published in index journals showing lenticule extraction related complications making up for a majority of the total complications of smile surgery. So where did the idea originate? One day, I had a severe earache and I went to my ENT friend. He told me that wax is the culprit for the earache and removed it by irrigating my ear cavity and not pulling it out, which got me thinking. If the ENT can do it, then why not use it in ophthalmology? So I took this idea to my mentor, Dr. Gaurav Luthra, and we developed a hydrocannula to extract the lenticule, making smile surgery further less invasive and extracting the complete lenticule without any cuts and tears. The hydro cannula is of 23 gauge and it bends to facilitate its movement over the contour of the cornea. Here are a few demonstrations which show how a simple idea can make a huge difference in the reduction of complications in smile surgery. The hydro cannula is introduced and the saline is injected, which aids in smooth retrieval of the lenticule. This lenticule is now placed on the cornea to show the intact edges of the lenticule. Another example of the same technique, which is simple and reproducible, leading to the extraction of the lenticule in totality without any cuts or tears. Way back in 2014, we started cryopreserving the smile lenticule for possible potential use in human subjects. And less than half a decade later, we started using it in construction of corneal stroma, therapeutic keratoplasty, keratoconus, and most recently in regenerative therapy. Who knows what the future holds and what new uses of the lenticule might come up in due course of time, thus making it imperative that we retrieve each lenticule in totality without any tears and cuts, and we store it for possible future use, hence making our innovation extremely important and one that could possibly help many individuals for restoration of sight, leading us to call this lenticule my precious.
Nicely made presentation, Rohan. So actually the problem with the smile surgery is the dissection. Once you dissect it properly, then removal is always easier. So if we can add something in your cannula which helps in the dissection also, then it will be a great tool. But definitely with the forceps, we get a lot of injuries on the cap. So this is a good tool and very easily available, I think. This is just a cannula. But definitely some improvement can be done. It's a good innovation.
Ma'am?
Yeah, no, I would echo what Dr. Bhupesh said. The issue is primarily with getting into the planes, and dissection is usually not that much of an issue, but it's definitely one step ahead in terms of extracting the lenticule out in a much more easier way. So do you inject the, is it injected into both the planes and then it's...
No, he's already dissected.
Yeah, he's already dissected it, I got that, and then you're just injecting it and that's
that comes
allowing
out.
the lenticule to...
In the entire video, actually, there is a case in which what happens is that once we inject it, we see that it has not been separated completely. But how this helps in that also is that if the dissection is not done, your visualization of the point where that dissection is there, where that tag is there, is much better. Because otherwise, when you are dissecting, it's a hazy view. But once you put the fluid inside, you know exactly where the tag is and you know the vector force to apply to pull it out in totality. That's there in the entire video, actually.
Only challenge which I think, I don't know that if there are smile surgeons in this group, a lot of us don't use water to clean the thing because we are worried that the quality of vision suffers because you have put fluid into the system. So that is one thing which, I mean, of course, there are equal believers and non-believers of fluid. Some of us we use. But one thing which you can try, which what ma'am said is that the same cannula can have more on the, vents from. So when you see, basically all of us want something where we don't put an effort to dissect. So imagine you just, before even you're dissected, you go in and inject. So what happens is the fluid just makes the separation, and also you have vents down. So when you go in, fluid separates it. If you can create one, you got it what I'm trying to say. You are now, entire fluid is coming from the top, front, right? Yes. 1, 2, 3, 1, 2, 3, inject. So once it goes in, if it can dissect, if that fluid can dissect and go in and dissect, that would be what all of us want, because we don't want to put trauma. You can call it visco dissection, like how you do a big bubble. Like instead of big bubble here, you're not using air. You're actually using fluid, or you can use air, whatever you think. Create a mechanism like big bubble in this, so that your dissection, am I right?
And simultaneously inject.
Yeah, I mean, that would make it even more simpler, where you have both the planes getting dissected at the same time with the jet of fluid.
Yeah. Exactly. But this innovation has a lot of potential of improvement?
I mean, I am not a refractive surgeon, but when you are showing that video, so that theoretically it looks like it's so much fiddling inside.
That is actually, sir.
It's a fast forward.
No, that's true.
Increase,
That's
3x
actually,
speed.
I mean, the hydro dissection, that part.
Yeah.
That's not theoretically it looks, yes.
I think unless it is totally dissected, it can't come out. So if the fluid is, you can't put the pressure so much that it can dissect anything.
Correct.
So only thing we are just putting, it can take out care of the debris and other things, but probably it's just giving a mechanical support to free floating one.
Even if it reduces by 50% mechanical dissection, still a surgeon, all the surgeons here who do smile or any of the smile procedures will help.
And probably some debris is there which we can't see, that is also washed out with this one.
So I have a question for Dr. Rohit also. So in many cases we get a flap fold with lenticule fold on itself. So will this cannula help in that also? Can we unfold the lenticule?
But many times it folds because one side cut is not
so
cut.
Will this cannula help in that unfolding again?
It could unfold. It's like exactly like what ma'am and all, or you would do with your DMEC or DSEC flap, no? When it taco folds, how you iron it and other things. I mean that will. But like I said, instead of once his cannula has fluid coming from the end. So if he tries it out and tries some mechanical thing, then he should do it.
Rohan, like you can try some conduct a study actually, a comparative study. On some cases, I think that will actually come up with this all parameters of corneal thickness, other things, details. So that will help actually.
A simple technique.
OCT, OCT,
yes,
anti-segment OCT.
A simple technique, but have you faced any sort of complications with this?
So in the entire video, there is actually a case in which, so the basic principle for this is Bernoulli's principle, sir. How an airplane generates lift, similarly if the pressure inside is more, only then it will come out. If your flow is turbulent through the cannula, then that dissection, that it will not come out completely. So that we have faced, but then also the visualization becomes so much better that we know where the tag is. So we know exactly where to pull it out so that it comes out in totality. The idea is to have this lenticule come out in toto with the edges, because that is what can be used later in tissue addition surgeries. Once we use a forceps to take it out, sir, we have high chance of traumatizing that lenticule, cutting through it or traumatizing it or scratching it in some other way when we are taking it out.
And one very important take-home point, this is for all the youngsters who are presenting here, is that move out of the zone of a lot of hypotheses. All of us make hypotheses, but even in this, like sir said, figure out who can look at you said Bernoulli's principle. Test it out with, collaborate with centers across India and say that this is my idea, I want to test it out. You'll have at least 2-3 institutes who will do. There are a lot of engineering students who need projects. There are a lot of MTech students who need projects. Like she mentioned about work with imaging people. The same images, can we create image based assessment? There are a lot of young engineers, if you go to students, when they are in the final year, they need some project. They're very, very intelligent students. They can create a lot of things for you. And give them this project, let's do this way. And they're very interested in it because they are tired of doing the same project. So bring out your innovation, and that's what Japanese do. If you go to see their videos, he would have explained the whole Bernoulli's on the lenticule.
Okay. So in my entire video, it is explained.
Exactly, but what you do is,
it has to be proved.
You can't explain a video on your hypothetical model. You have to say, we went to this department, this is what I did. And this applies to all those presenters today, that you have to go out of your comfort zone of doing the routine thing, whatever is available in your ecosystem. Any last comments from all three of you? One comment. We have 5 more minutes. Dr. Saxena, sir. Dr. Geeta.
Yeah, like you mentioned, a lot of interesting concepts came out today. Especially the AC tap that Dr. Sangeet Mittal mentioned about. I mean, that is something which is really innovative. The smile flap, and the suprachoroidal injection, with really some of the very interesting concepts that we got to understand, and for the others also, like Dr. Rohit mentioned, it's just a matter of adding a few more steps to your techniques to make sure that it has that required value addition to make sure that we can actually make it practical. I think that would be my idea.
And the others also, we have given suggestions. I want all of you to come back next year with those suggestions. Like we had this dry eye thing. If you can just look at different types of dry eye and maybe compare something and come out with the parameters, which is we made, then that will be good. And we had the micropulse laser. We looked at thing, and there was a very good talk on the image guided system. I think it's very practical. The reason is most of the time we are dependent on it, and it's very, very costly to have an image guided system, even in the best institute. So if you can bring in a less cost effective, and if you can work with some image people and come out with much simpler, there's a fantastic model. And we had the visual rehabilitation, we keep it as the last, but there's always the, when we realize how it is, they say value of a well is known when it's dry. And that's a fantastic one. And I mean, everything was very good today. And thank you all, and thank my co-chairman, Mittal sir, and all the judges. I think you'll have to submit the marks to madam here.
Thank you.
We're done. I mean, we finished on time.
Thank you, sir. With permission of all chairpersons and judges, we conclude this session. Thank you very much. No, sir.
All the presenters who are present here. All our presenters can come quickly.
I'll please request Dr. Rohit sir and Dr. Sandeep Saxena sir to please stay back. Ajay, you have to go for another session. Okay. So we'll be starting our oration session now. So I request Dr. Sanjeev Mittal sir, if he's here. Dr. Vinod Arora sir, if you can come onto the dais. Dr. Mayank Pangti sir, please. So we have the prestigious Dr. Vinod Arora oration for Uttara Eyecon 2023 now. Dr. Mittal sir. So just a brief introduction about our President Dr. Vinod Arora sir, after whom this oration is named. He is the director at Navjyoti Eye Hospital and Dehradun Wave LASIK Center, Dehradun, past president of the IRSI, past president of the North Zone Ophthalmological Society, president-elect, he is now president actually, yesterday sworn in, and member managing committee AIOC from 2010 to 16 and now continuing after 2023, has published over 30 papers, is sub-editor of Himalayan Journal of Ophthalmology and reviewer for IJO. He won the Best National Paper Award in DOS in 2000, has presented over 700 papers, keynote addresses and conducted courses and national and international conferences, awarded IRSI Gold Medal at Chennai in 2017, IJO Honor Award for Peer Review 2022 and BP Kashyap Oration at Jharkhand Ophthalmological Society this year and awarded the ISCKRS Excellence in Refractive Surgery Award this year. So some of the past recipients of Dr. Vinod Arora oration, you can see them, and last year it was Dr. Namrata Sharma who gave this oration. And it's a pleasure and honor for me to introduce this year's Dr. Vinod Arora oration awardee, Dr. Geeta K. Iyer, who's a senior consultant at the Ocular Surface Clinic and Cornea Services at Shankar Nethralaya, Chennai. She did a short-term observership in ocular surface disorders with Dr. Sheffer Seng at Miami in 2006 and in Boston Type 1 K-Pro with Dr. Claes Dolman in November 2006. She was trained by Professor Giancarlo Falcinelli in performing the MOOP K procedure. So she has so far done more than 300 K-Pro surgeries. As a founding member of the Cornea Society of India, she was the president of the society in the year 2020. She is the managing editor for the Journal of Cornea and Ocular Surface, the official journal of the Cornea Society of India. She is on the board of directors of the International Tear Film and Ocular Surface Society, and she is an adjunct faculty at SERI in Singapore. She is a steering committee member of the International K-Pro Study Group. Her work in the management of chronic ocular sequelae of Stevens-Johnson syndrome has been extensive with aim to preventing the occurrence and deterioration of the sequelae, as well as understanding the immunopathology of the ocular disease. Her other area of interest include dry eye, pediatric penetrating keratoplasty, ocular surface tumors, ocular surface disorders including chemical injury, stem cell transplants, and K-Pro. She has more than 80 publications in peer-reviewed journals, and she holds a patent for developing a dry eye application. So with this, I invite Dr. Geeta K. Iyer to please come onto the dais and receive her oration. Certificate from Dr. Rohit Shetty and the other executive of UKSOS. I request Dr. Geeta to please give her oration now, which is titled Optimizing the Ocular Surface Pre and Post Refractive Surgery. Thank you.
Ocular surface and refractive surgery are literally considered as two ends of the spectrum in the entire of ophthalmology. The happy 2020 patients fortunately form the bulk of patients that we see post laser vision correction in our refractive clinics, but the patients who take the maximum chair time and the patients who make life extremely challenging for us are the unhappy 2020 patients post LVC, unhappy mostly because of the dry eye disease. the most common ocular condition that occurs post laser vision correction, and it is this subset of patients where the realm of ocular surface and refractive surgery significantly intersect, and this is what will form the crux of my talk for today. At the outset, let me thank the organizers of Uttara Eyecon for this honor and privilege to deliver the Dr. Vinod Arora oration at Uttara Eyecon 2023. My sincere gratitude to Dr. Gaurav Luthra, Dr. Saurabh Luthra, most importantly Dr. Vinod Arora, for having given me this opportunity to deliver this oration titled Optimizing the Ocular Surface Pre and Post Refractive Surgery. I would also like to thank Dr. Saurabh for his kind introduction. Thank you, Saurabh. I have nil financial interests to declare. DED following LVC is something that we all understand and know is extremely common following the procedure and extends for several months to maybe even years following the surgery. The severity varies depending upon the procedure to some extent and largely based on the patient, and DED post LVC has a multifactorial etiology, namely neurological, inflammatory and mechanical. Most importantly, neurological, which occurs because of the extent of nerve damage in laser vision corrective procedures due to the severance of the corneal nerves, as well as the damage to the nerves that is inflicted upon by the laser ablation itself, which is usually more often seen in patients who undergo the LASIK procedure, followed by query PRK or query SMILE, which explains the speed of recovery being faster in SMILE and PRK compared to LASIK, with the normalization of parameters reflective of dry eye disease occurring any time between 3 months to 3 years following the procedures. So in a nutshell, what we as refractive surgeons create is an iatrogenic neurotrophic keratopathy that has an impact on all the layers of the tear film, in addition to the contribution of the inflammatory and mechanical causes, which also affect all the layers of the tear film. We are all aware of the different categories of dry eye as per the T-Force Deuce 2 report into aqueous deficient dry eye and meibomian gland deficient or evaporative dry eye disease, and there's a large subset of patients that have an overlap of the two. As far as we are concerned with the DED screening in pre-refractive patients, it's important that we filter out those who are symptomatic and have clinical dry eye disease, but more importantly to filter out those patients who have clinical dry eye disease but are absolutely asymptomatic, those who are preclinical where there is a risk of pushing them into being overtly clinical following the surgery, and those conditions that can mimic dry eye disease and can get compounded following the procedure. This means that for optimizing the ocular surface, we need to have an effective system in place that will help us screen these entire subset of patients pre-laser vision corrective procedures, and would also include managing these eyes before as well as after the LVC procedure. Fortunately for us, the causes for dry eye disease in refractive surgery candidates is largely limited. So when we look at MGD as a cause, it is primarily in this age group of patients caused by blepharitis or primary MGD, patients who are on hormone therapy for PCOD or thyroid, those who might have been on or are on isotretinoin for acne therapy, and this is a subset of patients who use contact lenses significantly, which has an impact on meibomian gland dysfunction. Having an actual reduced tear quantity leading to aqueous tear deficiency in this age group of patients is quite rare, though it can occur and could be physiological, could be related to an underlying Sjogren's syndrome, either primary or secondary, could be post-adenoviral conjunctivitis in the past, or could be neurotrophic related to a past HSV infection. When the desired output in dry eye disease screening among pre-LVC patients is to capture all the relevant information such that we could mirror with our colleagues with respect to documentation, as well as intelligently communicate with our patient regarding the underlying status. When it requires significant input from us as surgeons, and when it requires a lot of information from the patient in terms of history, clinical evaluation, and a gamut of tools, how does one ensure identification of borderline or frank dry eyes in refractive surgery candidates? And the million-dollar question here would be, can this be done for us by somebody else? Could we have something that would help us streamline evaluation, which would provide us with a uniform reporting platform that would help us with diagnosing the type and severity of dry eye disease, in addition to providing us with a directive for management? Look no further. At the Ocular Surface Clinic in Shankar Nethralaya, we have designed and conceptualized the Ocular Surface Portal, the first of its kind in the world. That is a web-based application wherein what we have done is combined technology, clinical expertise, experience, and literature support, keyed in all these small pieces to basically have what we call the dry eye module, or the first module of the Ocular Surface Portal. Is this artificial intelligence? Well, not exactly. What it is an application intelligence platform which collects, understands, and acts on the data provided, translating it into actionable information based on the published algorithms. So what are the features of this dry eye module, and how is this going to help us with respect to the screening that we are looking at for our refractive surgery patients? It can be used by all ophthalmologists, and it includes advanced features for those who have the specialized investigative tools, and the only mandatory tests that the application warrants are a Schirmer's 1 testing, the fluorescein tear breakup time, and corneal staining. These are tests and equipment that all of us are equipped with, and I shall now play a short video which will show how the dry eye application needs to be used, not just for screening our refractive surgery candidates, but also for evaluation of dry eye patients in general.
Let us examine this test patient, and this is how the application looks, the Ocular Surface Portal. We have several panels, and let's take a look at what each one of them has to offer. So the history panel has several questions to it. In fact, there's a total of 37, which looks like it is a lot of questions, but then these are the questions that we normally ask every patient who comes to us with complaints of dry eye. So once you fill the answers appropriately, like you see here, if the patient has already been diagnosed to have Sjogren's syndrome, whether he's on medications, since how long, and which systemic medications, can all be captured in the application. Beyond this, the second panel is the DEQ5, where the scoring of the symptoms is done for each eye separately, and the appropriate drop down is selected for each of the 5 questions in the DEQ5. In the dry eye mimics panel, you can enter the vision, and you can also mention if there are any clinical features that are suggestive of any condition that could mimic a dry eye. The dry eye examination is the most impressive panel of the application, where you can actually enter the lid margin related findings in the form of lid margin telangiectasia or thickening of the lid margin, which will be represented schematically. If the meibomian glands are blocked or the secretion is reduced, then the gland openings close down. If there's presence of squamous blepharitis or there's trichiasis on the nasal aspect, then that is again represented clinically. And if you have cylindrical dandruff, and if the puncta are cauterized, then this is something that you would need to mention in the application. The conjunctival findings include the presence or absence of hyperemia, conjunctivochalasis, limbal nodule, and of course the extent of conjunctival staining in each of the quadrants of the conjunctiva, which is then represented schematically. The corneal findings relevant for us with respect to dry eye include staining of each of the quadrant, presence of filaments. So accordingly, we mention the extent of punctal staining, and that again gets captured very beautifully in the examination panel. In the diagnostics panel, which is a mandatory panel where the values have to be entered, these are the values for Schirmer's 1, tear breakup and staining, which we have entered, and then you generate. So if you change this, say, to a different value and then you generate, then you get a diagnostic sheet which captures the essence of what the patient has in terms of the type of equistia deficiency, characterizing the meibomian gland deficiency, whether there is any plus disease based on what you have entered in the history and the clinical features, what are the contributory factors again based on the history, and what is the punctal status for each of the 4 puncta. And this can be printed, and the dry eye diagnostic sheet can be handed over to the patient. If you're referring the patient to a rheumatologist, the cornea rheumat interface sheet opens, where you can enter all the where the data gets captured from the app, and you can enter in whatever you wish to communicate to the rheumatologist with respect to HCQ screening, toxicity, clearance for cataract surgery, presence of any emergency condition which requires any emergency management, and then you print this sheet. It generates a customized referral letter to the rheumatologist, puts in all the data that you want to share with the rheumatologist very clearly, and asks the rheumatologist for a feedback regarding the underlying condition and the use of medications. The advanced investigations panels allows you to enter the values for each of these investigations that you might have access to, and some which are not mentioned in the application can be entered manually. There is a prescription panel which can be used to generate the medications that you want to prescribe to the patient, along with the doctor's notes, which has these pre-written templates that can be used in the treatment regimen. And of course, you have the upload document panel where you can enter in all the lab reports and the slit lamp pictures for a particular patient. You can decide whether you want to continue to edit your findings or whether you want to submit once you are sure that you have entered all the relevant data. So what else does it do? It provides you with a symptom sign trend chart. It compares previous examinations. And to summarize, it's a highly useful tool, provides you with a uniform standard reporting system, which is an extremely effective means of communicating with patient, colleagues, and rheumatologists. To register, please log on to ocularsurfaceportal.in.
So that basically explained how the application actually works for all patients of dry eye disease. And what is important to understand is that there is a particular sequence in the way in which we conduct the dry eye screening in these patients, which is relevant to all patients, irrespective of whether they are for refractive surgery or otherwise. This is the sequence of testing that we follow at Shankar Nethralaya from top to bottom, left to right. But what would be the absolutely essential tests that one must subject patients undergoing laser vision corrective procedures are the ones that I have highlighted in red. Especially if there is corneal staining, it is a red flag that one needs to take into consideration, because corneal staining does not usually occur in patients of MGD, and when it does occur, one needs to rule out the cause for ocular surface staining before you actually subject the patient to a laser vision corrective procedure. It's equally important to understand how one needs to do a dry eye evaluation in these patients. When you have so many things that one needs to look for, there's always a need to try and figure out if we could end up having a logic amidst the chaos. And once we get it into practice regarding a particular way of looking at the eye, then it just becomes second nature. And this is what this particular video highlights as to how and what one should look for when we do a DED screening. So general evaluation, starting with the eyelashes, the lid margin, the superior bulbar conjunctiva for relevant features that are suggestive of dry eye disease. Look for features suggestive especially of any phonacial shortening or any mild cicatricial change which you might see in a patient who's had past adenoviral keratitis. Do the same thing for the other eye. Always look at the puncta, look at the medial canthus, look at whether the eye in general is moist, or whether there is any focal area of lackluster appearance. Once the slit lamp evaluation is done, the staining is then done. Nowadays, with the yellow filter, you can also assess the conjunctival staining, which is another important parameter that needs to be taken into consideration. Look most importantly for lid viper epitheliopathy, because that is something that patients could be symptomatic due to, even though you are not able to see anything else on the surface. And finally, finish it off with a meibum expression to look at the expressibility of the meibomian glands as well as the quality of meibum expression. The tear breakup time is something which needs to be looked at in these patients. The appearance of the first random breakup on the surface, which tells you what the tear breakup time is, after which you would grade the severity of the staining on both the conjunctiva as well as the cornea. You don't really need to do a separate lissamine green staining nowadays. If you have access to a yellow filter, you will be able to grade the conjunctival staining with the fluorescein strip staining itself. So all the 4 quadrants of the conjunctiva are graded with respect to staining, and the corneal staining is also recorded, and this is again the lid viper epitheliopathy, which can make these patients symptomatic, and you might keep looking for a cause, and finally understanding the presence of conjunctivochalasis. So with the application, with the understanding of how the ocular surface is evaluated, it is a very comprehensive way of understanding which of these patients have a possibility of developing dry eye disease following your laser vision corrective procedure. And once we have that in place, we need to then understand regarding the management of both the MGD as well as the ATD component that these patients might present to us with. So more commonly what we encounter in patients of pre-LVC screening are those who end up having meibomian gland dysfunction, and the treatment for this, especially when you're treating a patient who has blepharitis or primary MGD, is by treating with a PG-PEG or a lipid-based lubricant. Here it's important to remember that prescribing a lubricant is not really just the habit of pen, rather the lubricant needs to be tailored to what exactly the condition the patient suffers from. And when we treat patients of MGD, it is the PG-PEG or the lipid-based lubricant that has a role to play, apart from the other conventional modalities of management. And of course, the MGD-directed interventions such as thermal pulsation or IPL can be used to stabilize the ocular surface before we take up these patients for LVC. Among the patients where the tear film instability is related to hormone therapy or thyroid imbalance, it is best to ensure stability of the hormonal status for at least 3 to 4 months, and if possible, obtain a clearance from the treating endocrinologist. When you specifically ask, it would be surprising to know how many of these patients actually are on or have been on isotretinoin therapy. And this is something which needs to be taken into consideration because it can have a significant impact on both the healing as well as your meibomian gland dysfunction. The dermatologist's guidance that exists in literature is to wait for at least 6 months after stopping isotretinoin before you take up these patients for any kind of surgery. However, there are a lot of controversial reports with respect to this, and what we follow is to stop isotretinoin for at least a month or 6 weeks before we take up these patients for LVC. Always document with the help of a meibography to assess the dropout, if any, related to the use of isotretinoin. Ensure tear film stability, and if required, subject them to specific MGD-directed therapy on a case-to-case basis. The management of patients who present to us with aqueous tear deficiency is a totally different ball game, but fortunately these are the less common patients we see in our refractive surgery candidates. But you can have patients who present to us with a low Schirmer's, with a reduced tear meniscus height, but are absolutely asymptomatic. And in these patients, apart from the investigations that I had highlighted earlier, we have access to osmolarity, so that is something that we routinely subject subject these patients to. If the osmolarity is high, then it's a definite red flag, though if it's low or normal, you could still probably consider going ahead with the procedure after you have subjected them to the appropriate management. Reassess the surface to look for any signs of cicatrization. Fluorescein clearance test is something that we do routinely to look for the presence of reflex as well as emotional tearing. And the management of ATD pre-LVC here, it's largely a hyaluronate based lubricant. We do try and see if we could use trehalose if there is corneal staining, topical cyclosporine for 6 weeks prior to the procedure. Punctal plugs are rarely required pre-LVC but do have a role to play in those patients who develop significant dry eye post the procedure. Opt for a non-LASIK procedure if that is an option. Prior HSV is an absolute contraindication to doing the LVC, and the patients need to be counseled about the possibility of adenoviral reactivation in case of a past history of the same. And in these patients with DED, it is extremely important that you spend more chair time with these patients before the procedure and counsel them regarding the possibility of worsening of the symptoms, because that is something which will significantly help you in case they worsen after the procedure is done. So after we prepare the surface and optimize the surface, we reassess the patients of ATD in 2 months, and if the values are still low, especially your Schirmer's, your tear meniscus height, then, and if the FCT shows a reduced reflex and emotional tearing, these patients are referred to the rheumatologist to rule out the presence of an underlying systemic collagen vascular disease, which is usually rare in this subgroup of patients. But if they do have Sjogren's syndrome, either primary or secondary, and we have seen a few patients in this age group who are diagnosed cases of Sjogren's syndrome or rheumatoid arthritis, in general, refractive surgery, probably barring ICL, is not recommended or performed by majority of ophthalmologists in the presence of these conditions, though there is limited literature to support the procedure in well-controlled patients, especially those who are not on a multi-drug regimen or those who do not have SICA. All these are basically short-term outcomes, and we still do not have any data regarding the behavior of the cornea in long-term in these eyes, and these are preferably not subjected to refractive, especially the laser vision corrective procedures in these eyes. So this is the dry eye suite that we have at Shankar Nethralaya, which is both temperature as well as humidity controlled, and the patients are subjected to a detailed dry eye screening in this clinic. I would just like to sum up with a few case scenarios which help explain how we manage these patients, because not all of them come to you with just one particular cause or one particular deranged feature. It's usually a combination of parameters that needs to be taken into consideration, and the management is tailored based on each individual. So this was a 23-year-old female who came to us for refractive surgery. She was using contact lenses earlier, absolutely asymptomatic. On examination, her tear breakup time was 6 seconds, but otherwise most of the other investigations, including the myography, were normal with a near normal lipid layer thickness. So she was someone who had mild meibomian gland dysfunction. She was asymptomatic. So all that we had to do for her was medical management of the MGD, educate about a complete blink, and we went ahead with the refractive surgery. This was a 25-year-old female who was symptomatic because of her MGD, a tear breakup time of only 4 seconds with no corneal staining, where the lipid layer thickness was noted to be significantly low. And despite medical management, she still continued to remain symptomatic, for which we subjected her to a lippy flow treatment, after which her symptoms significantly abated. And then we went ahead with the procedure, explaining about the possibility of an exacerbation post-treatment. This was a 24-year-old male when unfortunately his smile turned into a frown. He had the smile procedure done elsewhere 2 years back for a -5 diopters. He had been diagnosed as dry eye on multiple lubricants. We also treated him as dry eye, both a combination of meibomian gland dysfunction as well as aqueous tear deficiency. In fact, we got his rheumat evaluation also done, which turned out to be negative. He was started on topical cyclosporine Post 2 months, there was no improvement. We reassessed his history, subjected him to a LipiFlow treatment, after which he was better, but still significantly symptomatic, in fact significant for him to actually harbor suicidal thoughts, and he was subsequently sent to an orthoptics evaluation where he was diagnosed to have significant accommodative insufficiency, and following an in-house session of orthoptics exercises, the patient actually felt much better, which explains that you not only need to look at dry eye disease and its manifestations, but also at mimics, which can lead to symptoms that so closely resemble what a patient can present to you with DED as. And this is another patient whom I had done a femto LASIK for, who was 2020. And if you actually see, you can see the amount of time that I would have had to spend with her post LASIK, because she had multiple symptoms. We figured out that she had vitamin D deficiency, which was corrected. She had orthoptics related issues, which was corrected. We went ahead with the proper meibomian gland dysfunction treatment. But if you closely look at her when she's speaking, there's this little bit of hemifacial spasm that you can see on the left hand side, which was picked up, and she is currently under treatment for that with our oculoplasty and neuro-ophthalmology colleagues, because she was more symptomatic in OS. The left eye was looking much smaller, whereas the left eye was the eye which had the higher refractive error before the treatment was done, and it should have actually, if at all, looked larger than the right. And the previous investigations or examinations were when both of us were masked. So that is another thing. I mean, you need to make sure that you constantly keep looking at some of these subtle indicators that might provide the clue to diagnosis in these patients. But having said that, it's important to look at these patients in a entire perspective, in a holistic way, so that we know what exactly the problem is and what exactly we are treating. So in summary, I think we all do understand that it's extremely important to optimize the ocular surface, both pre as well as post refractive surgery, with the various screening tools and the management tools that we have. We need to arm ourselves with the right tools to diagnose these patients. The ocular surface portal is something that would definitely add significant value to the diagnostic armamentarium that we currently have, and this is something which is freely accessible at this point in time. We also need to look for causes beyond dry eye disease, especially the mimics. We will not be able to do away completely with the unhappy 2020 patients related to DED, because we know that LVC as a procedure definitely causes dry eye disease. But the idea is to see how we could reduce the number of these patients and prime them and counsel them, so that we are able to address these problems in a better way in these patients. So the ocular surface portal and the application is something which helps us bridge the gap as far as this unmet need is concerned with respect to evaluating these patients, streamlining our evaluation, having a uniform reporting, because I myself might not write the same thing in my notes today versus another day. So leave alone being able to compare what I write versus what somebody else in this room writes. So there is a need for uniform reporting, and ultimately this will help us to improve the quality of patient care. And if we do this on a large scale in multiple centers, we would have unprecedented multicentric data in a field where we do not have any data at all today as far as dry eye disease is concerned in our country. I would like to end by thanking our technology partner who helped us develop this unique dry eye application, and the whole team back home at Shankar Nethralaya. We offer a 3-month short-term ocular surface fellowship for those who have completed their cornea fellowship, and anybody interested could definitely apply for the same. And with this, I come to the end of this oration, and I would like to thank everyone again for having given me this opportunity, and all of you for a very patient hearing. Thank you.
Thank you. Thank you, Dr. Geeta. I think such a wonderful flow of work from simple examination to the software and then the cases. I think it's a very fitting oration. Thank you.
Thank you.
Excellent.
Thank
Gaurav,
you.
please, Dr. Gaurav.
So with this, we come to the UKSOS International Gold Medal for 2023. And I would request Dr. Gaurav Luthra to please stay back. And Dr. Satanshu Mathur sir and Dr. Sanjeev Mittal sir is there. Okay. Okay. I'll request Dr. Tyagmurti Sharma sir and Dr. Rajendra Trishal sir to please come and take the dais as chairpersons, please. So can we have Dr. Rupesh Agarwal, who's joining us live from Singapore? Can we have him PIP picture in picture there in the Zoom? He's already there. Hi Rupesh, good morning. How are you?
Hi Saurabh, I'm good. How are you?
So it's a pleasure to have you once again back live. We enjoyed seeing you and virtually yesterday evening. And now it's a pleasure for me to introduce Dr. Rupesh Agarwal once again. It's a pleasure and honor for us to have you as our International Gold Medal awardee. Very well deserved. Could you please pull up his CV also, and could you, So Associate Professor Rupesh Agarwal is Senior Consultant Ophthalmologist in uveitis and General Ophthalmology. He is Head of Research at National Healthcare Group Eye Institute, Tan Tock Seng Hospital, Chairperson of the Research Talent Development Committee, Tan Tock Seng Hospital, Singapore. He is Domain Lead, Recruitment and Development Academy of Clinical Scientist and Innovator. He is Co-Head Ocular Infections and Antimicrobial, Singapore Eye Research Institute. Associate Professor Lee Kong Chian, School of Medicine, Nanyang Technological University. Associate Professor Duke NUS Medical School, Senior Clinical Lecturer, Yong Lu Lin School of Medicine, Honorary Consultant, Moorfields Eye Hospital, London. His research interests includes artificial intelligence, ocular inflammation, HIV and ocular infections, ocular TB, drug delivery, biomarkers, ophthalmic trauma, blood flow and biophysics. So you can just see his profile, his interests. And his major interests are mentoring clinicians in their research journey. He is a lead investigator for several of these big studies, some of which Dr. Vishali Gupta mentioned yesterday, the COTS study for ocular TB, Proton, iGates, CVI Grade Coin, and OSS. More than 350 publications, a prolific researcher. So it's a pleasure to have you deliver your UKSOS International Gold Medal for Excellence in Ophthalmology 2023 at Uttara Eyecon 2023. Dr. Rupesh, please.
Thank you, my dear friend Saurabh, and thank you once again for having me here. And my apologies at the outset for not present in. Let me put up. You can see my screen. Yes.
We can see your screen.
Yeah, I'll make the full screen. Okay, thank you. So at the outset, I'd like to thank and accept this award on behalf of all my patients who were part of this journey, and on behalf of my team who has put together a lot of efforts, and then also on behalf of my co-investigators and collaborators and mentors, and without whom the success would not have been possible. And of course, it is, as Dr. Rohit Sethi has said, it's a collaboration with the engineers and all. And above all, my family for giving me the time and opportunity to work on this project. So with that, I like to present about my journey with the choroid, and has been set up the tone for this conference is about the journey less traveled, or the road less traveled. So choroid is one of the things which I thought when I started with this journey in 2012, that this is one area of ophthalmology which is less traveled. And as Dr. Geeta, once again my colleague, also mentioned about the dry eye, which is again something which not many people have done work, and she has done a phenomenal work on setting up the dry eye portal, which is I think super amazing. So along with the same line, what we wanted to kind of present and think through is on the choroid. Why, first of all, why we need to understand about the choroid in terms of its anatomy and physiology. What are the importance of choroid when we talk about the ocular or the systemic health? And what are the ways we image the choroid? And the term which you've been hearing from me for past many years at different meetings is about the choroidal vascularity index and how far it has come up. But before we get into this choroid as such, I wanted to quote about the famous quote from Thomas Edison was about our greatest weakness lies in giving up. And the most certain way to succeed is always to try just one more time. And as was mentioned by Dr. Rohit Shetty in his innovation talk and about by Dr. Rao also yesterday, about we coming out of the comfort zone, giving up our best and giving up this thing to innovate and to come up was my inspiration. I thought, okay, let's try in something which not many people have done and see how we can move the field of science and move India and our community forward through this innovation. Is that clear? Can you hear? Okay. Yeah. So just to get into the basics of the choroid, as we do know that choroid is the structure behind the retina at the back of the eye, but also to go back to our anatomy, choroid is a vascular or a spongy structure comprised of vessels and the stroma. And within the vessels, there are three different types of vessels: choriocapillaries, sacculars layers, the halar layer, and the stromal tissue. So we have two types of tissues within that. This is again a diagrammatic representation of blood flow and the histopathology of the choroid. But it is, if not many people are aware, this is the most vascular tissues in the body. The thermoregulation is done by the retina, and it is rich in pigment producing melanocytes which absorb the light, and it has been quoted to have highest blood flow in the body on a per tissue weight basis, innervated by a lot of autonomic nerve fibers and ability to expand or contract based on various physiological conditions. So this was our basic understanding when I started the work on the choroid, and we thought of looking into the choroid about as a biomarker which can play a role in various physiological as well as the pathological process, and how does it help us in understanding the pathophysiology and the mechanism of various diseases. So this is what, with the advent of OCT, we started imaging the choroid, and there was something which was looked behind it. This is still not the best picture of the choroid which we see on the modern day OCT machines. But this one was segmented by various different researchers across the world, where they were trying to identify the area of choroid and trying to identify the vessels within that. So this is just to give you a glimpse of what can be there within the choroid when we talk about the choroid as such. So we started our research, and that is again, once again, a request and an appeal and a suggestion to the junior residents, if they are sitting in the audience, is to start with a literature review. And this was a literature review which we started by saying that, okay, the choroidal thickness and how does it impact the systemic health, and we published this in Survey of Ophthalmology by probing into the various conditions of the health and the eye which can affect the choroid in general, and then we went on to understand why does the choroid is affected. But this was the first paper, and which has received quite a good number of citations till date. When we did this paper, we looked into the various imaging modality, and interestingly, way back in 2002, 2003, when I was at Shankar Netralaya, my thesis with Dr. Dhanashree Ratra was on Indocyanine green angiography and looking into the choroid and uveitis. And I never knew that I will be again going into the choroid when I'm in Singapore, and I'll be probing that from an OCT biomarker point of view. So I started getting interested in the OCT, and one of my first early grant was on writing up on the choroidal thickness in uveitis using the OCT tool as a biomarker, and there we got to know that there are various tools which we can use for that. But from there, we went deeper. We wanted to understand and probe what can affect the thickness of the choroid. There were many papers till 2013 saying about choroidal thickness can be affected in this condition, this conditions, and multiple other conditions, but not many papers were there about understanding about the mechanisms of why choroid is getting affected. And these were some of the early diagrams, early pictures which we try to do using this. But before we understand how these pictures were derived and how this term was derived, let's look into the journey of the choroidal vascularity index. And for us, it is very important for us to understand the structure and the complexities of the choroid. So this is an animated diagram which will make you understand what happens within the spongy structure of the choroid. So this is the normal choroidal structure with the larger choroidal vessels and the smaller choriocapillaries, and in between there is a stroma. So when there is, we call it as an increase in CVI, so there can be increase in the number of vascular channels, or there can be increase in this diameter of the vascular channel. So these are the two possibilities why there can be increase in the vascularity in the choroid when we say that there is an increase in the vascularity or increase in the CVI. Contrary, there can be decrease in the CVI, which can happen because of the decrease in the number of the channels or decrease in the diameter of or loss of choriocapillaries or the larger vessel. So either way, we can have a decrease in the CVI. So this animated diagrams was through my friend, once again through my collaboration with Andres Roselet from Argentina. And then we went and we thought we should probe into that. When we were working on this concept of looking to the choroid, I saw a very interesting paper in American Journal of Ophthalmology by Professor Sakamoto group in 2015 by his student Sonata. And there we looked into their index and then the way they compute that. And that is the beginning of this. So sometimes a letter to editor can be the beginning of something which can be a major discovery or major science in this thing. So here, if you can see the highlighted portion, we wrote to the letter to editor and to the authors of this, and this was written in a very constructive way that we would like to suggest an alternative measurement that can potentially be more stable and a reliable marker of changes in the choroid. By calculating the proportion of luminal area to the cross-sectional area of the choroid, we term this index as choroidal vascularity index. So this was the beginning of this term called as CVI, when in August 2015, this letter was published in EJO, and this was written in a very constructive way rather than criticizing someone's hard work of the research. And that's where Professor Sakamoto and we started working together. And one of the initial papers was on the uveitis when I started working with Pierre Skin and Adnan Tufil at Moorfields Eye Hospital. But subsequently, there were a series of publications related to choroid and choroidal vascularity index in various different journals with various different collaborators across India, across Singapore, and across the world. More than 300 papers were published. Definitely not all of these are mine, but many of these were inspired through the same word of CVI. And you can see this index of CVI with more than 30 conditions. Again, credit goes to my fellow William, who drawn this interesting network diagram about how the choroidal vascularity index was published from 2016, inspiring not just the same discipline, but many different collaborators and co-authors across the island and across the world about this condition. So what it has led us to is with the central theme of choroidal vascularity index, not just in the ocular disease, but also in the systemic disease, started with the uveitis, then we went on to probe the hereditary retinal dystrophy with Dr. Dhanasri Ratra and a team there, with macular degeneration, again with Jay Chablani and multiple other collaborators, including Jenny from SNEC, glaucoma with my colleagues at SNEC and SERI, polychoroidal choroidal vasculopathy. Again, we are looking with Narayan Netralay on the MACTEL of this, retinopathy of prematurity with Europe conditions, the myopia, a large study we did with Hong Kong choroidal central serous chorioretinopathy, and multiple other neurological and systemic conditions which we are trying to investigate to see what is happening in the choroid. So once again, I like to reiterate that choroidal vascularity index can be a very sensitive marker, but not necessarily a specific marker. As you can see, it's being affected in multiple diseases there. Now, let's get into the technical part of it so that to understand the engineering concept behind it and the journey of the choroidal vascularity. We have seen the practical applications where all this tool has been applied, but we also want to understand how through repeated attempts and repeated iterations, how we have improved this tool. So the journey started with the manual tool, which was based on a course. I did it in London when I was doing my fellowship there. I learned on ImageJ. Then I thought, okay, why don't I apply this ImageJ technique? And that is where we started using this. So this is the ImageJ portal. You import the image into this. And after that, a lot of people have started using it, and we managed to teach this tool to a lot of my colleagues. And then you select an ROI, which is region of interest. Unfortunately, not return on investment for some of the people who will be interested in that ROI. But ours was always the return on region of interest. We started using a polygon tool. So this was way back in 2014. Now, a lot of people will say, oh, why you not gone with the AI? But I think you have to start from somewhere. We started with a very simple technique, and I did quite a lot of work, and with plenty of students and research assistants and all, we managed to do quite a number of segmentations, and you can see the segmentation was done. After that, this was added to this tool of ROI. Once it was added, then there was a binarization steps wherein different steps were to be carried out. And this is all through a lot of iterations, we practiced and all, and then we applied the knee black technique, which was able to give us the exact bannerization, and then we calculated the CVI based on it. So once again, a very simple way, and you can use it across a different discipline, and this is what we learned from this attempt at it. And then we published this in the UGAT is the technique, the field which I practice, and this was from the data set from Pierre Steen and Carlos Provicio, and we did it on that. So we started doing it, and quite a number of papers using this technique were published, but we thought we want to move forward. And as Dr. Geeta has very rightly pointed out in her portal that if you get multi-center people and multiple people to use your portal, that will not only just validate, but also will extend the use of it. Therefore, we came up with this term called as a COIN or a CVI grid. And CVI grid was set up as a global consortium to look into the choroidal vascularity index. And we launched this portal of cvigrid.org. And it was an online portal with multiple researchers across the world with multiple institutes to look into the choroidal vascularity index. And with that, we launched our first protocol A, which was embedded on this web-based portal, not on the image J. You go into this, an active member can log into the grid part of the portal. And in the grid, you can upload your program or you can upload your proposal. Once the proposal is uploaded, you can then identify which type of machine and which type of images you want to upload once all the images are uploaded. So this is once again, a lot of people were using it till date, and there's a lot of people are still using it, including dear friend Saurabh also. We worked with him on quite a number of projects, and then you can do this protocol A, which was automated tracing. But in this, once again, you need to be very critical about your work. We were not very happy with this protocol A, and then I aborted this protocol A because it was giving a lot of errors. And I was not happy that this was the first development in 2017 when we thought we cracked it and we were able to do a fully automated segmentation of the choroid, but unfortunately it was not so. Then we still remained with the protocols which were semi-automated. So the protocol B was designed, and again it was inspired by some of the trials which they do, protocol A, protocol B, protocol C. So this was the another segmentation tool or technique which we wanted to use it. And you can see in this technique, once again, the project is uploaded. And you can identify one of the projects, multiple collaborations of the project ongoing here. And once you go into the project, you can look into a particular image. We'll just go into one of the image and then see what is happening here. So once the image is uploaded, what will happen here is the two circles will come up. Now, why these two circles? If you see the choroid is in the form of an arc. And I will just like to extend what Dr. Rohit said is you just don't have to just give the things to the engineers, but also work very closely with the engineers. So my thing is every Monday morning and every Friday morning, I sit with the engineers for at least 2 hours in a week to discuss with them what they have developed and iterate and come up with a new tool. And this is based on those two circles, and then dividing that into arc, we were able to get a reasonable tool for understanding about the choroid, and then there were fine-tuning which is still required. So this was slightly faster, and then we kind of adjusted it to get the values, which was choroidal vascularity in different zones in the choroid. So we segmented the choroid into central choroid, the lateral, the temporal choroid, and the nasal choroid to get us the different. So you can see the field is moving forward, but then the data access issue, the privacy issues started coming into the picture, and my own hospital will not allow the images to be uploaded onto the cloud. Now, what do we do with that? How do we overcome this challenge? So we created this offline portal called as GoCoin. And in the GoCoin, it is an offline version of the coin. And you don't have to necessarily go to the cloud, and then you can still do it. So I'll just show you very quickly how the offline version looks like. And this is where protocol C came into the picture. And this is about the protocol C, which will show the offline person. So this is local host. This is not running on the cloud, and we managed to install one instance of this at Narayan Nethralaya as well during my last visit to NN. And and in this visit, in this protocol, you can see the same thing is there, but certain things which we want to download from capabilities of AWS, which was available for earlier protocol B and protocol A, but because this was an offline portal, we can't use the entire capabilities of AWS, which is Amazon Web Services. We developed a new technique by identifying the vitreous retinal interface, which we call it as the zone 1. Then we segmented using the parallel lines because we understand the choroidal layers and the retinal layers are parallel to that line. And then we created those 4 segmentation lines, and this one was done again very faster. And after that, we segmented it into different zones of the choroid. so that we can get exactly the different choroid and the same value started coming up. Only the technique of segmentation was different, and this also we validated in quite a number of papers. But this is a completely offline version where you don't have to upload your images, and while you're sitting in your clinic, you can conduct it in real time when a patient is there sitting next to you. So that was the idea. With that, we put together everything into interesting publication in PRER, which is a comprehensive overview of the application of CVI. So what next? So in the next 5 minutes, I'll just tell you what's there in horizon for us and where is this portal going to go. You have seen the journey from image A to a semi-automated portal onto the CVI grid, and then from CVI grid to coin. And then from coin, you have seen us moving towards this Go coin. And from Go coin, what next? Where do we want to move forward? So you can see the automated segmentation is still the need, because we are getting tons of images every day, and collaboration thing is there. And with the AI, we should not be lagging behind. And we wanted to go again and have an next attempt. And that's where I say the failure should not let you down, and we probably should think again. We thought about going for an automated segmentation using Vision Transformer, and we train a VIT model, and this is the work in progress, and I haven't included on the coin portal, but I promise you it will be coming up soon, probably by next VRSI, where everyone can start using it, and it will be an open access portal where everyone like an image can use it without any charges being there. And this is a near perfect segmentation, which we are getting it from our VIT model, and the ROI which will come up will be exactly as per the choroids in various scans and all. And hopefully, and this is trained on some of the images which I have, not really based on the collaborators' images, and which was trained on a very limited number of images. And there will be an offline version, I hope, for this. We are still struggling to put up an offline version. Currently, their online version is available, but I'm trying to validate it before I roll it out to all the collaborators and colleagues there. So this is not going to stop. At the same time, my colleagues at Singapore Eye Research Institute and my very dear colleague, Professor Leopold, and his team has put together a new world of imaging, which is coming up in a big way. It's something called as a GAN imaging, and which some of you must be aware about, generalized adversarial network. What do you mean by GAN imaging? It is like a fake currency notes. You get the fake images into the system, and we, rather their team, we are also developing. They have developed this. These are all fake OCT images. These are not the real images. So these are the artificial images, synthetic data, synthetic images, and then they train this model also to generate the choroidal vascularity based on this particular set of data. This data is not coming from the real patient. It is both entire artificial data, and they were able to compute choroidal thickness, choroidal area, choroidal volume, and choroidal vascularity based on this 146 eye pairs of artificial data images for the choroid, and they were able to generate. So I think this is something which you will come see more and more. The company whom I was interacting with called as MD Clone, they are looking into the synthetic data from your data. There is this work which is going on is the synthetic images, and something which will probably help us moving forward as AI is getting more and more data hungry. So we probably have to go and create something like that. But eventually, Dr. Geeta very rightly said about putting the dry eye portal to the use in the clinic. Where do we want CVI to move forward? What is the ultimate goal of developing all this thing? Yes, like everyone else, we want to use this this particular index to be in the clinical practice, and this is our vision. This is a OCT technician taking an OCT image. I really want to see this CVI coming there into this OCT machine. So this is not live. This is a machine from Topcon, but this is superimposed on this. This is the vision which is superimposed on this. And even this cannot be this patient image, because this is an image coming from a monkey eye. We cannot have that this patient image I am doing any kind of a PDPA violence. Yeah, so this is a monkey eye image which is imported onto this. But we want, when a report is generated, a CVI report is generated as an integrated tool for decision making and all. With that, once again, I would like to thank and welcome everyone to be part of this journey. And we started with CVI, and it has become COIN. And COIN has few more features of vitreous haze, retinal vascularity index, iris vascularity index, and there will be more and more tools to come up. But very happy to collaborate with everyone and learn from all of you. Once again, Saurabh, Gaurav, and everyone there, please, thank you very much for this honor and award. Thank you.
Thank you so much, Rupesh. Rupesh, that was so enlightening and mesmerizing, I should say, and especially for those of us who are into imaging of the retina and the choroid. it's very fascinating to see all those images and what magic you can spin with that. And I had just had a small question or a comment that for me, the choroidal scleral interface is the problem, I think, which most of us faced initially when we, went on to the journey of choroidal imaging. So how did you overcome that problem where you cannot really identify the junction between the choroid and the sclera?
So that's still a problem, and that is where I think AI can be quite useful. So we are training the model to help us identify, but I'll still go back to the basics and say that the basic solution should come from the OCT machines and the image acquisition. A lot of us believe and a lot of us want to do image analysis, but I think if your imaging is not good, I think what you're going to get out of it is erroneous and not correct. So with SSOCT, swept source OCT, the choroid scleral interface has started coming up well. So that has taken care of a problem to a certain extent. And after that, the techniques of segmentation has improved, and particularly the AI things with lots of images onto the cloud and all. People have developed good models of segmenting that. So I think these two have come up in a big way. But I think there are more machines coming up with more better segmentation. People are even coming up with imaging the sclera. So once they are able to image the sclera, then of course this choroidal thing will be seen more clearly. Yeah.
Thank you. Thank you so much, Rupesh, and looking forward to meeting you hopefully physically next year, in our meeting, and having one-to-one interaction physically, but it was almost as good as being there with you right now in Singapore. So thank you so much for joining in the morning and yesterday evening too, and heartiest congratulations once again for the award. And we really are honored by your virtual presence.
Thank you.
Thank you so much, Rupesh. Thank you. With this, we come to the next session, which is the session on cataract and refractive surgery. And I would request Dr. Rohit Shetty is about to come, I think, and Dr. Kumar Doctor is here. No. I request Dr. Rajesh Sinha if you can, please, kind of be on the panel here, and because I think people will be, kind of joining, because we are actually 2 minutes before time, so we hope to have people here. And Dr. Vinod Arora, sir, if you can also please come.
We've got another 2 minutes to start this session. Let's wait for another 2 minutes. So welcome to this interesting session, cataract and refractive surgery. So how many of you are refractive surgeon here? I think all of you are refractive surgeon, because you're doing cataract surgery, that's a refractive surgery. And that's the biggest refractive surgery than any surgery else, smile, LASIK, whatever you call, but cataract is now a biggest refractive surgery. So you all are refractive surgeon that way, if you're not doing LASIK or anything. So we are going to start with the session. I'll request Dr. Rohit Shetty, Dr. P.K. Pandey, Dr. Ashok Bajaj, Dr. Kumar Doctor, Dr. Rajendra Prasad, Dr. Abha Gaur, Gaurav Luthra. I think they'll be joining very soon. And without wasting time, we'll move on to our presentation. And first presentation is by Dr. Rajesh Sinha. He's going to speak phakic IOL, issues resolved and unresolved. I think this is one of the refractive surgery where you don't require very expensive equipments
Dr. Rohit has come, so he can start.
Dr. Rohit is here. Rohit, please join us. Okay, Rajesh, you start and Dr. Rohit will join us.
Okay.
Dr. Rohit here. So phakic IOL is the surgery where everybody can do it without any special equipments like excimer laser or femtolasic. So this is not involving much of the cost. Only thing you have to learn it properly. And then it's become one of the very rewarding refractive surgery. Dr. Rajesh, please.
Thank you, sir. I would like to thank Dr. Saurav Luthra, Dr. Gaurav Luthra, and the whole team of Uttara Eyecon for having me here in this wonderful meeting at a wonderful place. I'll be talking about the issues which are related to ICL. The major issues will be it's a lens which is being put in the sulcus for correction of refractive error. So one issue can be inappropriate refractive correction, but these days with the current generation formulae and all these technologies, it's not at all an issue, and the refractive correction is mostly appropriate and accurate. In the initial generations of phakic implants, ICLs, there was slightly more chance of cataract, but with current generation of central aqua port, what happens that the cataract as well as the deposits of viscoelastic on the capsule is also minimal, because you can aspirate the whole of viscoelastic even from under the vault. So that is also mostly gone unless the vault is too low, wherein it can cause cataract with time. Glaucoma, most of the times now, because of the central aqua port, it takes care of the glaucoma as well. Only issue is that we don't hardly have any retained viscoelastic. We hardly have the risk of pupillary block. The only thing is that if somebody is a steroid responder, then if the patient is being given steroid for a long period, one may develop, so that we have to be careful. The only issue that is really pertinent and really which has not been completely sorted out is unacceptable vault. So normal vault is 250 to 750 microns. A little bit lesser and a little bit more in the current generation of ICL is still acceptable, something like 200 to 1000 in the current model. But anything less than 200 and more than 1000 is not acceptable. The reason is this, that if the vault is low or high, it can cause complications. If the vault is too low, then with time the vault will further become low, there can be lens touch and it can cause cataract. A low vault can also cause uveitis because a large area of the uveal tissue is in touch. Because of the low vault, it is in touch with the ICL, and with the movement of the pupil, there is pigment release, and that can result in uveitis as well, as shown in this particular case. If the vault is too high, then in that case, the peripheral chamber becomes shallow, there can be risk of PAS, etc., and can cause glaucoma. So the question is, why this vault surprise? Because we do all the measurements correctly, still we do have surprise. The reason is this, that we implant the phakic IOL based on white to white measurements, and it is placed in the sulcus. The size of the sulcus is 0.21 millimeter more peripheral on one side, that is 0.42 millimeter more than the white to white in the horizontal meridian. However, in reality, the sulcus to sulcus distance is variable in a given eye. At every axis, the relationship does not remain the same, and that's why we do get surprises. We performed a study comparing repeatability in white to white measurement in comparison with sulcus diameter for assessment of size of ICL. We used OpScan 2, eye trace, lens star, IOL master, digital calipers, and the sulcus to sulcus dimension was measured with UBM. We found out that the repeatability was best with IOL master. The coefficient of repeatability, as you can see here, is 0.88. It was best with IOL master. The difference between IOL master and the standard digital caliper was 0.364, and it was well correlated. We found out that the vault decreased with an average of 0.101 millimeter from 1 month post-op to 1 year post-op. The initial 6 months, the vault reduction was slightly more, and after 6 months, it sort of stabilized and the reduction was very minimal. We found out that 80% of the eyes showed the same size as that calculated with digital caliper. But UBM estimated better ICL size compared to digital caliper in 7% of cases. So in 80% of cases, we had a very correct ICL size, in 87% with the UBM. The reason why I would say is that there is some degree of subjectivity in measurement of UBM as well. It also depends on the iris insertion, whether it's a little posterior or a little anterior, how much sulcus is visible, because you place the cursor manually only. But still, if we incorporate everything together, like sulcus to sulcus diameter, white to white, and ACD, then perhaps we may be in a position to give slightly better result. So if the vault is too low, then we have to explant and replace with one size bigger. If the vault is high, then we may wait for a month or a couple of months and then see. If the vault is still very high, more than 1200 microns, etc., if it's toric, then we have to replace with one size smaller, and if it's spherical, we can rotate it. So this is a spherical phakic implant wherein the vault was 1270, and it remained like that for almost a month. So we thought that it's time to rotate it. It's a spherical lens. For rotation, one thing that we should be careful is that we should inject a little bit of viscoelastic at the edge. The pupil should be well dilated, and the viscoelastic should be injected at the edge of the ICL, so that part of it goes underneath, part of it is above, so that you create a cushion over the zonules while rotating. And once you have done it, you rotate and you see that the vault reduces significantly. This is the pre-op picture. The vault was 1270, and the post-op it was 760. So it rotated, it reduced quite significantly in this particular case. There will be some reduction which will be variable, but still there will be definite reduction. If the vault is too low, in that case we can do an ICL exchange. So as you can see here, the vault is too low. The intraoperative OCT is showing that the ICL is almost touching the crystalline lens. In such a case, again, when you are explanting, you have to have a pupil well dilated, inject some viscoelastic at the edge so that part of it goes behind, and then you inject more viscoelastic behind the ICL so that it lifts up a little bit with the force of viscoelastic only, and then you can use your instrument to bring it anteriorly. And with hand and, I'll just go back. And with using two hands, two instruments, you can just hold on one side of the foot plate, not in the middle, on one side, and then take it out. And then, of course, place another ICL of a size bigger. So in conclusion, the correct ICL sizing is something which is still a little bit of concern. There are multiple methods. Some prediction formula has also been described. But I guess a little bit more work is needed in order to get the most accurate size of ICL. Thank you very much.
Excellent. Dr. Adesh, I was wondering, I think the white to white is the gray area whatsoever. We are putting the lens in the sulcus and measuring the white to white. It may not correlate always.
Yeah.
So UBM gives a better view, or?
Yes, sir. That's what I showed in the study that we had done, that in 80% of cases with the digital caliper, we could get appropriate size of ICL. Using the UBM STS, sulcus to sulcus dimension, we could get in 87% of cases. But I guess maybe what we felt was that when we do UBM, we place the cursor manually only. So that is why what happens that if the insertion of iris is a little anterior or a little posterior, then there can be variability in that. Something, some automated system, if it comes wherein it reflects from the sulcus, and then we get the accurate STS, maybe that will give us even better accuracy as far as sizing is concerned.
Rajesh, we actually did studies with 3 different UBMs, and we found an inter-user variability, like, inter-observer.
Absolutely.
So we were trying to do between 2 different people who are quite adept at, using the B-scan in our hospital. And we found that there was so much variation.
Huge variation with the UBM. Yeah.
And then, I think the only one, maybe Rohit will know about this, that Dan uses that high resolution UBM, what's it called? Artemis. Now, Artemis apparently, and Dan has come out with a nomogram for sizing, which is available online also, and I think it's proprietary. But he's come out with it, and apparently that thing, they've been able to get more objectivity. So that's probably the only one, but I'm still not sure, and it's supposed to be horribly expensive. I don't know, maybe 1 crore or something. It's not even commercially available. So what we've been doing at our place is we are now doing a study on anti-segment OCT for the lens rise and the scleral spur to scleral spur studies. And we are using the NK formula, which is basically a published formula. And and there's a lasso formula also, which utilizes the crystalline lens rise and the scleral spur to scleral spur. I think it'll be worthwhile if somebody has UBM, like you guys have UBM and you have ASOCT, if you can do a study on checking, rather than white to white with sulcus to sulcus, if you could study spur to spur with correlation with sulcus to sulcus size. And if we find much better correlation, we may be in a better situation, because UBM will not be possible for everybody to have, but ASOCT is very easy for, and maybe Rohit's place can do this study and tell us, because you'll have both UBM and ASOCT, and you have all the good ASOCTs, MS39. You guys could see whether there's repeatability or a consistency between spur to spur and sulcus to sulcus measurements. That would help us a lot.
One is that. The other thing which is we just published in AGO, that's going to be a very strong paper for a lot of ICL, is not about ICL. When you have a corneal diameter which is correlating to your astigmatic cylinders, the areas where you have a cylindrical correlations, we have a different diameter and different white to white. That means that your white to white measurement is dependent heavily on the axis of cylinder and the white to white in that area. That means your white to white gross, so that companies now, after we bought the paper, AGO was so excited about it, even 2 months ahead of print they put it up, and now we're getting companies, suddenly everybody wants to incorporate it in their software, that your axis of cornea and your white to white totally differs. So now that is where Pentacam wants to put that into their software now.
Yeah. First of all, Rajesh, excellent presentation. Somehow I tend to disagree, because we have UBM and I do huge number of phakic lenses. I have never been able to hit the nail on the head with the UBM, because even if I do the same measurement again, I do not get the same value, leave alone different people doing that, number one. 3 years ago, we were talking about, remember Rohit, one of the sessions I did on mastering finer nuances of phakic lenses, where I mentioned if I am having a high astigmatism, I do the vertical white to white and horizontal, and then based on that, I do the sizing of the optic of my lens. So the reason was, that's how we were able to get away with very huge discrepancies with white to white or pupil sizes and large optical sizes, because it is very important to know the corneal diameter. So we do vertical corneal diameter and horizontal corneal diameter whenever there is more than 2 diopters of astigmatism, and the fine tuning of the lens, because we all agree that we are just measuring 0 to 180, but the lens is approximately 6 mm wide, so it's also hitting on the edges of that globe, but you're just measuring 1 diameter. Suppose there's a huge astigmatism, you will have an irregular wall. There would be 2 haptics which would be pushed more. So when we noticed that on our AOCT, that there were some areas of the lenses which were rising higher, that's where I came with this idea that you do a vertical. And I think that's exactly what Rohit's saying. Knowing the corneal diameter, especially if it's a high astigmatism, makes a huge lot of difference.
And you can do it in your Pentacam. You go back to the raw data, you check that raw data images, you see the axis of your cylinder, and it will give you the white to white of that. So that means you have to, if you're putting that cylinder, you have to look at that white to white, not the horizontal white to white, because the horizontal will be different from the axis of I think. And you can start tomorrow itself. I'll send you that paper. It's just come online. Just remind me. I'll send it.
I mean, we should do on the white to white on the axis of.
Exactly, sir. Because we found that the axis of your thing is completely different from your axis of horizontal.
But Rohit, you're implanting the ICL in the horizontal anyway. Even if, suppose, for example, at my astigmatism all at 90, and I decide to measure that, but I'm implanting my ICL still in the 180.
But if you are using that to calculate your right sizing, and it might help you, sir.
Yeah, Gaurav, you have a point there, but what Rohit is saying is 100% true. Because, we are thinking of an ICL as a linear object. It is not. It's 6 mm wide. So whenever you rotate it, there are 2 poles which are not bang on the line, and we caught it Because, you know, we were having an irregular wall. In the center, the wall would be different and some part would be higher. That's when we got thinking what's going wrong, and we found that the diameter was different in different axes.
So maybe one day we'll have a device which will give us 360 degrees sulcus measurements, and then that will be the day.
And the most excited
Yeah.
people about this paper were the medic companies. So every company has been writing to us, can you set the print? Because now suddenly they realize that white to white is not the horizontal, you have to have. So now I think in shortly they will just incorporate this paper.
Yeah. Another reason why the vault has been unpredictable, because there was a recent study which showed that in 80% of eyes, the footplate of the ICL is not in the sulcus. It's not both sides are in the sulcus. One in the sulcus, one on the ciliary body, something like that.
You should look at this and see if you can recalculate.
Yeah, we'll do that.
I think both of you need to work harder
Yeah.
on this.
Yeah.
You are fully equipped to work on these things. Okay, so we'll go on to this keynote address, which is going to be delivered by Professor Rohit Shetty, and it's very interesting. Phantom symptoms and explanations. So Rohit, please go ahead.
Thank you, Gaurav sir. Thank you, Dr. Vinod sir, and the entire society here. My talk is on about phantom symptoms and its explanation. And I'll cover 2 talks, so I'll finish with the time allocated for me for these 2 talks. And the second one is unusual cases. Both belongs to the same level of same line. So what are the phantom symptoms? Whether you're doing a cataract or refractive surgeons, my eye hurt when I clean my eyes, my excessive watering, this takes up a big chunk of your practice. It waters when I see the bright lights. They're called phantoms because it's like ghost who walks. You don't see, but it exists. According to the patient, it exists a lot. And there's all unbearable pains, whether my yoga will help me, whether meditation or Ayurveda will help me, and a lot of those things. So one of my areas of work, the last close to a decade, has been it's not a physical center, it's a virtual center. Means it exists, but exists in multiple dimensions of research of unknown. Basically everything which is unknown, which we claim as, which takes a lot of your unwanted time. First, let me start with the phantoms of healing and why does healing differ. The healings differ because there's a synchronous way of how your immunity is balancing with your health. And you need immune system because immune system keeps you healthy, it's safe. But when your immunity is there, but it exists in an over-exaggerated response, that's when work done by Dr. Geeta and entire ocular surface people says that is the balance, that's a tipping balance. When it's synchronous, you get a ballet or one of these beautiful ice skating we all enjoy. But when it's not, that becomes a challenge. So how do you evaluate the immune system? We have to isolate the culprit because the whole immune system is not at fault. It's just that few of them. And we have to pick them up, those who are that few. And what started as a very small journey of people and then became very big in group today. And today when we speak about immune system, we are able to look at it from your tears, vitreous, aqueous, or whatever we can get from you. And that became what we call it as a point of care kit. And that's going to be the biggest disruptor in the way we evaluate our ocular system from tears to all parts of it. At this point of time, we are limited with the kit because it has only this many wells which can identify it. It's microfluidic. It has an immune fluorescence reader. You can pick it up from your tears, and we are able to develop these questions sometimes like these, like an ophthalmologist. A lot of ophthalmologists themselves suffer which we can't treat, like burning sensation, and you can look at the evaluation of it. What is interesting is it picks up the most important culprit here in the immune system. What we normally do is, without this knowledge, people treat him with steroids, which sometimes goes to gallons of it, and we don't get a right approach because we have no idea who is at fault. In this non-targeted approach, you virtually kill all the other ones which are in black, which you don't need to kill. You're actually killing somebody just because you don't know who is the culprit. That's what we see happening in the wars today. The people, the collateral part of war is the children's die. They don't need to. They don't even know what war is. And look at the molecule which was responsible in this doctor was ICAM-1, intracellular adhesion molecule. So what we did was, these were the normal and abnormal values what we have. It's just like your blood report today. So once we look into this aspect, we know that there are medications which are available. There are medications which is going to come. We were doing this trial for liftigrast. I think many patients are doing. And the liftigrast, which is Zedra, works on this molecule, which is T cell. Basically, it's a molecule which stops the adhesion of the T cell to LFA, a molecule, LFA antigen. So when you have this, it's blocked. So we know that this patient who has been, the ophthalmologist who's been using these kind of drops, which is not targeted, it's not going to work. Minute we started him on that, look what happened. He suddenly became, you just targeted the exact molecule which was creating. And we all the time will see new molecule comes, leftigrast comes, XY comes, but nobody understands that they're all made for a specific. The cyclosporin works on a band of IL-6, IL-2 and MMP9. It doesn't work that well on ICAM. So if you give him Restasis for the rest of his life, it's never going to work because it's not the band in it working. Exactly the same thing. You treat a gram-positive with a gram-negative drug, it will not work. It may work here and there, but it will not work. And that is why the biggest reason of a phantom symptoms is we are using non-specific medications on patients without understanding it. That is not the fault with us. It's just the fault that the science has not moved as forward as the pharmacology. The second thing is epithelial profiles. You look at these gland, these are your T cells. I used to always call it dendritic cells. This is my old presentation. A new study which says that these are T cells which you can actually study on your confocal microscopy. And when you see them, these are the work done by my team. I can see these are how the epithelial cells, these are your lifeline cells, these are your lysosomes. They are the cells which helps you to talk. They are your Wi-Fi's of your cells. And when you have the lysosomes missing, you have dendritic cells here, the nerves are not. And look at the epithelium. It's a surrogate marker of what is happening on your hidden thing. And the good cells have good epithelium, the bad cells have bad epithelial profiles with dendritic cells. Let's assume you do a SMILE or LASIK or any of these procedures. Within 3 months, you might get a 6x 20/20 with best of surgery. But look at the epithelial profile. The epithelial profile is completely messed up. This is like a big heap of epithelium out there. The nerves are not generated. The epithelium is under stress. And look at the lysosomes will still function. This is one of the reasons why healing is different in different people, is not because of your surgery, but because of your inherent status of it. And what does it happen? Imagine you do a surgery. We have to understand that a cylinder can also come from your epithelium. A 0.5 diopter of cylinder is coming from your epithelium, which kind of masks your toric IOLs, you mask your EDOF lenses, you mask your multifocal lenses. So, and there's a significant amount of coma. And who is causing coma? Not your lasers. The coma is coming from your epithelium. So, the most important thing is we also need to understand the collagen healing. And this is very interesting thing for Dr. Gaurav and Dr. Kumar and all the people who are doing SMILE surgeries. You are looking at SMILE surgeries, assuming that every surgery has the same collagen. And this is how a normal collagen should look, and this is how abnormal collagen is. The lighter blues means the collagen structures properties have weakened, and the darker blue means that it is. I have 2 talks, so 7 more minutes. And when you do any refractive surgery like a SMILE or a LASIK on them, what you do is your keratocytes gets minimally disturbed in SMILE, and your LASIK, it gets more hyper disturbed, means they become more myofibroblasts. So when you have these changes happening, when you do a SMILE in a non-forgiving eye, when you have a weaker collagen, you end up not having any scarring on the collagen. and you end up having more scar on your refractive surgery. That means LASIK is a very forgiving surgery. Forget about the biomechanics part of it. A smile, even if you have a 0.1% doubt and you do a smile, the cornea does not heal like LASIK. LASIK is scar. The exact scar you see, which you don't see clinically, is a scar you would see on a LASIK, which is like cross-linking. The same scar you see it on the cornea, even after 2 years, it's cross-linked eye. It's laser, it's burn. In smile, you don't get cross-link. That's one of the reasons when you see a post-LASIK ectasia, 99% chances your corneal topography is 99% normal. But you'll be wondering, where did I go? Even that 1% small miss you do on a smile, you will develop ectasia. You may say, I never had an ectasia, wait for 5 years. I have 4 ectasias in smile in 10 years. All 4, I have zero problem in my topography. It was a small borderline biomechanical change and you get this ectasias. So anybody planning smile, the first take home point is it's extra unforgiving compared to a LASIK. And this is what happens. When you do a LASIK, you create that scar. And the scar is good if it's controlled, like cross-linking scar. And minute you do any smile, you don't see a change. The intraocular pressure itself pushes it beyond it. And we have found that there are a lot of us have carried this gene called lysyl oxidase gene, and that gene is a major factor. This is a female doctor looking for a refractive surgery, and these are all very important to check. She has a very, very fine thing which you see here called microneuroma. If by chance I do a LASIK on her or a PRK I don't know, I touch this microneuroma, she will end up in a neuropathic pain for the rest of the life. If you see neuropathic pain in post-refractive eyes, 99% of the time, the neuropathic pain comes from people who have missed it. Now, let's see what happens here. It's a bulbous ending. That means the nerves don't have Schwann cells. What happens is there's an extra bulb there because of trauma or whatever, but they're quiet until unless you disturb them. You disturb them, they end up become a challenge. And this is how it looks on confocal. This is the corneal nerves. So in this patient, what did we do? If you do a surgery, there are enough publications on pain. So what we did was we went on smile, we went down. We went 140 microns down. When you go 140 microns down, you kind of bypass the corneal nerves. When you bypass the corneal nerves, the nerve had absolutely no change. It looked exactly the same. So you bypassed it so that you prevented it. Any other procedure on it, of course, you can do a ICL and other things, but in case you want to do it, this is how you bypass it. So the most important thing here is that even though you have a similar looking topographies and similar looking corneal thickness, you will have different types of collagen. And this is very important for all people doing lenticular extractions, that just because your topography looks normal, it doesn't mean you have different patterns of OBL. I am sure Dr. Gaurav may have seen more, but these patterns, minute you see a pattern, I'm sure the people out here would say, oh, I'll go back and adjust this energy. This is more energy. This is probably the optimal one. Here I put more laser spots. The first thing we have to understand is the laser is not hitting a tissue which you have a known properties. Every known tissue here has different properties. Let's look at these properties and look at this. Each of the collagen is different. They're all healthy collagen. They're not LASIK. This collagen is different, this is different, and this is different. Now, the weaker the collagen ends up with a much better dissection. The tougher the collagen, this moderate collagen is decent. Look at the one which is the worst collagen, you are struggling. And this is going to be a challenge, Dr. Gaurav and Dr. Kumar, when you're using machines with lower energies. Lower energies, lower spot size are meant for this collagen. If you have a collagen which is here, you will get those laser burns because you're using more burns for the collagen which you don't require. And for this, you will have to struggle because your lower the energy is not meant for such type of collagen. So that is one of the reasons to have a huge change in the way it works. I'll stop this presentation, take a few questions, and then
you can actually finish all three of your presentations. We can have discussion on this, and then you can go on to
yeah,
the next one.
because yeah.
So Kumar, can you please come here? You're supposed to be panelist in this session, so you can join us.
And to sum up on this particular thing, when you dissect it badly, when you have a tougher dissection, your keratocytes are angry. And your keratocytes angry, and they have different keratocytes, and that makes your vision getting slower. When you have a dissection which is angry, that means your keratocytes response is completely different.
In fact, Rohit, I'm quite identifying with what you're saying now, because we have this for no reason whatsoever. You know, in a particular patient, you'll have just the most amazing and easy dissection, and you know, you'll think that your I mean, everything came out perfectly, and then another patient, you know, it'll just be like so challenging to do it. So, you know, probably this makes sense.
This picture explains clearly, and most important thing is we are all moving towards low energy, sir.
Yes.
So when you move to low energy, like Elita, you're at 40 nanojoules. It works very well here. I've been telling every engineer, you're using energy like you're measuring it on a known system like wood. You know how the strength is, and you think it is not wood. They're all normal topographies.
Can I ask you, you have the same sitting on the same setting, 5 patients.
Exactly.
I experience the same.
And now what do? You go back to the laser. You are not looking at it from a biology. The biology is different, and we have done more than 700 odd patients with each matching. And this is a work done by my colleague, Dr. Pooja and Dr. Gairik, that, you know, it so matches to the biology that, you know, you don't have to go back to your machine. And when I spoke to you about a case, what happens is this is exactly what happens. Can you see that? The white spots are this. Because when your laser is hitting a collagen, that are myofibroblasts, they will disappear, but it will take at least 3 months for the patient to recover from poor to good vision, because your myofibroblast takes 6 months to become again a normal keratocytes.
So I want to ask you 2-3 core links, like you have the ocular hysteresis, you measure the strength of the cornea. So do you have a relation between that machine and your collagen structure, which you must have done?
Yes.
And then you go to the energy level?
Yes.
So do you have a link up of all this?
I don't have a rough nomogram, but there is one parameters on your corvis called SPA1. SPA1 is the first concavity of your cornea. That matches very well with your collagen. If your SPA1 is more than 124, you will get a very scattered OBL and a very tight dissection. In fact, I don't even offer smile to them, knowing if he's a very demanding patient, because he will have it. But if your SPA1 is between 90 to 110, it correlates very well to the finest dissection. So you don't go low on energy on a SPA1 with 120. Now companies want, after this work we showed, the companies want to link this energy to the biomechanics, because all biomechanical parameters will not tell you. You have to, of all the AI we did, it matches very well with the SPA1.
So theoretically, a strong collagen will need more energy?
The strong collagen will need more spot sizing. More spot sizing. You have to reduce the spot sizing. Now, if you have the spot sizing is 4:3, you have to reduce the spot size. So you have put more spots. More energy you put, the cumulative energy will be more, and you will actually burn the cornea. So you reduce the spot size and the track size, and you will get probably better results.
So the ultimate track would be this.
Exactly.
That you get information from corvis, you know your collagen, and then you decide the spot size, and then you have a smooth dissection.
That's
in every
exactly how, especially when we had Smile, we don't have to worry too much about it, because there was very little you could do. But all the new 3 machines, like what Bhupesh is doing, Elita and Etos were doing, they're all going down on energies. They're all at 60 to 70 nanojoules. Smile is at, we are looking at 120 nanojoules. You're coming half. So, but we are using the same collagen.
What about the 800? Does that energy?
800 is the same 120 nanojoules.
Okay.
So, but you can play with the spot sizing. That intraocular pressure created is less, so that your OBL, if you have more IOP rays, your collagen goes into a stage. So that's why the 800 is better, because of the speed is making the time of IOP less.
Also, quick question, like, that's very interesting that the smile eyes are, more, less forgiving, if you have
Yes.
situation. I was wondering that does that then make sense that, in those borderline, situations with smile where you would not normally even think about like doing anything, does Smile Extra actually help?
Absolutely, it works.
So because, we've been doing Smile Extra for these few indications after Sri Ganesh's group published that, that whole study. We have incorporated, like, we're not doing over -6 for sure, but over -8 if I have to go for some reason and ICL is not possible, I would do a Smile Extra, or even with the slightest like suspect on the bad maps or borderline corneas like 495, 490.
You should.
I'm doing a Smile Extra.
I do a lot of Smile Extras
Same
now.
here.
I've seen the collagen
Sometimes
changes.
50% of our patients are Smile Extra.
It
now.
really works well on the collagen. It makes the collagen more oriented, and it's different.
Right.
I just wanted
So I
to
think
ask
we
you
could
one.
go on with the next.
Just want to ask you one thing, that all those images were taken on brilliant microscopy, right?
No, sir. It's a polarization OCT, which we developed, which looks at collagen.
So I guess in clinical practice, large majority will not be able to use that. So if we can have some parameter which correlates with those
SPA1,
images.
sir. SPA1. That's what I said. SPA1 of more than 124 means your collagen is extremely under tight. It's a very good collagen. But good collagen means that when you're operating on a smile, you will have to put a little more extra. So you will have to play with your spot size, energy, and line distance. But thinner corneas, like 90 to 70, are the ones where you don't have to worry too much about this because you will dissect. That's how I give my fellows to train. When it's between 70 to 90, I just allow them. They just, within one sweep, they get it out. And but if it's 130, 140, I tell my patients that your recovery is going to be very slow because your collagen is very strong.
And the more energy you use, the recovery also becomes a little
Becomes the
slower.
champ because you are using, because you are changing the keratocytes.
I think we'll go on to Rohit's next talk.
I have a next presentation. I'll just skip a few slides so that in the interest of time, I just, it's not moving, slides are not. So I did discuss a few of them. So I will, one of the most important thing is, this is about your healing. When you heal, this is after post-cataract surgery. You put a fantastic lens. Now look at the lens. It's not the lens now, it's the epithelium. The epithelium has created an irregular cornea with coma, with spherical aberrations. So when your patients are not happy with your lenses, before you do anything on the lens, just check your epithelium. The cataract surgeons have a huge impact on the way the epithelium heals. So this is my first take-home point here. The epithelium healing is very important to a cataract surgeon, as important it is to a refractive surgeon. And every cataract patient will have a different types of healing, which have a huge impact. If you have an MS39, you'll know exactly how much of cylinder the epithelium is inducing. And this is a simple line diagram showing how your EDOF and other lenses misbehaves when you have an irregular corneas. This is a patient who has a normal looking topographies, but you can see that there is an inferior steepening. The biomechanics is showing normal here. And this is a classic example of epithelium being the culprit. In this case, it was more of an epithelium. I think it's missed in this slide, which is creating a change, and the role of biomechanics is very important in this case. So again, this is the same patient with an epithelial hyperplasia, which is pseudo-steepening. This is where you need the epithelial map and also the role of biomechanics measurement. And this is what I just mentioned about the collagen. This is where what happens, when you have an ocular surface which is not healthy, the healing of your cornea is different. And that's why, we do a smile, LASIK or whatever, the recovery is slower because what it does on the interior is completely different, and that has an impact on your quality of vision. And this is a patient who had a very, very proper, good surgery of smile, but complained of all the time of something not happening. It's a centered ablation, but there is some amount of higher order aberrations in him, which we are not able to figure out from where we was getting. If I do on a healthy patient, a perfect smile and a perfect healing of keratocytes, you don't get anything. You have this day 1, day 0 wow effect. But the same patient with lot of T cells, the T cells out here, I do a same smile, same type of a thing, this is his healing. And this is what makes your patient comes to you. I'm not seeing clear, there's something cloudy. And whatever kind of slit line, this is 900 times magnified. Confocal is 900 times magnified. And you can see these are the things which messes up. And why do you get it? Is because an unhealthy ocular surface makes your keratocytes very angry. They're always in a state of anger. And this is what the kind of vision you get, which takes a long time because that will take a long time for it to go. So what I'm trying to say in this few cases is that we have to understand the laser, the machine. We always keep fighting in debates and other places about the best machine I use, the skill I have. But ultimately, it's your biology which is your godfather here. If you don't control your biology, whatever machine you use is just never going to work, because this particular slide of healing, where you have a perfect healing phase and a perfect keratocytes post-op, and if you are operating on an ocular surface unhealthy patient, a dry eye patient, a contact lens intolerant patient, you will end up in trouble. Thank you.
Rohit, one thought was that if you say that the keratocytes are causing scarring.
They're not scar, they're healing, they're aberrant healing. See, scar comes when you're clinically evident. These are non-clinically evident. See, when you are non-clinically evident, they will always be hidden from you, whatever you do. But even if you do a backscatter imaging on your cirrus, you will just pick up a few faint things, but you will never be clear. So scarring, scar means you will see macro. So that's why, we miss a lot of these patients all the time, but we don't know what is happening. We have to understand that because the healing has been abnormal, and that's the reason if you are operating on a patient who is very demanding, and he needs a day 1 20 by 20, and he's a contact lens intolerant, or he has a dry eye, be very clear to him, it will take time. Or you do a LipiFlow, highlight, give him time, and give him, because these patients are the ones who would heal abnormally.
Epithelium can be responsible for your cylinder. So do you suggest that in all our pre-op cataract patients, premium, we should be do a...
You should be, because if you look at, we did an average of epithelial profile in premium cataract surgeries when you're putting your toric lenses. We were seeing an average of 0.3 to 0.4 diopter pre-op. The cylinders were coming from the epithelium, which is again a dynamic one, which should change also. So that means that you are hiding an ocular surface issue. Irregular epithelium comes only 2 times. When you're wearing a ill-fitting contact lenses, if you're not a contact lens patient, like a lot of our cataract patients are, that means their ocular surface is unhealthy. Because what happens is every epithelial cell has one corneal nerve which goes in. The epithelial cells becomes the Schwann cells for it, because we don't have a Schwann cells in the corneal nerves. So every time you do anything on the corneal surface, these cells starts becoming exaggerated response, and you get those hyperplastic status. So if you see an epithelium which is very noisy, it means that you're dealing with a very irregular ocular surface patient. So you would probably have to pre-start him with the cyclosporins or liftigrast, or do an IPL or LipiFlow for these patients.
So even our toric measurements would be affected.
Absolutely, because it would change also, because you do a surgery, that they would change also.
Rohit, on that, last question, because we have to move on. I mean, we've been using the Antirion, and we find not great consistency between what we were using OptoView, like this one, for almost 7-8 years. Very comfortable with it, because it gives you those 2 scans. It gives you the 6 mm and it gives you the 9 mm. Okay. Now, first thing is Antirion misses out on the 9 mm. It's only giving you like 6 or 7 mm. So many times, the peripheral changes you don't pick up. They say that my resolution is not great in that area. But even where it is great, I see more ununiform epitheliums on the anterior because it has a 1 micron and a 2.5 micron thing. Whereas on the OptoView, we don't see that. Sometimes that, those irregularities, I'm wondering that which one is right. We've been so used to the one from the OptoView, and frankly, the epithelium thicknesses, their maps are so much more easier to interpret. On anterior, there is like sometimes so difficult. I actually close it and look at the OptoView because it gives me like kind of better information. And there's a difference of almost 5 microns between what the anterior measures and the and for the corneal thickness, the OptoView always measures about 20 microns less as compared to the anterior. And I think anterior is more correct there though.
One thing to make it very simple on this, OptoView gives you a lot of false hope on so many things. OCT in the periphery, as it goes to the periphery, whatever it gives you, you have to take it with a pinch of salt because it is extrapolating a lot. Anterior has more spots in the periphery. So anterior, whatever it's giving you, at this point of time looks more sensible.
And is it consistent with MS39? Like on the anterior, we don't have MS39, so but have you
not always, but
maps?
very similar, very similar. And because when you go to periphery, even though OptoView is giving 9 millimeter, you speak to any OCT experts in the world, anything after the cornea curves down is just noise. What OptoView does is it doesn't tell you it's noise. It gives you something so that you become comfortable about it, but it's actually not there. Like if you look at Pentacam to the periphery, it is giving you a noise, but it's just making you think that you're getting something which is better than the others. Thank you, sir.
Thanks a lot, Rohit. Thank you so much for those wonderful talks. I'll invite Dr. Kumar for the next talk. I think Rohit might be leaving soon. And are you planning to leave in a short while? You have another one, no? No, I'll finish this. Okay. You have...
Either SDM.
Kumar is going to be speaking on anterior applications. Oh, we already discussed so much anterior. Okay, anterior applications as ASOCT in my practice.
Yeah, so I'm only going to give a few examples of imaging on the anterior. Yesterday, Dr. Shivani had already spoken about the biometry part of it. So I've been using this now, and I'm going to talk only about imaging because I'm using it as an imaging tool, and I'd like to share my experience with you. I think I don't have any other anterior segment OCT except this. So I had no other choice. But it is fantastic information. If we consider this, we have the ciliary body, we have the conjunctiva, the scleral spur, the lens thickness, the cortex, the nucleus, we have the angle, the cornea, anterior, posterior, chamber, everything. So we get all these details in proper depth. So how can this help us in our routine practice, and how does it benefit us at all? So I'm just going to tell you the way it functions. It's very flexible. The number of scan lines is huge. Scan length and height is very good. Resolution is decent. We can position the scan the way we want, and we can centralize and decentralize this examination. The advantage is the scan depth is of 14 mm. The scan length is 16.5, so it goes limbus to limbus. So we can record anterior pathology and lens fitting, and capable of imaging the vitreous, sclera and the limbus in the periphery. Again, the big advantage, we can customize it the way we want. So you can have a single scan, we have a cross scan, horizontal scan, all round scan. So all these patterns are possible, and we can scan in the area that we want. So that's one big advantage. Now this is one example of a dislocated crystalline lens, and you can see a heaped up vitreous, which normally you don't get to see. You will see it on a slit lamp, but when you image it, it can be seen quite well. So this is one example. Keratoconus, obviously you can see that how you can see the image, and you can see the natural lens inside. We can even visualize the limbus and the scleral region. You can even see the conjunctival nevus and a muscle attachment. That's one big advantage. So you just ask the patient to look on one direction, and you can then take the image that you really want. So you can see both of the attachment of the muscle. Again, an eye stent. Originally we had an eye stent available. So this is eye stent in position. You can see the eye stent, which is actually a back shadow, and you can see that too. Coming to chamber depth. So we have wide anterior chamber depth with the concave iris, and then we have a normal mydriasis, and we have a narrow angle, which you can see that the anterior chamber is very, very shallow. And this also can be imaged, and you can get a full image like this. So I had a huge Desmond's detachment during IA, and the question here is, obviously we got a thicker cornea next day. I did not put a lens, okay, because I was struggling with the Desmond's itself. So you can see the whole Desmond's, there is no IOL. So what I've realized is that if you have a Desmond's detachment without an IOL, it actually goes and sits in the pupillary area. But if you have an IOL, it doesn't go and sit there. So you can see the whole Desmond's detachment, and you can see one point of attachment in the whole cornea. This was a massive Desmond's detachment, of course needed gas, etc., and you take the patient up. So you can see again in another view, the whole Desmond's is going down into the pupillary area. I went ahead and put an IOL, and then we put a gas, so you can see that Desmond's getting attached superiorly, and you can see the lens reflection coming from the inferior part. As far as keratoconus is concerned, I still do sometimes C3R with intacs. So you can plan whatever degree you want to place the intacs, 1 segment, 2 segment, what depth. But the beauty here is the post-op. So you can see post-operatively, you have placed an intact segment, and actually you can measure the depth is what you had planned is where it is sitting, or it is sitting somewhere else. So you can see on the left side, the intact segment itself and the depth itself. So here is another big advantage. Now this is a case of posterior lenticonus. So this is another thing that you can see, diminution of vision. The child came to me, 18-year-old girl, and you can see a bulge which is going outward, which is the posterior part of the lens itself. Ahmed glaucoma valve sitting in the anterior chamber, again can be imaged, and you can see the depth. Peripheral iridotomy, you can even image that and see the depth. High hyperopia, you can see closed angles. We also have matrix, so we can actually measure the angle for how much is and needs PI, doesn't need PI. You can get the anterior chamber depth itself. So this is a closed angle, and this will also need measuring. Now this is another interesting case where a small nucleus piece was sitting behind the IOL, but the posterior capsule behind the IOL is intact. So sometimes we wonder whether the surgeon had left it just like that, or there is a PC rent and the nucleus went and sat there. But you can actually scan and you can see the posterior capsule, ahead of that a small nucleus piece, ahead of that an IOL sitting. So the small piece is sitting behind the IOL. Now this is a case of posterior polar, where we can see a pre-existing dehiscence in the posterior capsule. We decided to do femto. So of course in femto, the posterior part, which normally has a 600 micron gap, we went ahead and made sure that the gap is increased to 1.2 millimeter. So increase the posterior safety margin. That's one big advantage of the whole thing. So this is one advantage here. Okay. Post-op results, you can go now. This is very interesting. I never thought of this, but my colleague helped me here, because we do femto regularly. So we just decided that we scan this after doing a femto, and what you can see post-flax, a free-floating capsular axis, okay, and a 200 micron disc of the cortex cut and floating above the normal lens. So this is post-flax, before cataract extraction, just an image of the whole lens that we have done. You can also see a bit of fragmentation that has happened, which comes as a back shadow. So I think Antiron as a tool works beautifully for imaging itself. It does help you to plan better. Even the matrix calculations really work very, very well. Thank you.
Thank you, Dr. Kumar, for such a wonderful talk. I think it's a multimodal imaging system, and we are covering the entire segment with this system. We are getting all the information. Thank you. Next, we move on to the next talk. That's on advanced surface ablation. PRK by Dr. Tyagmurthy Sharma. We'll have got 2 talks on surface ablation, and the questions will be after 2 talks.
Dr. Tyagmurthy. So good morning, everybody. Thanks UKSOS for inviting me for this talk. And just to see the amount of instrumentation which is rapidly coming in ophthalmology, it's a very, very daunting task for people to just follow all the new instrumentation. So I'll be talking about a procedure which probably I started in 1996 or so. Yeah. So it's about PRK. And PRK, I call it the marathon man. In spite of such a great deal of advancement in technology, we have this procedure which has stayed and even become better over a period of time. So it's basically that there are various definitions for what is a PRK or a epi-LASIK, LASIK, advanced surface ablation, transepithelial PRK, or which we call the touchless PRK, or the topography link PRK, and PRK extra as well. So it was very popular when the whole procedure started. It was the only surgery done, and at that time there was no limit on how much amount of myopia you are going to correct. I still have patients who I've operated 20, 25, almost 20 years back, who I corrected -8, -9, and they're all still stable and doing very, very well. So the issues were basically haze and regression, and because of that, LASIK became the more popular procedure, but it has made the PRK has made a strong comeback with advanced surface ablation. So the best suited are the thin corneas, because I see a 500 micron corneal this thing, and I say, okay, I will do a PRK. Thin corneas, steep corneas, irregular corneas, post-RK, it's the procedure of choice, and after post-LASIK complications. So there are various treatment modalities also which we can perform, which are called PTKs, and that one of the treatment of choice is for recurrent epithelial erosions, and topography guided treatment with CXL for former frustrated keratoconus or the borderline corneas that we have. So it's very inexpensive, it's quick, and it's very difficult to get it wrong. So I feel it's a very good point that you can't mess up a PRK. Enhancement is very easy and very few complications. So various studies have been done. LASIK complications are way higher. Trans PRK 1.9% and conventional PRK is around 2.9%. So in comparison to LASIK, there are flap related complications, buttonhole, partial flap, incomplete flap. All these complications were there with the earlier keratomes. With the recent keratomes, these complications are hardly ever there. But then there can be a host of complications like DLK, epithelial ingrowth, etc., and a dry eye. So LASIK is actually destructive. I mean, both procedures are destructive. But in LASIK, we are at least removing that 120 micron or 100 micron, which is lying there pretty much useless. Then post of ectasia, much more in LASIK. LASIK accounted for almost 96% of post of ectasias, and PRK only 4%. Well, that's a huge figure. So regression is similar in both the procedures, and it depends on the amount of correction that you are attempting. Obviously, for higher myopias, you are going to have more regression. So it keeps evolving. It has come with various new names, and the most common new name used is advanced surface ablation. Mitomycin C usage has again reduced the haze component, and in fact we use it almost routinely in all our PRKs, and there is a huge potential for topography guided PRK. Still, LASIK remains the procedure of choice for a very simple reason that it's the recovery is so strong and so fast that you don't want to subject the patient for 3, 4, 5 days of time when the epithelium is regrowing, and that's a very painful time for a lot of people. So you are limiting your indications, but you have to keep weighing between LASIK and PRK. So these procedures all, including SMILE now, they all having a peaceful coexistence. Proven over decades, this procedure, it is safer, It hasn't died like RK did, because RK was physiologically a bad procedure. And this will remain a very, very solid procedure. And its applications are there in clinical conditions like recurrent corneal abrasions, corneal erosions, superficial corneal opacities, surface irregularity, and complications of PRK and LASIK. So the complications of LASIK would be central island, corneal haze, decentered ablations, LASIK flap complications, flap striae, topography-based ablations. This is initially I used to do PTK procedures also for recurrent corneal erosions. So this was the technique which I used to do with the Zyoptics platform. And my routine post-op procedure routine would be giving a BCL, antibiotic drops, cycloplegics also I use sometimes, and good strong analgesia, and even sometimes sedation also. So this is my post-op treatment, and I keep them on follow-up for at least 3 months. So pain, discomfort, there are a lot of ways how to reduce the pain and discomfort. One of them is that cold saline application. And I have seen epithelium not heal till 7 to 10 days. So it can be a pretty harrowing time. There is always a small risk of infection. And there is some amount of haze, which mitomycin C has made the haze a lot less than it used to be earlier. And hyperopic shift can be one of the complications. So these are the various conditions in which we use PTK as a procedure, in band-shaped keratopathy as well. And in the non-visual category, in basement membrane epithelial dystrophy, bullous keratopathy, and erosive erosion secondary to trauma. So, in fact, our next topic is also advanced surface ablation. So I would like to stop here, and if there are any questions.
I think we'll have discussion after Dr. Arora's
Yeah, I
talk,
think
because
that,
then we'll have better,
yeah,
you know.
Sure. Thank you.
And Tyag, you're absolutely right. I also really feel that PRK is still one of the best procedures that we do. So we'll have Dr. Arora's take on it, and then we'll have.
Thank you.
You can come and sit here with me.
Phone there.
So Dr. Vinod Arora has also been a pioneer in refractive surgery, and has been, evolved from one of the busiest RK surgeons in the 80s and 90s, I would think, and then on to laser correction. So just like you, he also started.
I think the technologies hardly die. They come in a new avatar or something. Refractive surgery started with RK. Then still we having arcuate keratotomy. Even has come with the FEM2, we are making arcuate incisions. So it's not died, but it will come a new way. That's why we are earlier doing, earlier we were doing the ALK or PRK, we were taking the lenticule. The lenticule extraction was there, and then came the lasing, and we stopped it, but it has again come back in the form of a smile and relax. So the things are keep on improving. Same with the LASIK refractive surgery started with PRK, which was much better than RK at that time. But as soon as the LASIK came, we stopped doing PRK. It was kept only for LASIK rejects only. But now it has come again to the mainstream. And it's taking as good as LASIK, SMILE. The share of ASA is also increasing day by day. क्या वो talk है नहीं भाई? So we are इधर भी दे दो मेरे स्क्रीन पर कि वही देखना है. ऑलराइट, यहाँ नहीं आ रहा. उसमें तो नहीं है, उधर तो नहीं है. So it was already covered. We have started with the RK, PRK, LASIK, interlace, epilasic, SMILE, Contura, you name the things. We have a lot of things. Then again the advanced surface ablation. So things are keep on coming. PRK was more accurate. It was able to correct myopia, hypermetropia and astigmatism at that time compared to RK. The results were pretty stable, but the problem was pain, delayed healing, scarring was there. So came the LASIK. There was a rapid recovery, there was a wow factor, decreased risk of scarring, there was no pain as we could see in the PRK. But the flap-related complications were there, stry, buttonholing, partial flap, and interface like debris, epithelial growth, DLK, late trauma, and ectasia are the complications, not common, but yes, they can occur after LASIK. Then came the femto, which make the architecture of flap much better, and these were thinner or planar flaps, and fewer incomplete flaps or buttonholing were there. But some problem still persisted, and ectasia was reported even after femto LASIK also. Then came the smile. Smile is again a wonderful technique, but still we have some limitation which are getting better. At present we can't correct hyperopia. Customized treatment at present is not possible. Difficult in low power correction, you have to take a lot of tissue along with that. Then by toric or mixed astigmatism, a little difficult. Treatment is centered on the pupil. There's no cyclotorsion compensation. Of course, the things are improving with the newer models. And as we have to remember, the little decentration occur with a femto flap, it's not going to harm anything because it's not contributing refractive. But in a smile, even a very minor decentration can cause can cause coma or other problems also. And in fact, the coma problem is quite common in smile patient, which persists for a few months. Then came the surface ablation again, LASIK, epi-LASIK and advanced surface ablation. So these are the some indication which makes it better than all other procedures, like irregular astigmatism, FFKC, if the cornea is too thin, if there is a night vision concern like glare from large pupil of flap, then if there are anterior stomal opacity, that can be taken care with an advanced surface ablation. Where the sports or where the duties are as such hazardous, where the chances of trauma is much more, it's much safer than any procedure. Then if there is a prior RK or AK, then again we want to do the customized treatment like wavefront treatment, or it makes much better way to do it. Then if the patient has RD surgery, if it is a filtering blab with the deep set eyes where it's difficult to put a PI or the cone or keratome on that cornea, then we don't have to put a pressure on the cornea. That makes it much safer then. And lastly, we can combine it with C3R. The incidence of ectasia probably is the least in advanced surface ablation. It has been reported in femto LASIK, and even smile it has been reported, but probably the chances of ectasia are minimal with the advanced surface ablation. There is a comparison of our clinical results between trans-PRK and femtosecond LASIK for correction of high myopia. So our range has increased a lot. I'll come to that one. We can combine it with PRK to get a much smoother cornea, and higher order aberrations are taken care with this thing, which gives a much proper fitting of contact lens or glasses, or the quality of vision improves a lot when we combined with topo-guided treatment. The normal procedure was local anesthetic DOP, epithelium removal. There were various ways. Epithelium is removed. It's a very simple procedure. Laser is applied. I should say it's a idiot-proof, you can say. Anybody can do it on the first sitting. There's no learning curve, except you have to know the fine nuances. But surgical step is very easy. Putting 0.2% mitomycin has changed all the game. Then came the bandage contact lens, and we put antibiotic lubricating drop. So you aim, press, and put a contact lens and drops. That's all. The complications which are common earlier, stromal scarring, irregular astigmatism, persistent corneal epithelial defects, recurrent epithelial versions, which may cause significant discomfort, epitheliopathy. Of course, these are not common with modern lasers. First is the smart surface technology. What has improved the things? One thing is the mitomycin, which has changed the game. The chances of haze and regression are practically reduced with mitomycin. Then came the smart surface technology, or the epithelial remover, which has improved a lot. So the removal epithelium has become very smooth. This is from Eyecon, and this is, I want to show how we have changed from removing epithelium. The slide is borrowed from Arthur Cumming. Here you can see in the first one, there is a quite gap. It's not very smooth what we used to in PTK. But in this model, we have got a very, very smooth surface and there's no collateral damage. It's a PTK, it's a neutral one. There's no refractive component in this thing. And the whole procedure has become one-step procedure. And our limits had gone high. It's as good as for LASIK, or you can say for SMILE also. You can correct up to 10 diopter of myopia. In fact, in LVP, they are correcting up to 13 to 14 diopter also. So the limits are very high now. We can correct the hyperopia up to +3, then mixed astigmatism, hyperopic astigmatism, or the myopic astigmatism, all can be corrected with easily. The advantage here is we are removing epithelium in a wavefront optimized way. That gives us a very smooth sheet to be removed, and our surface which remain is very, very smooth and is easy to start our procedure. So Streamlight utilizes optimized epithelial ablation profile. There is no residual epithelial island. More pulses are used outside 4 mm zone to prevent epithelial remnants. So practically there are no islands or anything there. And it's a one-step treatment, requiring only one centering, therefore enhancing precision. There is active eye tracking throughout the entire process. Ablation is determined automatically with the laser based on the PRK ablation profile. So we don't waste the epithelium extra which we are using alcohol or anything. So we have to make a bigger zone, but it automatically calculates the zone, and it's a clear-cut distinction between the epithelium removed and non-removed. So we got a good collateral epithelium there to heal it. That makes, and there is active eye tracking throughout the process. So just to summarize, what is the advances of transepithelial PRK? There is a accelerated healing and visual recovery. Patient feels very little pain. It maybe lasts maybe another 20 hours or something, but the pain is much reduced. There is a less pain, reduced risk of haze because of accelerated healing, by smooth surface and better contour, by removing damaged cells and reducing thermal effect. There is a gap between the two procedures. The shortcomings are, the flip side is, it accentuates the need of epithelial mapping. It causes more heat. It's still not available with premium profiles, like we want to do custom Q or contour. People are trying it. Maybe in future we'll get it. And there's a price tag. We have to use a card for doing this thing. So just talking about the advanced surface ablation, the advantages are obvious. It's a gentle, no touch, no cut, no incision. It's a safe, more biomechanical preservation and corneal stability is there. It's a stress-free, faster treatment in a single step, no effect on posterior segment, excellent clinical outcome, reduces dry eye by leaving the nerves that produce tears intact, can be combined with CXL, and it's economical also, easy to use, time saving. There's no need to have femtosecond laser, even or microkeratome for that matter. So just to conclude, surface ablation is one of the most effective tools in the surgical armamentarium of refractive surgeon. It is still underutilized, but is a very promising and exciting with superior results. Thank you. Thank you very much.
Thank you, sir. So there are various ways to skin the cat. Is it similar to that? I mean, we are removing the epithelium in so many ways.
Basically, epithelium removal makes a lot of difference. The reason being, whole the game in advanced surface ablation depend on the epithelium. In LASIK and contour, LASIK and SMILE, we are not dependent much on healing. But here, everything depends on the proper healing. So if we are removing epithelium much more smoothly, that gives a smoother surface. And to begin with, we get a better results with that things. So we can use alcohol, but alcohol causes lot of traces go on the peripheral side. They may leak even to limbus, called damage to the limbal cells, and even adjoining area. If you use a mechanical method, they are quite good, but still we can leave the islands of epithelium there. So laser gives a clean cut surface. That's very important to start with.
So Tyag, how do you remove the epithelium?
I love alcohol.
Right. Okay. Only thing is that what I used to use alcohol for my first 5-6 years. Then I moved on to the Amoils brush for almost 10 years. And then after that, I'm on Trans PRK last 4-5 years. All the same, I still use the brush. Alcohol, frankly, you don't even need to use alcohol. Even if you're using just the hockey stick, you don't need alcohol.
Alcohol, you can almost get a Rex's. You can almost get a Rex's kind of a feel.
You can get an equally good epithelium removal without anything. Just put a few drops of Paracane and wait. I mean, maybe for 2-3 minutes. Because alcohol potentially for the limb and stem cells and so many other reasons, I just stopped using alcohol. The eyes are so much quieter. Even when I moved from alcohol to Amoil's brush, there was a huge difference in my post-op thing. And ever since we moved to trans-PRK, the patient satisfaction day one is, most patients are actually reading 6.9 or 6.6 parts on day one. And we use a BCL soaked in ketorolac, this thing. And the pain score is almost gone. We can't differentiate between our LASIK patients and our PRK patients today. So there's a huge evolution in PRK.
I just want to know one thing. Various ways of removing the epithelium. The healing takes place in the same time.
So, you're right, but
healing will occur in the same time.
No, okay, I'll tell you again, there is a difference. What happens is with trans-PRK, you are exactly removing 1 millimeter extra epithelium than your largest optical zone. So it's scientifically more kind of accurate because see, if you're using a 6 mm optical zone and an 8 mm ablation zone, it'll remove 9. So it's a very precise removal, which you cannot achieve with whatever you might do with alcohol. You will end up reaching somewhere close to the limbus. I mean, 1 millimeter inside the limbus or so. And you are deepithelializing. I mean, even that area which is left behind will actually be not viable epithelium. So you will actually have the epithelium growing in, all the way from the limbus, right? So the healing definitely takes a little longer. And the patients, the comforts are, so which platform are you using?
So I use the Zeiss one now.
Right. So doesn't it have the epithelium mode on it?
No.
I thought
so basically,
MEL 90. Okay.
I would like to add there, on the junction, even if you are using alcohol, there's some dead cells are there, there's some old tissue overhanging there. You can't totally clean it.
So I understand the part of at the time of the surgery, but at the end of 1 month, there is no
at the end of 1 month,
I doubt there's any difference.
And there is, I mean, they are all.
Also, see, there is another thing, sir. We are using Streamlight, me and you are using Streamlight, but those who are using the Schwind, I think Mayank is using Schwind, and the Smart Surf is apparently slightly superior as far as the stromal bed is concerned. Its nomogram for using the Smart Surf technology for removing epithelium is supposed to be superior even to what Alcon is using in some ways, because it creates a much smoother bed. That's what I understand from whatever I've heard, and therefore the quality of vision and everything, healing time and everything is much better on the Schwind, maybe even better than what we have on Streamlight. I've been told. Would you like to quickly comment on that?
The vision should, the viable vision should be 6.9 by 10th day and 6.6 by.
Right. You also remove the BCL on the 5th day.
Yeah.
Yeah.
That's quite
because
long.
the wound healing would be very fast.
So you know what happens, Tyak? If you even when you remove the 3rd, 4th, or 5th day, whatever, you will have that fusion line right in the center. And you'll sometimes see patients not seeing so well because there's that line where the epithelium grew in and it forms that Y-shaped suture kind of a thing, right? Exactly. So frankly, if you remove it sooner, sometimes you will have that small central island in occasional patients and you'll have to put it back. If you do it on the 5th day, it's a no-brainer because almost 99.9% patients have healed. So there's no point calling patients on the 3rd. You're not winning any war, is what I think.
So two questions. One is, which BCL do you use for soaking? And second is, what is your post-op protocol?
So what we are doing is
how long do you continue giving steroids with steroids?
I use the the disposables from Johnson & Johnson, the AccuView. I think we are using the one which is the 5 days. No, we are using the 15-day one. We are using the fortnight one, but we are using a 0.25 par or something that we get. Okay, and we have recently started using another pure BCL, which one of the companies is marketing, which is slightly more expensive, but it is basically a much better quality BCL. I don't remember the exact specifications.
Even Bosch and I'm giving this thing, you can get a good quality bandage lens from there.
And post-op, sorry, please continue, sir.
Yeah. And secondly, we keep it 5 days. It's not just to epithelium recovers on the 2nd or 3rd day, but still we keep it there just to give a smoother surface. And patient is more comfortable that way. That doesn't matter because the patient is comfortable on the 2nd day also. But we keep it there just to epithelium grow properly underneath it. And secondly, if you see any debris, examine on the 3rd day, 2nd day, if you see any debris between the cornea, you have to change it. The basic trick is it should be very well-fitting contact lens. That's very, very important. If it's not a proper fitting, then it can cause problem. And soon we are going to get this lenses which will dissolve itself. It's a biodegradable. Maybe another 3-4 days they dissolve themselves. Probably that will change the things much better than what we have now.
So the protocol I'm using 6 weeks and we are using only FML. FML tapering over 6 weeks, 6, 5, 4, 3, 2, 1. I mean, I know people use 3 months and people use, sorry? So no NSAID, but we do start steroid on the table, which means that patient, starts to use the topical steroid right after surgery. We don't wait for that, 1 or 2 days of epithelialization. Actually, that's the way we've done it for and it's wrong to say like this, that that's the way we've done it for 20 years, but frankly, it's worked well, so I don't want to change what's working well.
I use cyclosporin drops in all my post-op patients. I give them Restasis for 3 months.
Okay.
Yes, that's a good idea. And secondly, most of the important, one of the things which we often miss is having a proper UV blocker goggles.
Yes.
Sometimes we ask a patient to buy it from market. So they get a goggles which are not 100% UV blocker. So they have to use it for 3 months in the daylight. And if they are going to say high altitude or they are going to beaches, then we say use it for 1 to 2 years at least on the beaches and high altitude where the UV light is much more. So now I started giving glasses from my clinic also. I don't ask them to buy it. So that I can assure that they are getting a 100% UV blocker glasses. That's very, very important.
So do you take into account the variations in the epithelial thickness in each patient? I mean, because some people might have some epithelial hypertrophy. With streamlight, you might get some variation in outcomes.
Unless you are doing proper good epithelium mapping on OCT, I think trans-PRK should be, because there are patients who are like 550 cornea and they will have just a 47, 48 microns epithelium, and there are others who are like 490 cornea. So it doesn't go by the 10% rule as such. And sometimes we've had patients with, and also there may be disuniformity. That's what I was telling. We always watch out for epithelium maps which are showing any disuniformity. And if there is significant, like more than 3 or 4 microns disuniformity in the central 6-7 millimeter zone, I may not do a trans-PRK. I may switch to a Moyle's brush.
Secondly, if you're talking, yes.
Now, see, now the new machines are having a 1 micron resolution, and you can fairly, it's pretty predictable. I mean, on the OptoView, I'm using it for 7-8 years. It gives you a pretty good idea if there is a significant, disuniformity. Yeah.
Secondly, it may be a good diagnostic tool, but the thickness doesn't matter your refractive results. If it is a 45 micron, you remove 55 micron, and if it is with trans-PRK. And if it is 55, you remove 45 microns. Because there's this, suppose you're doing a deeper dissection, that means your optical zone will go a little wider. If you're going a shallow ablation there, that means your optical zones comes a little down. So the refractive component doesn't change there. So it's just give us an idea whether the epithelium is proper or not. So if it's a 45 micron, 55 micron, you kept it 50, 55, it hardly matters in the refractive outcome.
So who's next? I think, sir, please come. I think Dr. Bhupesh is next. So Bhupesh is one of those few people who has access to both platforms, and he can tell us a lot about how he is finding difference between the Visumax, the Smile that they've been using for some time, and the Clear. So we look forward to Bhupesh sharing his views.
So before starting this presentation, I would like to say that all the machines that are performing LASIK, all lenticule, all are good and all are giving good results. If any machine is not giving good results, it's not possible them to survive in the market. So I'll start my presentation. So I'm telling some points between the Smile and Clear, which I'm using. So no financial disclosures in any of the machine. So since RK time, RK, PRK, LASIK, LASIK, they all have some or other issues like corner haze, regression, hyperopic shift, flap-related complication in LASIK, and dry eyes. So the need for the flapless procedure was felt long back, and then the research started with the Visumax from Zeiss, and the Smile came in the market. So we all know Smile procedure, in which the lenticule is made and it's removed depending on the refractive error. And I'll not show this video because everyone has seen this. So coming to the limitation of Smile surgery, So the main problem with the Smile Visumax that I faced was a limitation with the centration. So because you cannot center the smile on the cornea. Once you dock the patient, you cannot move it. You cannot, if you do the redocking, then again the chances of suction loss is very high. So centration is a problem. Then plane identification was a challenge, but it is a beginner problem, not anymore for the trained surgeon. Retained lenticule, in some cases, that can happen with any machine. And the other limitation was accuracy in the high astigmatism cases. So Smile came in the market with a taboo that it will not correct the astigmatism. But with the newer platforms now we can correct comfortably around 4.5 to 5 diopters of astigmatism with good results. And hyperopic correction is still a limitation for any lenticle-based platform. So coming to the newer platform that we have acquired a few years back, that's a Clear. So Clear is from Zimmer and Zimmer Z8 and stands for corneal lenticle extraction for advanced refractive correction. So there are some key features that this machine provides. The first key feature is the centration after docking. So once you dock the patient, then also you can center it on the monitor. So that's a very big advantage. So it ensures that all the cuts will be perfectly in the center. So you'll get lesser amount of aberrations post-operative period. And then other advantage is the vacuum. So suction loss was another challenge with the Smile machine. We also face few suction losses and we have to convert into PTK sometime PRK and sometime circle software for LASIK. But with the Zimmer, till now in last 2 years we have not faced a single suction loss. I think that is the amount of vacuum that is generated during the suction. So it's very good. And then this machine gives a very easy option for beginner surgeons who is starting the lenticle surgeries and they're not a cornea surgeon. So it's very easy. And they have 2 tunnels. Those are the guiding tunnels for the upper plane and lower plane. So the main challenge that surgeons face that the correct plane identification. But with the Zimmer, this challenge is no more. And this machine also has an intraoperative OCT. So you can visualize what you're going to cut, while in a Smile or in a Visumax machine, you cannot see what you're going to cut. And then this has a low energy, high frequency and smaller spot size proprietary software, and that works very well for the dissection. So I'll be discussing one by one. So this is what I was talking about, the centration after docking. Once you dock the patient, and if your docking is decentered, that happens in most of the time. So you can center it on the computer. So it's very easy, and once it's centered on the computer, the cut will be centered. And this have a automatic torsion correction. So there is no issues of cyclotorsion also with the machine. So this is another advantage in comparison to the Smile machine. So coming to the vacuum, suction loss in Smile is very common, and we always pray during that 9-second or 15-second that don't go for suction loss. But with Zimmer, once it's docked, you can chat with your staff, you can talk, whatever you can do. Nothing is going to happen with the suction loss. And the main reason is that in a Smile machine, the suction is on the cornea. It's a soft suction. Whereas in the Clear, it's slightly on the harder side and it's on the conjunctiva. But it's not on the limbus. So chances of hemorrhages is not there, but good suction is there with the Zimmer machine. And this I was talking about the concept of low energy, high frequency and overlapping laser spots. So I think this is the USP of this machine, that this uses very low energy of around 70 to 80 nanojoule, and the repetition rates are very high and the spot size are overlapping. So chances of getting tissue bridges are almost negligible, and it cuts very smooth. The dissection is almost very smooth in all the cases. No OBLs and no tissue bridges. So this is what I was talking about, the multi-guided tunnel. So one tunnel automatically enters in the upper plane and other enters in the posterior plane. So if you open the posterior channel before also, there is no problem. You can go anterior from the other side. And there is the option, if you don't want 2 tunnels, you can shift to 1 tunnel, or you can open 1 tunnel, or you can design 1 tunnel depending on your need, 2.5, 3.5, whatever you want. So you can do that. So this is how the lenticle appears with the 2 tunnels. So one is for the anterior, other is for the posterior. And this is the intraoperative OCT. So this machine has a OCT option also. So you can visualize how deep you're going, at what plane you're traveling. So this is a video from the company side, I think. And volume, can you give the volume? Yeah, this is an inbuilt OCT.
Just in that small robotic arm, you have an OCT integrated? Wow.
So that's and this IOCT works very well in the cornea cases, especially in dull cases and all those cases.
Underactive suction
So
allows complete control for centration
volume
and repositioning. Cyclotorsion is automatically compensated. Surgeons also have the option of using intraoperative OCT to create a cross-sectional visualization of the plant lenticule and the residual stroma. The Z8 creates a lenticule inside the corneal stroma. Thanks to the short working distance to the eye, the focus size is very small, and thus the energy required for each laser pulse is low. In combination with overlapping spots, this produces a uniquely smooth and even cut, a feature Zemer is known for. Depending on the surgeon's preferences, 1 or 2 incisions are made. Guiding tunnels are integrated to make it easier to identify the anterior and posterior planes. Next, the surgeon inserts a dissector and carefully separates the lenticular interfaces in the anterior and posterior plane. After the dissection, the lenticule is extracted.
So coming to the real patient. So the docking is 2 steps. First you have to dock the PI here. And once it is docked, then coming to the lenticular dissection. So this is a 2 tunnel, and once we make 2 tunnels, it looks like that it will induce some astigmatism or something, but it's not like that. So there is no induced error, effective error with these tunnels. So see, we have not identified the plane, just enter it directly. So just see the smooth dissection. This machine don't have the inbuilt camera. That is a problem with this machine. So you have to record with a microscope camera. But so that's why the recording is not that great. Just you have to sweep it. With the left hand also you can dissect. So it means the dissection is very smooth. And this is a lenticule in totality. So perfect centration in almost all cases and good outcome on day 1. So and this is a chart showing the difference between the Visumax, and now we have the Shund also and Zemer. So almost all the points we have discussed. And so if we talk about the conclusion, both are good effective procedures, although new things come with the new additional qualities, and Clear has that advantage right now. Thank you.
Wonderful talk, Dr. Bhupesh. I was interested to learn, all these points are so nice, but refractive outcomes between the two, are they comparable? Or, usually with the lenticle extraction, with any new platform that you get, takes time for you to kind of understand the energies and the results and the nomograms, and it takes a good couple of 100 cases before, you are kind of consistent enough to get
Definitely. Initially we had problems with some cases, but I think we have done almost 300 to 400 cases till now. And they have made some changes in the new software. So after that, there is no need of marking also, and results are very good. And if you talk about the recovery time and compared to Smile, so recovery is slightly on the better side, faster in the Clear. I think the main issue is the centration, because when the cutting is very centered, so vision quality is better than the Smile.
Also, the minimum lenticle thickness, is there just like on Visumax, you would have a minimum lenticle thickness? Is it really required here, or you don't?
No.
So if you were to do, say, a 1 diopter of correction, for example, what would be your lenticle thickness?
So we can around 20.
Would you keep it like 20 microns or something?
Yeah.
Okay.
Yes.
Because on Visumax we try to keep it at least 40 to 50 microns by adding that neutral
yes,
lenticle.
peripheral
Here you
edges.
don't need to do that because
No,
the ease
no.
of dissection is
We
very
can
good.
remove that. Yes.
Wonderful.
Yes.
And also if you were to make only a single plane, for example, if you can identify the posterior plane, then anterior is so much easy to do. So, you might just do one side cut, identify the posterior plane to naturally go into the posterior plane, and kind of dissect the anterior plane yourself, and then you have an automatic entry to the posterior. Is that a possible? Have you tried that? Because making two side cuts somehow seems counterintuitive.
No. So
to me.
we don't do now. We don't do now. So these were the initial videos.
So if you do one, which one do you choose, the anterior plane or the posterior plane?
So no, we make the incision similar to smile now, and with the same plane we go up and then down.
Okay, but if you had the choice on single side cut to choose a plane, which one would you choose, posterior or anterior plane?
So I think anterior.
Anterior plane, because you want to do that first. Perfect.
Yeah.
Thank you so much.
Thank you.
Do you have any question?
Thanks.
Well done, Bhupesh.
Yes, sir.
So again, we'll have Gaurav, who needs no introduction. He will be speaking about smile, contoura, oblique, trans-PRK, which one to offer and when. Gaurav.
Thanks, Tyag, and very interesting refractive surgery learnings here. So times have changed, and now patients walk in asking for their choice of refractive surgery procedure pretty often, and you are kind of trying to cope with their demands. They've already read up on the internet, they've seen lots of YouTube videos, and they've come asking for a particular procedure, and we've been doing both contoura and smile and all the other things. Almost 7-8 years we did contoura and smile together, so we find that demand is sometimes unreasonable as well. There is also now a demand for epi-contoura, even though the machine doesn't really have a software which links Streamlight with contoura. You have to do it as two separate procedures. And then of course smile and ICL, and there's so many things that are coming up now. So it's always good to choose the right procedure for your patient, because one procedure does not fit all. It depends on the availability of equipment, the surgeon's preferences, the patient's preferences, and of course the most important thing, the patient's parameters and indications, which should be the primary driving force when we choose the right procedure. So also depends on equipment availability, because you may be sharing a facility, you may be using an existing facility. Nobody wants to invest on too many machines, that they're almost very, very difficult to break even on. And you might be, some people use the microkeratome, some don't even own a microkeratome, they're just doing PRK, and then of course if you have a femtosecond laser. So it all depends on what all you have access to and what you are comfortable doing. However, that should not change what you want to offer the patient. If you feel that what you're doing something and the patient might be better off getting something else, one should not hesitate to refer that patient elsewhere. And also surgeon preferences can make a difference, personal experience, equipment availability, again, convictions. Sometimes, I see some people who do only 100% contoura, and I see people who do 100% smile, which, may not be in the best interest of the patient. And then peer influence makes a lot of difference. And then, of course, industry is always trying to influence you in one way or the other. And then country-specific factors, like Japan does no LASIK at all. So their patient preferences, we've already discussed, their expectations from the procedure, their occupation and interest. It's always great to talk to the patient for a few minutes to understand why they're really here for the procedure and what are they expecting out of it, and then match their expectations with what they've read in Google, or they have been fed information from so many sources. So we all understand that how the three procedures differ. We've already gone through that just now. I won't go into the details again. But PRK, in my hands, I don't like to exceed actually 70 to 80 microns of central ablation. The maximum I would ever be forced to do is about 100 microns. But that said, in LVP, they go to 120 to 130 microns, and they use mitomycin for, for depending on per diopter of ablation, and they get great results. I am scared of haze when I ablate more than 60, 70 microns, so I would maybe switch to some other procedure. Smile allows you to do -10 of spherical ablation, and then also allows astigmatic corrections, and a total of 12 is the SE, that is spherical equivalent, that it allows. But frankly, lesser than 1.5 to 2 diopters, the lenticule becomes too thin. And if you're doing a very high ablation, I would do a smile extra. Astigmatism, we regularly now go up till 2.5, 3 diopters, and we get great results as well. Hyperopia is still not commercially available. LASIK has the best range. You can do almost everything with LASIK, including very high astigmatism. And that's one of the big plus things for LASIK, because can be customized and you can do almost everything with LASIK platforms. PRK, we've had 2 good talks. I will not go into the details. There are so many pros. I do a lot of PRK. There are some cons, but then they've kind of gone away. Patient discomfort is not a big concern anymore. Haze is infrequent. It's very rare if you do it correctly. And of course, slower visual recovery. This you have to talk to the patient and make sure that they understand that. We've already seen, all of us have seen these smile videos, they're better biomechanics, but then again, today's talk threw open new vistas. Rohit said that, smile may be less forgiving, and so I think the verdict is not out, which is the most biomechanically stable procedure. Till we have better information, I think PRK still holds as one of the best procedures for biomechanical changes in the cornea. Of course, no flap complications that you would see with smile, epithelial ingrowths, flap striae, with things that we dread, and lesser induced dry eye. And today, wow factor is great with smile. Most patients have great 6/6 vision day 1 or day 2 post-op. The optical zones are more true with less glare and halos, and being a corneal suction, it's a much gentler suction, and no red spots on the conjunctiva for post-op patients, and very good, minimal precautions. We hardly have precautions post-smile. You can almost tell them to take a regular shower from next day and go back to their normal routine. These are the few of the new lasers. So almost all companies are now moving on to lenticle extraction platforms. Eximers have started evolving much less. No new excimer platforms are becoming available now. It's all moving towards lenticule. And we have had talks today on possibility of ectasia with the 3 procedures. So that has to be kept in mind, because that will influence your decision, and the depth of ablations that you might be doing, and the residual bed has to be kept in mind. Dry eye, there's no doubt, smile has been shown to score over all the other procedures, at least in the first month or 2, but by the end of 6 months, almost all 3 procedures show almost similar profile for dry eye. Wow factor, as I said, when you start doing lenticular extraction, you see that patients on day 1 may not be 20/20, but once you cross about 100 eyes, most patients behave almost identical as LASIK, and their visual recovery is pretty good. And post-op precautions we've already discussed are very less. So this makes a lot of difference, because there are people who come in with various demands, like somebody may be getting married in like a week or 2, somebody may be going for a medical interview. So you have to choose what procedure is going to fit some patient the best. Some patients will do better with smile, some will do better with PRK. Some of them come to you saying that I don't want any mark on my cornea, it should not be picked up on slit lamp exam, they're going for a medical. I would obviously offer them a PRK, because post PRK most patients you can't really make out if they've had a procedure, except if you do a topography. So going on, some patients are visiting you from abroad and they want to travel within a few days. I would not want to do a PRK there, because they won't be available for follow-ups. I might offer them a smile over PRK if I have to do that. So I think we've seen the LASIK pros and cons. Full range of treatments are possible. Faster visual rehabilitation possibly than PRK and smile. Excellent track record. We've been doing it for 25-30 years, and enhancements are very easy to perform and easy access to surgeons and cheaper. But also we also know the cons. We just discussed all these possible things, and going on, I think today we wanted to talk about a little bit about Contura. We all know that Contura is a topo-guided treatment. We saw it during live surgery. It's basically a topo-guided treatment for virgin corneas, and it got FDA approval for topo-guided treatments because they were trying to show that it is safe in virgin eyes, and they ended up finding that it does better than conventional wavefront optimized treatments, and that is how Contura was born. And it has advantages over wavefront guided big time, because now we hardly do wavefront guided treatments. We mostly stick to either wavefront optimized or maybe Contura treatments. I'll just show you this one case and I'll finish. This patient was 22-year-old male and was here with -1 sphere and -6 cylinder at 20 degrees in the right eye, -1 and 5.25. We were trying to decide what to offer this patient. Very high astigmatism and symmetric bow ties. The bad maps were normal, and corneal astigmatism was fairly similar to the manifest astigmatism. Corneal thickness was good. These are the bad maps there, and this is the eye trace. And you can see that the internal aberrations are not as many, the mostly corneal aberrations over there, and that's the other eye. And the epithelium maps look good. That's on the anterior. We were checking for whether we should do ICL. We were trying to consider ICL as well over here, We tried to find out that what we should do, then finally decided to go with a Contura based treatment. We have been doing such treatments on wavefront optimized as well over the years, but now with Forcities and using Contura, we found that work comes out well. This is the Forcities planning, which shows you, what will be your treatment plan using the various vectors. And then it comes up with a plan, uses the pentacam data also, in addition to what it measures on the Vario topolizer and what you put as manifest, and then comes up with a recommended treatment, which is really helpful to us now, and we use a lot of Forcities planning for our Contura treatments. This is the other eye. What I wanted to show you was the post-op outcome. Both eyes did pretty well. And post-op, we got better results. We've been getting better results than what we typically get with our wavefront optimized. Post-op, the correction was pretty good. Patient has had great vision. So over the years, that last 3 or 4 years that we've been using the Forcities software, we found that it works very well for such eyes. I won't go to these other cases which I thought to compare between the various procedures because my time is up. But I'll summarize by saying that, I'm sorry about that. Some 3-4 interesting cases were there to show, but with paucity of time, I won't choose. So when to choose Contura over Smile? Hyperopias, because it treats on the visual axis with high astigmatism, significant corneal aberrations, and patient wants it for some reason. Sometimes you have to accept the patient's demand, and then we obviously prefer Smile now for majority of our patients, myopes from 2 to 10, myopic astigmatism. Recently, we've been doing astigmatism more than sphere also and getting great outcomes. Sports persons, professions with higher risk of trauma, borderline dry eyes, those seeking faster visual rehabilitation and physical rehabilitation with less precautions. And we still do a fair amount of PRK, small corrections, thinner suspect corneas, combining with CXL, sometimes with topo-guided CXL, topo-guided PRK with CXL. Enhancements might be good with PRK and professions requiring no corneal scars. We still do LASIK for very small corrections. Sometimes if you do, I don't like to do Smile for below 1.5 to 2. I'll either do a PRK or I'll do LASIK. Those who want quick rehabilitation, I do LASIK for them. Hyperopes, of course. High astigmatism, as we just saw, those seeking almost instant visual recovery. And then if you are trying to customize those treatments, those who cannot afford Smile. So I think no one modality is perfect for every situation, and understanding each patient's need is critical. And all modalities have a place in the refractive surgeon's armamentarium. And yes, Smile is gaining on LASIK while PRK still holds its own. And I think once hyperopic Smile becomes available, indications for LASIK may be even less than what they are today. Thank you.
Thank you, Gaurav. That was really illuminating. And which is one factor which decides that if you have to put one factor as the deciding factor between a Smile and a LASIK?
So I think, I would choose Smile for almost all patients because I don't like to make a flap anymore. Why should I weaken the cornea? It's only when I can't offer a great outcome with Smile when I'll switch to, LASIK. PRK I don't mind doing except they are very big ablations. I offer PRK to almost all patients, and except if the ablation is very high or if the patient can't wait for visual recovery.
So in practical life, economic considerations are also there.
Absolutely. I mean, there are patients who will want, where Smile is a good idea, but they can't afford it, then you'll choose something else.
So I think that is one of the biggest determinant. So we'll go on. I think we have a paucity of time. So the next topic is post-RK and post-LASIK cataract surgery, challenges and solutions. Dr. Tushar Grover. Thank you, Gaurav, for a lovely talk.
So very good afternoon. My gratitude to Dr. Gaurav, Dr. Saurav for having me here. So I'll be talking about post-RK and post-LASIK cataract surgery, the challenges we face and what are the solutions. So I'll be talking about the pre-op, intra-op and the post-op challenges, starting with what we encounter pre-op. So the most significant challenges that you have pre-operatively in these eyes is getting the keratometry and consequently the IOL power right. You also have the challenge of which lens to select and what should be your target refractive error. Now the limitations that our keratometers, placidotopographers, and even the optical biometers have is that they essentially measure only the anterior corneal curvature. They do not measure the posterior corneal curvature. They assume a ratio between the two. They're also blind to the exact corneal center, and even that is extrapolated. So all of this is fine in virgin eyes, but when a cornea has been altered because of laser vision correction, these ratios do not really hold place. So that's where the Scheimpflug tomography helps us, because it is taking into account the refractive effect of the anterior and the posterior corneal surface. The map that I like to use is the Pentacam equivalent K reading map. The reason why I like to use it is because the power is calculated in such a way, the equivalent K readings are calculated in such a way that you can feed them directly into any IOL formula which has a refractive index of 1.3375. So this is what the report looks like. You can see the equivalent K readings in different zones centered at the pupil here. You also see a histogram right below that. Now, when you look at this particular patient, you can see that these K values are quite constant and consistent across the different zones. You also see this histogram, which is like a single, what it's called a Burj Khalifa kind of a peak. So it's a very uniform cornea. The standard deviation across different zones is also very low. So what you can see is that this patient, even though the patient has undergone a refractive surgery, it's a very regular cornea, and that is why I would not hesitate to choose even a multifocal IOL in this particular case. Here again you see that the K values are consistent. There is cylinder here, there is astigmatism. The histogram is also slightly spread out, which you would expect in somebody with astigmatism, but the standard deviation again is quite low. So here again, I wouldn't hesitate to use a multifocal if the patient wishes to, and I would definitely go for a toric in this particular case. On the other hand, when you have a patient like this, you can see that the histogram is extremely widely spread out. The equivalent K reading values are all over the place. The standard deviation is extremely high. So this is somebody you would absolutely not want to put a multifocal IOL in, and not even a toric IOL. So this patient, you would go for a monofocal IOL. So this is how you would choose which lens to implant. And for the power, like I said, you can feed these values directly onto the SCRS online calculator and you get extremely accurate measurements. Now, what should be your target refractive error? When you're operating on a patient that has undergone LASIK, you should target plano, because you don't expect too much post-operative refractive change to be happening. Whereas in RK, you should be targeting myopia, because you expect a post-operative hyperopic shift, and more the number of cuts, the more myopia that you should target. Having said that, there can be unusual case scenarios such as this, where you can see it's an extremely flat cornea, keratometry values as low as 21, 22, 23 diopters, and when you feed these values onto the SCRS online calculator, it refuses to accept the values and tells you to check the values instead, because the lowest value that it would accept for post-LASIK eye especially is 30 diopters. So here I didn't really have a direct way to calculate. One way is to leave the patient aphakic and then calculate subsequently. What I did was I checked how the IOL power values were changing as I went from 31 to 32 to 33 diopters, and tried to extrapolate that information as to how the IOL power would be if the keratometry was 25. So with this, we were left with slight hyperopia, but this was counseled to the patient and the patient was fine with that. The other eye, we were much closer to the target. So moving on to the intraoperative challenges, particularly in RK eyes, you do have the challenge of where to place the incisions. So if you have space between two RK incisions, the incision can be made there, and if not, you should go for a scleral tunnel. In this case, you can see that the incisions are being made in between two RK incisions. Flax can also be done in eyes that are post-RK. One thing that you have to be a little mindful of is that you do sometimes get these tags when you're removing the anterior capsule. You can have uncut areas of the anterior capsule, so be extremely careful when you're removing the anterior capsule here. The other challenge that you do face is sometimes these RK incisions open up, so all you have to do is suture these RK incisions and then you can carry on with your case. Of course, we're seeing a lot of ICL, post-ICL cataracts as well now. The technique that I like to use to remove the ICL is the tuck and pull technique, where you have two blunt forceps in both hands and you tuck and pull the ICL, and this is quite atraumatic and you don't need to enlarge your incision beyond 2.8. Now, post-operatively, particularly in post-RK, one thing that you do face is a slight hyperopic shift soon after surgery. And that essentially happens because the RK incisions have swollen up. There is edema at the RK incisions. And even if you do a corneal topography, immediately after surgery, you'll notice a flattening of the central cornea. So that is why that hyperopic shift is happening. So in that case, it's just important to stay calm and wait. And in a week or so, your RK incision edema is going to settle down and you are going to get to target refraction. So don't be in a hurry if you get a sudden hyperopic shift or a hyperopic refractive surprise soon after surgery. And the long-term hyperopic shift, etc., of course, is going to happen with RK, and you have to plan according to that. Apart from that, refractive surprises are possible, particularly in post-RK eyes and these extremely flat and irregular corneas like I showed. So be mindful of that and counsel the patient for that in these kinds of cases. So to summarize, IOL power calculation is probably the biggest challenge that you face in these eyes, and that's where corneal tomography and the ASCRS online calculator help you get much better outcomes. Post RKIs, you do have that challenge of incision placement and leak incisions during the surgery. And refractive surprises, like I said, are possible. So please counsel the patient for that in the unusual and extremely flat and irregular corneas. Thank you.
Thank you, Tushar.
Thank you.
This is one of the most challenging aspects of cataract surgery, getting a correct power of the IOL.
Yes.
And EKR is a very good indicator of that.
So our EKR is excellent, and I also use the same thing, so we are on the same track. Except that occasionally, you'll have like so flat corneas, like 22, 23 Ks, and then, none of your, kind of, even Ascaris calculator does not take, we had a situation like that. I think Dr. Amrita had presented this case where there was a patient who had both RK and LASIK done, like previously RK, and then for residual myopia, subsequently, another 3-4 diopters of LASIK done. And we were struggling with case of 22, 23. What would you possibly use there?
Yeah, so one of the things is the case that I showed. So that had an extremely flat cornea as well. So what I have done in a few cases is to see how that IOL power is changing as I move above 31. But again, you cannot be very, very accurate. So the only other way I think is to leave the patient aphakic and subsequently do an IOL power calculation. So that, because I don't think intraop aberrometry is also sensitive enough to kind of be able to calculate in these cases.
I'll just bring up a very, I came to Dehradun and Haridwar for a very short while when I finished my residency at RP Center, and I used to work with a brilliant surgeon, Dr. So he used to do retinoscopy and give the IOL accordingly, and he had a trial box and he had special gloves he had made. And I found that very, very, and because in these cases, they would do, doing a retinoscopy would be the best.
True.
So this he was doing 25 years back, his IOL, all IOLs were perfectly calculated, all powers were perfect.
Yeah, that would be.
So, I bring up this topic because he belongs to Uttarakhand only, and
he taught this to a lot of us. When I joined, luckily I had an A scan, but before that, everybody was in Dehradun doing this, and he had spoken this in DOS when I was doing my PG, somewhere in the early 90s, and he presented
so
it.
In spite of all these really, really advanced machines, that is the best method.
Absolutely.
Do a intraoperative retinoscopy.
Yeah, true. I agree.
Okay, thank you so much. Excellent. Now I invite my budding partner, Mayank Pangte. He is going to talk about newer generation presbyopia management IOLs.
Right. Thank you, Tyag. I would be talking about the newer advances in the IOL technology. More of the talk would be into the physics part of the lens, and specifically Vivity kind of a lens. It would be especially interesting for young students to understand how does Vivity IOL work vis-a-vis other IOLs which we know of. So for this, you have to understand the principles of wavefront. We all know what wavefront is and how a straight wavefront gets converted into a circular wavefront when it passes through a synoptic slit. And when two slits are presented, then it makes into a very good, beautiful, constructive and destructive wavefront. So a below diagram is also there, which shows how a wavefront would be focused into a single point when a lens is placed. So the new ions are wavefront shaping. So that is these are a few new terms which you might be listening now more and more. The concept is of wavefront shaping. So we all know how our lenses are, and to keep this topic short, we'll be talking about wavefront shaping. We know how Eyecon IQ looks. Vivity looks almost the same to a naked eye. This is the first wavefront shaping ion, and all the other profiles, visual disturbance profiles, halo profiles, glare profiles are similar to a monofocal ion. That's a good part of it. And it provides you excellent distance vision and intermediate as well as functional near vision. The functional near vision is the important word. So what it does is it has some surface modifications or surface transitions, which changes that wavefront which we were seeing previously in my first slide, and it stretches the wavefront and shifts the wavefront and brings it more to the focus. We just try to eliminate that action. So Vivity ion, if you see on the microscope, you'll find that there are two small stretch surface transition elements on the ion, which is at max 2.2 mm in the center. So there is a first surface transition, which is slightly elevated smooth plateau of just a micron height thickness, which stretches the wavefront. So now you just hear the word stretching of wavefront and then shifting of wavefront. So transition 1 causes the stretching of the wavefront and makes a continuous range of vision. And the surface transition 2, which is the central curvature change of around within this 2.2 millimeter region, which shifts the wavefront, shifts towards the focal point, that is the retina. So when the light, incident light wavefront strikes over the ion, this is what happens. So this is the first wavefront which comes out of the ion. So now the wavefront, instead of being a perfect circular wavefront, you see there is a dip in the wavefront, especially in this area, in the central area, and these are produced because of the surface transitions. So what it does, it causes you an advanced, a wavefront which is a bit in advanced, and a wavefront which is in a delayed form. So there are now two wavefronts which are happening, and what it does, as it moves ahead towards the central point in the retina, you'll find that this wavefront collapses, and it collapses and makes a single continuous area of vision, which is from intermediate to central retina focus, as well as some amount of on the back of the retina. So this is the concept of wavefront shaping. And what these transition elements do is, when we see a monofocal ion, it will just focus right on the center of the retina, with the least circle of confusion being both sides in front and on the back of the retina. So the surface transition 1 causes the same thing and makes a continuous wavefront both in front and in the back of the retina, and the surface transition 2, which shifts this depth of focus which we make here and pulls it apart in front. Instead of there, it pulls it towards the more functional area, towards the central part, and so even the intermediate zone becomes better. The better parts are that now the company has also come with Canarion Vivity, which is a modified ion, which we know, and IQ. This was in the IQ platform, but with Canarion platform, it will become much better. So this is now the concept of wavefront shaping. It's a next generation optical principle. We have to understand the optics of the lens so that you can use it to your benefits. And this gives you a continuous extended range of vision, and this is a functional vision. So the amount of light which is now being focused behind the retina is very less, and whatever it was being focused earlier, now it's shifted in front of the retina because of the surface transition central plateau area, central small curvature change. So the diffraction halo profiles are similar. It has a good defocus curve and provides you good vision acuity. As in my practice, I would counsel these patients and give them a basic flow chart to understand into the options of ion, and give them in blank as what would be the requirements post-surgery. And even ask the counselor to write and recommend, as well give them an estimate form as to what they are selecting before the surgery, so that they are 100% clear of what is happening before. A small bird eye view of the video. And here you will be able to see the beautiful central transitions whenever I will be moving the lens a bit central to plateau areas. And it will be visible when I will be moving the eye to some points. So this is an IQ platform, but in the live surgery we did use the Clarion platform. So IQ material is a bit sticky and tacky, and this is what it is. It will open up, but you can observe the center. Okay, now you can see the transition areas in the center. This is just visible on a slit lamp. On a naked eye, you will not be able to see that, those two transition elements. They are perfectly centered. See the Purkinje images on the iron. So these are adding new values and offering better results. We look forward, we hope the much more nearer visions will be clearer with similar technologies. So this is a concept of wavefront technology which we will be presenting. Thank you.
Thank you, Dr. Mayank. I think extended depth of focus lenses, basically, you are calling it wavefront. Why?
Because it's changing the wavefront into a shape which is increasing the extended depth of. How are we changing the EDOF is the concept of wavefront.
Wavefront itself.
The concept is behind is that.
Okay. Right. And do you have your VVT patients complaining of little halo at night?
No. That is the good part, that profile is of a monofocal iron. Counseling is of a monofocal iron. So your chair time to the patient is very less. You are not talking about glares and halos. All you are talking possibly is about the cost which is involved, which is obviously significant as of today.
Thank you, Dr. Mayank, and we had a wonderful session.
Thank you so much.
Thank you, sir.
And with this, we come to the end of this interesting session. And the next session is a very prestigious one, Dr. MC Luthra Gold Medal. Is the best of best session. So we have free paper session. We selected 9 sessions. We select the best of those sessions. Now there will be best of best that will get the Dr. MC Luthra. With me is Dr. Sushil Ojha, Dr. Trishal, we need one more. Dr. Trishal is there? Okay, can we have the evaluation sheet and... Dr. MC Luthra is one of the pioneers from our state. He was an instrument in starting this Uttarakhand State Ophthalmic Society. And as a young person, we joined here. He just taught us how to hold conferences, how to do this thing. And under his leadership, we were able to hold UPSOS 2 times, then many other conferences very successfully. So those things has been imbibed by all of us, and we carry on the tradition doing that. Who is the first presenter? Any idea? Okay. We have some introduction for Dr. MC Luthra. Saurabh? Okay. So, so Dr. MC Luthra was a great leader. He was also the president of UPSOS. He was the first president of Uttarakhand State Ophthalmic Society. And his leadership qualities, he was able to involve all of us in various conferences, and so we learned a lot from him. And Uttarakhand being a very small state, we were able to hold good conferences here from time to time. So meanwhile, I request Dr. Saksham Mathur to come on the dais. Just wait for a minute. ये ब्लॉक करेगा वो उधर ही बैठना पड़ेगा ब्लॉक करेगा The winner from second session is Dr. Sayukta Joshi. Dr. Sayukta is here? Okay. Then we have Dr. Shweta Parak. From session 4 we have Dr. Priyanka Kumari. From session 5 we have Dr. Chintan Desai. From session 6 we have Dr. Shruti Chal. Okay. Then we have session 7 Dr. Prakriti Pokhriyal. Then from session 8 Dr. Tripti Chaudhary. From session 9 Dr. Rohan Mehra.
Yeah, he'll come, I think.
Vishal, please join.
Please come. I can start my evaluation.
Okay. From there? Okay. Vishal?
So each presentation, like in the earlier sessions, it is for 5 minutes. Yes? So we have all 9 participants are here, so all the best.
Please stick to your time, because that carries a marks also. If you exceed that, gives a negative marking. Please start your time.
Very good afternoon to you all. I am Dr. Saksham Mathur, a final year postgraduate resident from Maulana Azad Medical College. And the topic of my study is comparison of lens and iris parameters in angle closure glaucoma versus open angle glaucoma on anterior segment optical coherence tomography. So why do we need to study about this topic? Because PACG accounts for 50% of global glaucoma blindness, disproportionately affecting people residing in Asia. And crowding of angle due to lens position and shape is an important contributor to the disease pathology. Gonioscopy, as we all know, is the gold standard for assessing the anterior segment and the angle. However, it is a subjective technique with a longer learning curve and requiring contact. So it has been supplanted by non-contact ASOCT, especially in post-COVID situations. ASOCT provides a rapid 360 degrees objective non-contact method of assessing the anterior segment and the angle, with angle closure being defined as an iridotrabecular contact of 180 degrees or more. The aims and objectives of my study was to study lens and iris parameters on ASOCT in eyes with angle closure glaucoma post-iridotomy and to compare these parameters in angle closure versus open angle glaucoma. There is a lacuna existing knowledge. What is that? There is a paucity of data evaluating lens and iris parameters in ACG spectrum eyes of Indian ethnicity. So that is why I decided to take up this study. The materials and methodology. The study group included primary angle closure glaucoma patients requiring either cataract or a combined cataract and glaucoma surgery at any stage of disease. That is primary angle closure suspect, primary angle closure or primary angle closure glaucoma. And the control group included age and gender matched open angle glaucoma patients requiring just cataract surgery. Our informed consent was taken from each patient and they underwent ASOCT by a Acacia 2 machine in a semi-dark room, and the horizontal 0 to 180 degree angles were analyzed. These are the parameters that I evaluated in my study. The lens parameters included the lens vault, the lens thickness, anterior vault and the relative lens vault. Iris parameters including iris curve, iris area, iris thickness at 750 and at 2000 microns. Angle parameters including angle recess area, angle opening distance and the trabecular iris space area, anterior chamber depth and the iridotrabecular contact index. This is a Acacia 2 picture of a patient showing the lens vault, which is the perpendicular distance between the horizontal line joining the two scleral spurs from the anterior pole of the crystalline lens. Other parameters seen in this figure are the anterior chamber depth and the anterior vault, which is the measurement of sum of lens vault plus anterior chamber depth. These are some other pictures of the machine. These are the angle and the iris parameters that I evaluated in my study. Coming to the results, I included 32 eyes with open angle glaucoma and 81 eyes with angle closure glaucoma, and here are the results. The lens fault was found to be significantly higher, that is 0.589 in ACG as compared to only 0.198 in OAG. The relative lens was also found to be higher in ACG. The lens thickness, as expected, ACG patients have a bulkier lens, which was corroborated in my study. The lens thickness was higher, and anterior chamber depth was found to be shallower in ACG patients. Iris parameters, the iris curve and the iris area was found to be lesser in ACG. The iris thickness at 750 microns was found to be higher in ACG patients, but at 2000 microns, the iris thickness was almost similar in both the groups. The iridotrabecular contact index was significantly higher, that is 28% in ACG patients, as expected because of the synechial angle closure we expect in angle closure glaucoma. These are the angle parameters. As expected, ACG patients have a narrower angle as compared to OAG patients who have a wide open angle, which was found to be corroborated in my study, and all the results were statistically significant. The conclusion is that ACG patients have a larger lens fault, 0.589 compared to OAG, a greater iris thickness, less iris curve and iris area, and a significantly higher ITC index. This is a slit lamp picture of a patient with a very high lens fault, that is 1.33. As seen in the picture, we see a bulky lens with a shallow anterior chamber, and as seen in our ASOCT picture, the lens fault is 1.33. The limitations of my study was that there was a significant sample size difference between ACG and OAG group. The ASOCT was done post-laser PI. So laser PI alters the iris and the angle parameters, which I am trying to correct in my further study, where I am including ASOCT doing pre-PI instead of post-PI. And there was a problem in scleral spur identification in some of the patients. Now this study is not something new. It has been done previously. So we need to imply it in a clinical life also. Thank you.
Thank you for such a good report. I think Dr. Saikta, you have to be here. And do you think it's a substitute for ASOCT can substitute gonioscopy?
No, sir. It can only supplant it. It can never replace it.
It's more for documentation and
yes, sir.
Plus you have some advantages.
Yes, sir.
We can take a photograph also, but does it offer certain more advantages?
Sir, ASOCT over gonioscopy. So it is a non-contact method, so especially in post-COVID situations where we don't want that much contact between doctor and patient, we can use it as a, not as a substitute, but as to just confirm the diagnosis or to show the patient, counsel the patient regarding the treatment. Right. But gonioscopy is the gold standard, it can never be replaced by ASOCT.
Thank you. So our next speaker is Dr. Sanyukta Joshi, and meanwhile I request Dr. Shweta Parekh to be here on the second podium.
Shall I start?
Yeah, please start.
Good afternoon, everyone. My name is Dr. Sanyukta Joshi, and I'm going to be speaking about the implantation of toric implantable Collamer lenses in post-keratoplasty pseudophakic eyes for the management of residual astigmatism. I have no financial interest to disclose. So one of the most important challenges that are faced post-penetrating keratoplasty is the high post-operative astigmatism of up to 5 diopters or more. And due to this, the patient is never fully satisfied. So what can be done for such patients? We can think about spectacles, but they cause a lot of higher order aberrations, and again the patient is not satisfied. We can think about contact lenses, but such patients usually have some amount of dry eye, they are old, so contact lenses are not tolerated well, plus the compliance is a huge problem. We can think about limbal relaxing incisions or arcuate keratotomy, but they are quite unpredictable to correct the high astigmatism, and you have to make them on the donor graft, so they pose a risk of wound dehiscence. We can think about corneal refractive surgery procedures like LASIK or SMILE. Again, they will cause some amount of risk of wound dehiscence, and they cannot be done in thin corneas. So we thought about using toric implantable Collamer lenses, fitting it as piggyback lenses in the ciliary sulcus on top of the existing PCRs which were in the bag in these cases to correct the post-keratoplasty astigmatism. So we did a study to compare the outcomes of this in the patients for correcting the residual astigmatism. We enrolled 15 eyes of 15 patients satisfying certain inclusion criteria, like they had to have undergone penetrating keratoplasty and was pseudophakic in that eye. They had a normal anterior chamber depth, a normal intraocular pressure, a good endothelial cell count, and a normal posterior segment. Here I'm discussing one of those 15 cases. He was a 79-year-old male who had undergone PKP for corneal opacity 1 year ago. As you can see, the refractive error, he had -4 of spherical and -5 astigmatism. All other parameters were normal. He had a PCIL in the bag on slit lamp evaluation. This is his pentacam. As you can see, there is a high post-PK astigmatism, and see the normal anterior chamber depth of 4.56 mm. So a measurement of white-to-white diameter was done using calipers at slit lamp, and a decision was made to implant a toric ICL of size 12.5 mm by ICRL. I've already done the 0 to 180 degree marking. I do my toric ICL marking, confirm it by my bevel gauge marker, make a temporal entry at 180 degrees, form the anterior chamber with viscoelastic. Then I'm going to form the ciliary sulcus because that is where I intend to implant my toric ICL. This is the toric ICL, ICRL by Biotech. I load it in the injector. Observe the PCIL reflex already in the bag. I inject the ICL completely in the anterior chamber first. Then I'm going to use a dialer to gently tuck the two leading haptics first under the iris in the ciliary sulcus, left and the right. Then I do the same with both the lagging haptics, and then I rotate it according to my toric markings. This is the 1 month post-op picture, best corrected vision of 612, clear graft, quiet anterior chamber, normal pressure. We also carried out a visual function index survey pre and post-op, pre when the patient was using spectacles and post after the toric ICL procedure. The patients showed very high satisfaction when they were fitted with the toric ICLs because the higher order aberrations had greatly reduced. This is a graph comparing the pre and post-op distance visual acuity. Of course, the post-op is much higher. Comparing the two spherical equivalents, the post-operative spherical equivalent will show a drastic decrease in the astigmatism. In two cases, we did have some side effects, like in one case, there was some rise in intraocular pressure. In the other, there was some amount of iris pigment dispersion, but very easily managed with topical medications. There was no other side effects noted on the graft or the pressure or the depth of anterior chamber. So the take-home message is that when you have a patient who has undergone PKP, has high PKP astigmatism, and if the patient is phakic, you definitely go for a toric IOL. But if the patient is pseudo-phakic, you must consider a toric ICL, implanting it in the ciliary sulcus, like a piggyback IOL. The patient will show very high patient satisfaction because they will have total spectacle and contact lens independence, and they will be rid of the higher order aberrations. Thank you for your attention.
Excellent.
Dr. Sanyukta, you implanted toric before all the sutures were removed. Do you think it should be done after the suture, all sutures are removed, then toric implantation be done?
Thank you, sir.
You showed the sutures were still present, keratoplasty.
Right, sir. So initially when the patient showed post-PKP astigmatism, we tried to go for non-surgical intervention. So what initially we did was we tried to remove the loose sutures. We tried to see if...
Surgery you showed sutures were still there and you implanted a toric
So we only did this procedure in someone in whom the astigmatism had stabilized over 1 year. We never did it before 1 year post-PKP. And in that case also, whatever sutures we could remove and we observed the change in the astigmatism, we found that there was absolutely no, there was still a large amount of residual astigmatism that needed to be corrected. And then we decided to go for surgical intervention. So we did remove a lot of the sutures we could remove.
Why didn't you remove all the sutures and waited for 6 months and for us to settle and then do the
So we removed whatever sutures on the axis of the astigmatism, which we thought were causing the astigmatism, and even after removing, so the astigmatism did reduce. So certain patients, suppose they had a -6, so it did come down, but then it stabilized. So we thought of...
suture-related problems.
Right.
So
Point taken.
that will again, so I think ideal would have been that
to remove all the sutures.
If you would remove the sutures, wait for 6 months for cornea to regain its normal contour and then remove.
Okay, point taken.
There's one more question. Why did it use this piggyback IOLs? They are supposed to be specific for this thing. I think ICL or FPCL is a little costly.
Right.
And second, once the you take out, phakic is good.
Yes.
But once in care with the pseudophakia, the chamber is much deeper and there are chances of rotation of these lenses. So why not to choose a piggyback lens which is specific for this reason?
Why did we go with the ICL per se? Like why didn't we go with the Sulcoflex? Like piggyback lenses designed to place in the sulcus.
Even you could use the Indian one, Sulcoflex.
So in this we did use the Indian. We used Icryl by Biotech. Like we didn't use Star Surgical.
Why to choose ICL when you got a specific IOL for that? There's a piggyback IOL that's giving a very, very good result.
Right. So actually we chose ICL for the simple reason that it has the central aqua port. So we didn't have to make a PI or anything, and we wanted to place them in sulcus. So we thought that because they have the pre-existing mechanism, they would probably not cause any post-operative side effects.
See, it's not required PI with the pseudophakic IOL also, or the piggyback IOL also.
Right.
We don't require it. They are more specific, and long-term study ICL, IPCL is not there.
Right.
So what will be the rotation stability there? We are not very sure, because the anatomy has changed at all. When the phakic eye or pseudophakic eye is quite different. Anyway, it's a good, I think, good alternative.
Thank you, sir.
Thank you very much.
Thank you, sir. Thank you, sir.
Dr. Shweta, please.
Good afternoon, everyone. At the outset, I would like to thank UKSOS for the opportunity to present this paper. So a 31-year-old male complained of pain in the right eye for 3 days and floaters in the right eye for past 4 months, and he presented with elevated intraocular pressure, anterior uveitis, and vitreous cells 2+. The left eye was essentially normal. So at its initial presentation, we could see a few snowballs in the right eye in the inferotemporal quadrant, along with active and healing chorioretinitis seen as hyperautofluorescent lesions in the ITQ. And in the SNQ, we could see a hypo-AF healed chorioretinitis patch. The left eye was normal. Investigations revealed strongly positive MANTO tests and findings on CECT thorax. The patient was started on ATT and systemic steroids, along with topical steroids and AGM. By the second week, the patient showed a reduction in the inflammation along with resolving snowballs and a healing chorioretinitis patch in the inferotemporal quadrant seen as stippled hypo-AF. However, by the 7th week, the patient complained of severe pain in the right eye for 3 days. We noticed a new elevated subretinal yellowish lesion in the inferonasal quadrant, which on OCT showed a massive choroidal elevation, overlying subretinal fluid, and outer retinal involvement. At this point of time, we ruled out posterior scleritis by performing a B scan, and our differential diagnosis included choroidal abscess, fresh choroidal granuloma, or paradoxical worsening. The same line of treatment was continued at this point of time. However, by the next week, the patient complained of intense persistent ocular pain, blurring of vision in the superior hemifield because of inferior massive exudation, and the lesion showed a massive increase in the size. At this point of time, oral steroids were stepped up to 60 milligram per day, along with continued ATT. The chest CT scan did not show any new pulmonary lesions. The following week, the patient was better, and we could see a reduction continued reduction in the size of the granuloma and resolving SRF. By week 16, there was a slow taper of oral steroids was performed, and MMF was added, immunomodulator, and by 6 months, ATT was completed. At the latest 10-month follow-up, the patient was in remission with a resolved choroidal granuloma. Paradoxical reaction is defined as an initial improvement in the findings after initiation of ATT, and a paradoxical worsening after either at the primary site or at new sites during or after ATT. It is important to rule out poor compliance, drug malabsorption, drug resistance, alternate diagnosis. It is reported in systemic TB, of course, and in about 14% of patients with ocular TB. The pathogenesis is similar to the JH reaction with the release of mycobacterial antigens due to bactericidal ATT. delayed hypersensitivity, and decrease in immunosuppression mechanism. Also, it is important to note that rifampin also increases the plasma clearance of prednisolone by 45%. There are multiple reports of paradoxical worsening, mostly in serpaginoid chorioretinitis, in panuveitis, in vasculitis, intermediate uveitis. Very few cases of choroidal granulomas have shown paradoxical worsening, and in both of these cases that have been reported, there has been a recurrence from the original lesion, not in a new site. The management of paradoxical worsening depends on increasing steroids and adding immunomodulatory therapy. It is also important to rule out incorrect diagnosis and drug resistance. These are my references. Thank you so much.
Thank you. If there's no systemic tuberculosis, do you still start ATT? Or?
Yes, sir. So like ma'am has reported the landmark study, like we were seeing yesterday at Dr. Vishali's oration. Now there is a consensus on that, and in India it's mostly on the basis of MAN2 or IGRA and chest CT or chest X-ray imaging. It is difficult to convince the pulmonologist, but we managed to do that in most cases.
That's important message, I think. The next speaker is Dr. Priyanka Kumari.
Good afternoon, everyone. Myself, Priyanka Kumari, Junior Resident from Regional Institute of Ophthalmology, Sitapur, is going to present a study on the visual outcome in eyes with posterior capsular rupture during small incision cataract surgery done by SICS trainee doctors. The place of my study was at Regional Institute of Ophthalmology, Sitapur. Exclusion criteria in my study was any patient with history of previous intraocular surgery, significant corneal edema, uveitis, glaucoma, high myopia, and posterior polar cataract. After proper general and ocular examination, 1,629 cataract patients of 15 to 80 years age group underwent manual small incision cataract surgery with 6 mm polymethyl methacrylate lens implantation during 6 months by SICS trainee doctors. 52 cases among them developed posterior capsular rent. Among these, 37 were males and 15 were females. Stage at which PCR occurred and whether vitreous prolapse was present or not were noted and dealt accordingly. Adequate anterior vitrectomy was done if needed. These cases were examined on next day, 7th day, 1 month, and at 3 months post-operatively. Post-operative complications were treated accordingly and best corrected visual acuity was noted. The maximum percentage at which PCR happened was at the steps of irrigation and aspiration, which was 63.46%, followed by nucleus delivery, which was 28.84%, followed by hydro procedure, which was 5.77%, and in steps of IOL implantation, it was 1.93%. There were different sites of IOL implantation. In posterior chamber, in 33 cases it was implanted in posterior chamber, 15 underwent SFIL and 4 were left aphakic. Complications were noted within 7 days and at 30 days. 33 cases had residual cortex, 27 had iritis, 22 had corneal edema, 22 had strat keratopathy, 14 had vitritis, and 8 had pupillary capture. There was resolving iritis in 8 cases. At 30 days, 3 cases had persistent corneal edema, 3 cases had vitritis, 6 had cystoid macular edema, and 3 were having dislocated lens. Best corrected visual acuity was noted at 90 days. 63.46% had visual acuity of 6/6 to 6/12, 26.92% had visual acuity of 6/18 to 6/36, and 9.62% had visual acuity of less than 6/60. This is a summarization of my result. The total incident of posterior capsular rupture in my case was 3.20%. Most common step at which PCR happened was at step of irrigation aspiration, and best corrected visual acuity more than 6/12 was noted in 63.46%. According to the previous similar study done by Balland et al. In 1988, In extracapsular cataract extraction, the most common step for PCR was at irrigation and aspiration, and BCVA more than 6/12 was noted in 54.8%. The study done by Chand et al. In 2003 in phaco emulsification, most common step for posterior capsular rupture was irrigation and aspiration, and best corrected visual acuity more than 6/12 was noted in 70.4%. Similar study done by Arvind Eye Hospital in 2006 in phaco and SICS, most common step for PCR was in irrigation and aspiration, and best corrected visual acuity more than 6/12 was in 6.8%. In our study, which was done in 2022 for SICS, the most common step was where PCR happened was at step of irrigation and aspiration, and best corrected visual acuity more than 6/12 was in 63.46%. Hence, by study, we concluded that PCR is a dreaded complication, so care must be taken during each step of surgery to prevent it. With adequate intraoperative and postoperative management, good visual outcome can be achieved. Thank you.
The PCR, after happening PCR, the cases were taken over by the senior consultant or?
No, sir, by senior consultant.
Same consultant in all cases or?
No, different consultant.
Okay.
Those who are being present at the time of...
Someone is supervising the surgery. All the surgery is done under supervision and senior consultant took over.
Sir, 6 months it is done under supervision, and then after that we can do independently, but one senior consultant is there in...
In your study, the resident complications were managed by resident only or senior consultant?
Senior consultant, sir.
And same different consultant?
Yeah, different consultant.
Did you check for the post-operative glaucoma in these patients when finding out the visual outcome?
Sir, glaucoma?
Post-operative glaucoma, yeah, because you have had a vitreous loss and all that, there are high chances of post-operative IOP rise.
Sir, we did not check for glaucoma. There was endothelial decompensation we noted.
So what does your study proves?
Sir, my study proves that if we go for intraoperative and postoperative management properly, then in PCR patient also a visual outcome can be achieved better.
Thank you very much.
Thank you, sir.
Can we have the next speaker, Dr. Chintan Desai?
Good morning, one and all. Today I'll be presenting a topic which has been fascinating for us retina surgeons since a very long time, improving the outcomes of macular holes. In fact, there was a time not long ago when sympathies and empathies were all we could offer to patients of macular hole surgeries. But then that changed, and now we have a 5-step procedure where we do a vitrectomy, remove the anterior-posterior traction by removing the posterior hyaloid, remove the tangential traction by staining and removing the ilim, and do an FAX or a gas with face-down positioning. But unfortunately, there is still a 6th step. There was still a 6th step which used to exist, and that was... Sorry, the music's not playing. And that was praying to the Lord at the end of the day that the hole would close the next day. So the high failure rate was because of various reasons such as the size, macular hole index, tractional hole index, and cystoid spaces. That's why newer techniques were invented, and the latest one which was invented is the inverse ilim peeling, where instead of removing the ilim in toto, we place the flaps over the macular hole so that it gives the necessary fibrocellular network for the macular hole to close. This improved the results significantly, but still there were cases where the flap used to get dislodged while trimming or post-operatively get displaced, or even during an FAX it got displaced. So different surgeons started using different viscoelastic substances to keep the flap in place, but it was never really sufficient. Having faced similar issues, I came across a journal club, a paper in one of the journal club discussions where Vishal and all, they said that they used PFCL which changed the consistency of the membrane, making it very sticky. And they said that they have an astounding 100% closure rate with their technique. And there was no better way to verify it than doing it myself. So this is, I'm sorry. Is the video playing? Yeah. So this is one of the cases where I did this surgery. So this is a 63-year-old female with a medium to large macular hole, 57 microns was the minimal hole diameter. After doing a normal vitrectomy, I start peeling the eyelid after staining it in a conventional manner without using PFCL at this stage. And as you can see, I'll be making 3 flaps. So this is the first one, which has been completed. Then this is the second flap, which is being peeled and put over the hole. And this is the final one. Once all the flaps are in place, the rest of the ileum is removed in a conventional fashion. Now you can see once the PFCL bubble is injected, the consistency of the membrane has changed completely. It's lost its elasticity, it has become very sticky, and it is very easy to maneuver it on top of the macular hole. It is important not to stuff it inside, just place it gently over the hole, followed by fluid air exchange. And during the fluid air exchange, again, it is important not to touch the PFCL bubble first, but remove all the other fluid. And in the end, as you can see here, the PFCL bubble is being removed. And the flap did not move at all. This is post-op 1 month, so a good outcome was achieved for this patient. This encouraged me to do a study where I operated on 57 eyes, 36 PFCL assisted and 21 conventionally. All comorbidities were excluded, all the holes were at least 400 microns in size. As you can see here, the average mean diameter is 600 microns. Anatomical closure, the type of closure, the presence or absence of any gliosis due to PFCL was studied. So as you can see here, these are some of the examples. The first OCT shows the hole has not closed. The second one has a type 1 closure, all layers are reconstituted. The third one is type 2 closure, where the inner retinal layers are not reconstituted. And the fourth one shows a closure with that hyperreflectivity in the center, which is suggestive of gliosis. So coming to the results, I did actually get a 100% closure rate in those 36 patients where I used PFCL, similar to the original paper. The second thing is the type 1 closure was non-inferior, so visual acuity was not affected, and there was no extra incidence of post-operative gliosis in these patients, making PFCL safe to use. In fact, there were no flap-related complications when you compare it to the other technique where the flap used to get dislodged or displaced. In this technique, there are no flap-related complications whatsoever. So why do this? Why are we are getting a 90% success rate with conventional ileum peeling and inverse ileum peeling? So why do this? Because we want predictability. We want to be sure that we move from the 90% to 100% where all our holes are closing, and we want to have that belief that irrespective of the size of the macular hole, we can close it. We can do this without having to face any complications pre-op, per-op or post-operatively, even in long term. And there is no compromise on visual acuity because it is not causing any gliosis, and PFCL is safe to use over here. And most importantly, we are doing it for a good night's sleep, because once we've operated, we want to make sure that the next day, irrespective of what we do, irrespective of the size, the hole is going to close. And nowadays I've stopped using gas. In fact, I adjust to a fluid air exchange for medium-sized macular holes, and the hole closes the next day itself. So it is a very safe technique, very useful in medium to large macular holes, and it is the next big step from going to from 90% to 100% success rate. Thank you so much.
Thank you so much. And my question is, while I'm seeing your OCT, your angle alpha and beta were not the same.
Yeah.
So you were putting a regular flap there, or you're changing the shape of flap?
No, sir. The flap, I'm not putting it inside the hole at all. Yeah. I'm just placing the flap over the hole and not stuffing it inside, so the flap does not change the shape of the retina anyway, of the macula anyway whatsoever. It is just that when the hole closes, sometimes the growth happens in such a way that it is not perfectly symmetrical. It has nothing to do with the flap that we are using.
Okay. Dr. Saurabh, any comment?
So I've been using this technique as well, but instead of the soft tip, I've been using the finesse loop. Yeah. And I find that it is also very atraumatic, because sometimes what happens is that when you're using the soft tip, sometimes if you're not careful, you will create a negative suction and you'll suck off the flap.
I've started using the ileum forceps now. I don't use the soft tip anymore.
So I've gone through all those stages, even use the closed forceps, the back tip of the closed forceps. Sometimes it can touch the edge of the hole, create a hemorrhage or something like that. True. So I found that with the finesse loop, it was the best way and the least traumatic way to, just push the flaps towards the hole, like you said, not stuff it, just appose it onto the hole and it closes.
Yeah. and it does not move at all. And one more thing which I changed from the original paper is they use PFCL for peeling as well. I'm peeling the ILM in a conventional manner without the PFCL and then injecting the bubble for a very short while, 5 to 10 seconds, and placing the flap and removing the PFCL. So the PFCL is not causing any side effects whatsoever.
Right, we use it for a very short, for the initial peel you don't need PFCL.
No,
it's
yeah.
only for the, the flaps to stay put.
Yes, sir.
And what
Dr.
causes
Shruti
flap
said-
not to get dislodged?
Sorry, sir?
What causes flap not to get
The
dislodged?
PFCL changes the consistency of the flap, so it loses its elasticity,
And
makes
then-
it sticky
and
and
then
loses.
what keeps it in place exactly over the hole?
Yeah, exactly, sir. The ILM by itself is sticky, so the ILM can stick to each other, but it does not stay on top of the hole. When we do a fluid air exchange, it sort of tends to shift away from the hole. And also, for doing that, we need, while doing vitrectomy, we need to trim the flap sometimes if we are not using PFCL. So while trimming the flaps also, sometimes it can inadvertently come out. So by using this, we are avoiding all those complications, and the flap remains very sticky and it is non-elastic, so it does not move anymore. It remains in place even till the end of the surgery. Next day, you can actually see the flap on the top of the hole.
So, sir, actually there is a redundant layer of very thin film of fluid around the hole when we are, finishing the macular hole surgery, and when you put the flaps in, they have a tendency to unfurl because of that very thin layer of fluid over there. So with PFCL, you are not, leaving that fluid pocket. So when the flaps are put inside, they will not, inside the opposed, they will not move back. And I'm using intraop OCT to intraoperatively see that the flaps are in place at the end of surgery also, even when I've removed the PFCL. So intraop OCT also I'm using in addition to the PFCL.
Thank you. Thank you so much, sir.
Can you have the next speaker? Meanwhile, you can sit there. Next speaker, you can.
Dr. Prakriti Pokhriyal, please start your presentation. Then we will go on. Dr. Shruti. Prakriti, can you start your presentation if you are ready?
And we will connect that one.
I am presenting a unusual case of collision tumor in lower lid.
Can we have the display?
A case of 60-year-old male came to complain of redness since 1 to 2 months, history of black nodular crusting at margin of left lower lid since 7 to 8 years, which is repeatedly scratched off manually. Recurrence at same site, no history of any significant medical illness. On examination, a melanocytic ulcerated eyelid margin involving punctum, hyperpigmentation in continuity on lateral aspect. Clinically provisional diagnosis was made of basal cell carcinoma. On investigation, incisional biopsy was taken, core biopsy in 3-layered, and sent it for histopathological examination. On histopathologically, there were diagnosis of nodular basal cell carcinoma was made. Then we done a wide local excision with decrocystectomy, and the tissue is sent for histopathology, where we found that the histopathological examination shows there is squamous cell carcinoma. All margins were clear and lacrimal sac was free from tumor. So because the previous shows the basal cell carcinoma and the other one shows the squamous cell carcinoma, we gone for a second opinion and slides was reviewed. And for confirmation, we gone for immunohistochemistry. On first slide, there was expression of BUR EP4 and P16, and there was negative for EMA, which is suggestive of basal cell carcinoma. And on second slide, there was highlighted EMA and negative BUR EP4 and P16, which is suggestive of squamous cell carcinoma. Then the final diagnosis was made left lower lid basal cell carcinoma with moderately differentiating squamous cell carcinoma, which is a collision tumor. Systemic evaluation PET-CT, a whole body done, there was no systemic metastasis. Discussion: collision tumor is a coexistence of two diagnostically distinct tumors in a common anatomical space. Several theories was made. The simultaneous proliferation of two different cell lines, a common origin from a pluripotent precursor cell that would differentiate in two components, or the casual development of two non-related tumors. Risk factors, there are genetic predisposition, old age, exposure to environmental carcinogens, previous treatment with radiotherapy or chemotherapy, immunosuppressions. The finding in imaging and research studies do not confirm the existence of collision tumor, the latest being histopathological incidents. 85 to 95% of eyelid cancer in non-Asian countries are basal cell skin cancers, and estimated 70% of these cases occur in the lower lid. Squamous cell skin cancer makes up 5% of all eyelid cancer. Allen D. et al. Reported a basal cell signet ring squamous cell carcinoma in eyelid in 2006 earlier, and our case is second case reported worldwide of basal cell and squamous cell carcinoma in eyelid. For increasing accuracy of diagnosis and management, a thorough clinical examination and detailed histopathological analysis with immunohistochemistry of specimen with a proper multidisciplinary discussion are the prerequisites. With regular follow-up can help to treat the patient effectively. Hence, core biopsy in multiple layers play a vital role in establishing the accurate diagnosis of the suspicious lesion. Thank you.
Do we have data on Asian population also for eyelid tumors?
So, actually, I reviewed the literature, but there is only the data is given for the non-Asian countries.
Thank you.
Thank you, sir.
Dr. Ekta, ready on the next dais, please. Shruti, you can start.
Yes, sir. Good afternoon all. The topic I will be presenting today is comparison of white-to-white measurements using the 4 devices and the determination of ICL sizing by measuring the post-operative vault. The phakic intraocular lens is used as an alternative to corneal refractive surgery. The posterior chamber ICL by Star Surgical was developed in 1993 and FDA approved in 2005. For proper ICL sizing, several parameters have been investigated, but white-to-white remains an important step in ICL sizing and is required by the online calculator of the manufacturer. But different devices provide different white-to-white measurements, so it is difficult to choose which value we should use. So the purpose of our study was to compare the white-to-white measurements from different devices like Pentacam, iTrace, LensStar, and digital caliper, and its effect in determining the correct size of ICL by measuring the post-operative vault. We used a retrospective cross-sectional study of 98 eyes of myopic patients, and white-to-white was measured on different devices and compared with the caliper white-to-white, which served as a baseline. The post-operative vault was measured after 1 month. The result of our study was the mean white-to-white varied significantly between the devices. The range of digital caliper white-to-white varied from 10.8 to 12.6 mm, with a mean of 11.6, and it was most comparable with the Pentacam mean white-to-white, which was around 11.84. The LensStar had the largest mean white-to-white, while the iTrace had the smallest mean white-to-white. The pairwise comparison between showed that the mean difference was the smallest between the Pentacam and the caliper, and the largest between the caliper and the LensStar. The Blonde-Altman analysis between the Pentacam and the caliper on white-to-white measure showed a mean difference of 0.18 mm, and the limits of agreement was around minus 0.446 to 0.83 mm, and it has a high correlation coefficient of around 0.693, which implied a very good agreement. The figure also shows that almost all the data points are within the limits of agreement. The caliper versus LensStar showed a high correlation of 0.8, but a higher systemic bias of minus 0.38. The caliper against iTrace showed a correlation of 0.64 and a systemic bias of minus 0.36. So among the 3 pairwise comparison, the Pentacam and the caliper had the lowest systemic bias of just 0.18 and had almost all the data points within the limits of agreement, and many of the data points were near the line of equality. In our study, 65% of eyes achieved a wall between 250 to 750 microns within 1 month, while approximately 10% had a lower vault of less than 250 microns, and 25% eyes achieved a vault of more than 750 microns in a month. The shallowest vault was around 0.14 mm and 0.24 mm, while the deepest vault was around 1.31 mm. So to determine the accurate ICL size, there are different parameters like sulcus to sulcus, which is measured by UBM, and the crystalline lens rise, which is measured by ASOCT, but manual white-to-white measured by the digital caliper still remains the gold standard. But the major dilemma faced is which one of these devices can provide data that would result in ideal post-operative vault. In the beginning, the STAR recommended white-to-white measured by the OpScan 2 for ICL size, but it is no longer available, and so the NEO devices are being used now. The previous studies have compared white to white from different devices, and the study most similar to ours was by Bomeston et al., which evaluated caliper, Opscan 2, and IOLMaster 500. And they found that measurement by the caliper was examiner dependent and varied significantly. They also observed that mean white to white with IOLMaster was higher than the Opscan white to white. In our study, the pentacam white to white yielded an ICL size similar to that of caliper in almost 86.66% of eyes, while the Lenstar and the eye trace yielded an ICL size in 71% and 66.6% eyes respectively. Post-operative caliper and the pentacam white to white yielded high percentage of eyes with desired vault. Purely using Lenstar or eye trace data would likely recommend a larger or smaller ICL size, which could lead to an undesirable high and small vault respectively. The conclusion of our study was that white to white measured by the 4 devices varied significantly, which led us to conclude that white to white measured from these devices were not interchangeable. We tried to determine which one of these devices had the highest likelihood of measuring white to white that can calculate ICL size, which would result in desired post-operative vault. If we consider manual measurement by digital caliper as the baseline, then white to white measured by the pentacam comes closer to it as compared to the other newer devices to calculate ICL size, which can achieve desired post-operative vault. Thank you.
So you think digital and pentacam are quite close?
Yes, sir.
And more consistent. Gaurav, any take on this? White to white for ICL. We got a different instrument, different readings.
Actually, we've been studying all these devices, also the 700 now, but because 700, IOLMaster 700 is relatively new with us, about a year, so we didn't have enough data. We've also been comparing that. But what we found was that the pentacam comes closest to the digital calipers, and that is why we are now using them almost interchangeably, because both of them gave, in our study, of almost these 96 eyes, they gave almost consistent vault size calculation between the two. So that was the purpose that, if we have to use one device, which should it be? Amongst these 4 devices that we studied, we found best correlation with pentacam, white to white.
Thank you. Thank you, sir.
Dr. Tripti, please start your. Dr. Rohan, meanwhile, get ready for your presentation on the next dice.
Good afternoon.
Dr. Rohan.
Good afternoon, everyone. I will be presenting a rare case of bilateral optic neuritis as presenting manifestation of lymph node tuberculosis. A 23-year-old lady presented to us with history of sudden onset diminution of vision, loss of vision in the right eye since 4 days. The vision at presentation was PL denied in the right eye. There was no history of headache, vomiting, or altered sensorium. There was no history of redness, pain, or trauma. There was history of malaise for 15 days with progressively increasing painful swelling over the right neck. She did not have any hearing loss, facial deviation, nasal regurgitation, weakness of limbs, or involuntary movements. There was no history of loose stools, vomiting, or dysuria. There was past history of neck swelling in the right side, which had subsided with oral medication 4 years back. No past history of hypertension, diabetes mellitus, cerebrovascular accidents. There was family history of tuberculosis in the husband who had been on ATT 1 year back. He had taken the full treatment and had recovered. She is married and has 2 children, 7-month-old twins. There was no history of abortion. Menstrual history was normal. She did not have any high-risk sexual behavior. Her diet was poor in carbohydrates and proteins. She did not have any addictions and did not consume any toxic substances. The patient was thin-built. On examination, she was afebrile. There was mild pallor and cervical lymphadenopathy was present. As you can see, this is the cervical lymphadenopathy. On systemic examination, there was no positive finding on including the nervous system and the respiratory system. On local examination, there was a 5 to 5 centimeter swelling, which was nodular swelling, which was mobile over the submandibular region, and there was mild tenderness associated with the swelling. On ocular examination, her visual acuity was PL negative in the right eye. In the left eye, it was 6/12, which was improving to 6/9 on pinhole examination. Rest of the examination was fairly normal, except for the pupils, which had a relative afferent pupillary defect in the right eye. Fundus showed media was clear, but disc margins were blurred and raised. So this is the right eye fundus photograph. We don't have a fundus photographer as yet, so that's why we have taken the video. And as you can see, the pupil is mid-dilated, and the disc margins are blurred and raised, and there is extreme tortuosity of the vessels. In the left eye, we can see the disc margins appear to be blurred, and there is splinter hemorrhage over the superior aspect. So a differential diagnosis of papilledema was done, and the patient was a secondary diagnosis as bilateral optic neuritis we had kept. So on investigation, chest X-ray was normal. She was mildly anemic. Hematocrit was reduced. MRI showed normal gray matter, white matter differentiation, and rest of the tests were normal. On investigation of the FNAC, there was richly cellular centrocytes with caseous necrosis. Zn-steen was positive for AFP. She was started with injection methylprednisolone 1 gram, IV infusion for 30 minutes for 3 days, followed by oral prednisolone 1 milligram per kg body weight for 11 days. And tablet acetazolamide was started. After the FNAC report, ATT was also started on day 3. So the patient, at the end of the 3 days, her PL had turned from PL negative, she was PL positive, but PR was inaccurate. And in the left eye, the vision was same. After third day, this is the fundus photograph. The edema seems to have reduced in size. Margins are a little well defined. In the left eye, this edema has resolved, not resolved completely, but the margins were more regular, and you can see the splinter hemorrhage. So after 15 days, the patient came to us with follow-up. Her vision had improved in the right eye to 6/9. There was no RAPD. As you can see in this small video. So what could be the possible cause? So we made a diagnosis of bilateral optic neuritis, and the possible explanations could be that because of the immune reactions and all, she developed it. So visual recovery from tuberculous optic neuropathy is common, and diagnosis, if it is recognized and instituted and proper treatment is instituted, the response is wonderful. Thank you. Thank you, sir.
Good afternoon, everyone. I have no financial interest in the subject matter of this presentation. So the topic for my presentation is effects of COVID-19 lockdown on signs and symptoms of ocular surface. So we know that COVID-19 pandemic, when it hit, it came back to us as a dry eye pandemic. It has been a silent pandemic that has been hitting us. Ophthalmologists have recognized it. It has left its footprint in ophthalmology as well. So what is it that literature says about this? So when we do the literature review in this, we see that COVID-19 and dry eye, they do have a connection. Also, the relationship between screen time and dry eye symptoms in pediatric population during COVID-19 pandemic have been documented very well. Even in the Indian Journal of Ophthalmology, mask-associated dry eye disease and dry eye due to prolonged screen time, are we heading towards a new dry eye epidemic? This was documented. So we know that, during the COVID pandemic, mask-associated dry eye, it came into the light in our OPDs. The cause was the air from breathing out of when it got channeled up, out onto the top of the face mask and over to the surface of the eye. So the movement of the eye, air over it, it caused an evaporative dry eye. So our research question was to determine the effects of COVID-19 lockdown on signs and symptoms of ocular surface. It was a prospective interventional study, included 3,046 eyes and 4 ophthalmologists. Inclusion criteria was no systemic conditions, regular sleep routine, not on any medication. Age groups from 10 to 60, divided into 6 groups by decades. Exclusion criteria included contact lens users, diagnosed dry eye patients, any ocular disease, or past refractive or cataract surgery, and patients who were lost to follow-up. Materials and methods, the study was approved by the ethics committee, and an informed consent was taken from all patients. So the dry eye evaluation included a Schirmer strip, a tear-fill breakup time, and the OSDI questionnaire. Time period was 12 months. In the OSDI questionnaire, we know that these are the scales. There is a discomfort subscale along with a vision subscale, and the patient is supposed to mark out what is their level of comfort. And the higher the score, the more severe is the dry eye. So what our results came out was that in Shermer's, baseline was 28 mm. At 6 months, it was 22 mm, and at 12 months, it was 19 mm. As far as the tear film breakup time was concerned, baseline was 8.7 seconds, 6 months was 7.6 seconds, and 12 months was 6.9 seconds. The OSDI at baseline was 10.2, at 6 months was 14.6, and at 12 months was 17.4, which was a progressive increase in the OSDI score. So compilation, the T-BUT reduced by more than 1 second in more than 65% of the patients. The Shermer's test reduced by 2 millimeters in more than 72.5% of the patients, and the OSDI increased by more than 1.5 in more than 85% of the patients, which gave us a positive correlation. To conclude, dry eye, ever since COVID-19 hit, has increased in prevalence, although we have to evolve just as that virus is evolving in the future. What we knew was that increased air circulation on the ocular surface causes evaporative dry eye, and excessive exposure to digital screens reduces blink rate, leading to dry eye. What our study adds is the study quantitatively shows that COVID-19 pandemic has had an effect on the ocular surface of our eyes, and corrective measures need to be taken to reduce this damage. The sample size of the study makes it the biggest study in our knowledge till now. The limitations were molecular level analysis is necessary to determine the exact level of severity of the situation at hand and truly label what we ophthalmologists already believe to be a silent pandemic. Thank you.
Dr. Rohan, did you take into the time how much these patients were using the mask for, time for the
yes,
in
so
12 hours?
Yes, so they were basically using it for 12 hours, sir. It was that's a limitation of our study. It was very difficult to determine what they're doing at home, but the standardized was that it was between 8 to 12 hours, the use of the mask for all the patients across the board.
Do you think the mask increases the humidity or decreases it?
I think it should increase the humidity, sir, because warm air which is released and it is getting contained in a closed space, so that will increase the humidity.
So it should improve the things. Anyway, it's a good study.
Thank you, sir.
Thank you so much. And while sir is helping us, find the Dr. MC Luthra Gold Medal awardee, I have I'll wait for Dr. Ashok and Dr. Satanshu also to come here. But in the meantime, I think I will go ahead and announce the awards for the rest of the sessions also, because there are a lot of sessions. I don't have a slide for that. You'll have to just bear with me because, give me that much because, I've had 2.5 tough days. Okay, I don't know in what order to start this, but for the photography result, um, the first prize goes to Dr. Shivani Patnaik for her photograph titled, sorry about that, reimagined a case of severe capsular phimosis as the Norwegian something. Sorry, it's not showing up completely. So that was the title of her, the image was titled The Arctic Circle. The Arctic Circle. And the second prize goes to Dr. Kumar Doctor for the image titled Dry Eye Complete Symptomatology. The third prize goes to Dr. Swati Singh. Dr. Swati Singh for her image titled The Star and the Abyss. So those are the prizes for the photography. The Dr. Satanshu Mathur Best Video Award goes to Dr. Rohan Mehra for his video titled Lenticle Extracting Hydrocannula for Smile. In the award session, the second best video, although they will not get the award, the second best videos were from Dr. Sangeet Mittal and Dr. Manisha Agarwal. And the third best video was Dr. Neeti Gupta. Hello? I'm announcing and you have to close. Can you come, please? Can you come, please? Okay, Dr. Ajay, Dr. Ashok. Dr. Ashok is there. Okay. I'm just, the MC Uttara gold medal is being finalized. I'm on the podium announcing the awards, yeah. Fine. Sorry about that. The third best poster, e-poster, goes to Dr. Rankinsai Marngar for his e-poster called In the Spotlight, a case report on visual loss following endoscopic endonasal surgery for ossifying fibroma. The second highest marks for e-posters went to Dr. Shreya Mishra for successful outcome of modified Nishida procedure combined with medial rectus recession in a case of long-standing post-traumatic complete abducens nerve palsy, a case report. And the best e-poster award, which is the Dr. A.K. Mehrotra award, goes to Dr. Shritu Shell for refractive and visual outcomes of SMILE versus Contura for correction of myopic astigmatism. So the best young achiever for this year was Dr. Abhijat Chaturvedi. That is the Dr. R.N. Singh Young Achiever Award. So I think we are just waiting for the tally and then I will just announce the gold medal winner.
Finally, we have results of free paper session. Third prize goes to Dr. Shweta Parekh. Second prize to Dr. Shritu Shell. And the first prize goes to Dr. Chintan Desai.
So congratulations. I can't tell you how closely fought it was. You know, the marks are like just 2 or 3 separating each of you. So it was a very, very, closely fought one, and congratulations to all of you for, such a nice presentation. And the Dr. MC Luthra gold medal goes to Dr. Chintan Desai. Congratulations. So with that, I think I'll just call Dr. Ashok Garg to, call the meeting to a close. Dr. Mathur has already left for Kashipur, so I'll just... Thank you, sir. Thank you, sir. Innovation का रह गया क्या? हाँ. Sorry, for the innovation session, I'm sorry that was missed out. Thanks for pointing that out. So there were 2 presentations which were decided as the best innovations. So Dr. Ajay Arora and Dr. Amrita Vidushi Bajaj got the innovator, young innovators. I think it's called young. No, not young innovators. President's best innovation award. They share the award this time. Thank you. डॉक्टर अशोक को बुला लेते हैं अगर आ रहे हैं तो.
कहाँ आ रहे हैं भैया ये कह रहे थे ना अगर फ़ोटोज़ के लिए बार बार फ़ोन कर रहे हैं अगर फ़ोटोज़ चाहिए तो अपने लैपटॉप में कॉपी करने का ना नहीं तो शाम को ही आपके पास पहुंचेगा लिंक तू पैक कर
फोटो लो फोटो कोई है नहीं बट कोई बात नहीं आप क्लोज कर दो थैंक्स कर दो इनको ऑडियो विजुअल वालों को फोटो वालों को ये लोग ने
इनको कल किया था
हाँ बट आज फिर कर देते अब यही बचे ना आपका कल थैंक यू
on behalf of UKSS Society and as a organizing chairman, secretary of Uttara Eyecon 2023, I want to thank all delegates, faculties who participated actively in this conference, and there was a lot of discussions on live surgeries and elaborative scientific sessions under the dynamic leadership of Dr. Saurabh Luthra, and live surgery from different parts of India under the able this mastermind of this live surgery session, Dr. Gaurav Luthra and Dr. Satanshu Mathur, organizing and looking after all this event. So, and beautifully flyers made by our young doctor Vijay Joshi, fashion show very well organized by Dr. Kanika and Dr. Sanjeev Mittal sir, the president UKSOS. He is very, very good and very supportive for this conference. He always guided and always we felt blessed whenever we talked and he guided us. So I want to thank all our trade partners also who wholeheartedly supported me, and it was not easy to organize such a conference because it takes a lot of expenses. So I want to thank trade partners, and I want to thank audio visuals, Mr. Grover, Anjani and his team. They wonderful job they have done, and not eating food, only eating odd times. And this photographer, Mr. Kakkad and his team, they have done wonderful photography with the use of artificial intelligence. They have saved our lot of time because we are getting latest technology-based photo. So, and my wholehearted thank to Mr. Deep Rajwar, the dynamic man who did this wonderful job for organizing and managing hotel parts, travel parts, and stay parts, everything, whatever you say, he will say, "Kya I'll do," and ever smiling and adjusting. So, and our trade partner, this who made beautiful stalls, Mr. Kamal, his son, Mr. Hidesh, doing wonderful job, and press, they covering the whole event. They made our live bites also. So overall, I think everybody did a good job. It was a commendable job as a team, and I think everybody enjoyed, everybody learned, and future, if we left any part, so we are sorry for that. So, and in the last, I want to thank this hotel also for wonderful hospitality and food part. So everybody enjoyed food, ambience, and hospitality of this hotel. And overall, my in the last, I want to thank my parents, my wife, my children, that who suffered a lot because I dedicated my time to this event. Thank you, everyone. Have a safe journey.